session, and I hope you will enjoy it. Let's start our first session of this conference, which will be with Dr. Badr Al-Mustafa. I think Dr. Badr Al-Mustafa is well known. He is a consultant family physician and hypertension specialist. He is the director of the training committee in SHAMS, or the Saudi Hypertension Management Society, and he will talk to us today about how to approach emergencies or how to recognize emergencies in primary care. Dr. Badr, the floor is yours.
السلام عليكم ورحمة الله. شكرا دكتور عمار. السلام والرحمة للجميع. أنا أرجو أن الصوت واضح دكتور عمار.
Yes.
وكذلك الشرائح مرئية.
Yes, دكتور.
شكرا جزيلا. بسم الله الرحمن الرحيم. Our talk for today will be about how to recognize in a more comfortable way the emergencies in primary healthcare settings. And as we all know that primary healthcare is a setting that the resources may be at its lowest among other health institutions, whether the human resources or the other resources, whether they are in machineries, diagnostics, or even consultancy. All these put the primary healthcare providers in a positions that ever since in his training, whether it is in the undergraduate or the postgraduate training. And this is very unfortunate, really, that the whole primary healthcare setting is not well modeled in the undergraduate, neither in the postgraduate, neither the undergraduate. However, we'll try in this 20 minutes to go through how to comfortably recognize the presentations that may be hiding some emergencies. First of all, I would tell that the WHO, the World Health Organization, has shown that I wonder if this slide is still there or not. I wonder if the slides are still there or not.
Can you
because I lost communication.
Can you share screen, Doctor?
To share them again?
Yes.
Is that fine?
Yes.
Okay. That among the top 10 causes of death and disability worldwide is unsafe care. And in that care, primary health care and outpatient visits constitutes almost that 4 out of 10 outpatients or primary health care patients are having some harm, getting some harm because of the care. And most of these care is really preventable. This 40% really constitutes a very large number. Please don't be, I would say, down in listening or seeing this number. It may be almost the same or less or more. It is in the emergency rooms and as well in the hospital outpatients. So we have all to share really our efforts really to pick up these 4 cases and dealing with them more comfortably and more safe. These errors mainly have been hidden in the diagnosis and as well in the prescription. And the diagnosis, it is mainly in the provisional diagnosis. And this, we know all that it is based on, enlarged on a good assessment. And part of it is on the use of treatment. Let's go ahead to a few cases to shed some lights on, and then end up this session with a model that I'm proposing really for how to approach safely the hidden emergencies in primary healthcare. I wonder if would you share with me your ideas about this case in a minute. Ahmed, at the end of a usual regular day, has presented with his father. He is just 4 years old. The boy was walking. He is not known to have any chronic or recurrent problem. The presentation was just really confined to little of vomiting 2 to 3 times with mild abdominal colic lasting for lasting about 2 days on and off. There was no perceived fever, and in a quick physical exam, because everybody was going off, vital signs unfortunately was not taken. ENT showed just mild hyperemic throat examination, and the abdomen was lax without any localized tenderness. I wonder if you can share with me some of your ideas about this case. How likely this case be an emergency? Is it high or low? Or you need still more information about it? But from these very little few information, is there a likely that this case be an emergency? I wonder if you may share your ideas. Unfortunately, the polls was not enabled, so you can share your ideas in the chat. I'm still back to the case. That the case is 4 years old. Boy presented walking with his father with a history of 2 to 3 vomitings during the last 48 hours, and on physical exam of ENT, mild hyperemic throat with lax abdomen and no localized tenderness. Might this presentation hide an emergency? How likely is that? I'm eager really to read from you in the chat. Okay. For saving the time, I wonder if you can share your ideas. Okay. High, maybe, low. Okay. Thanks a lot. What further information that you may like to have? Because many of you have mentioned 5. Okay. But you need vitals, yes, that's fine. You need more thorough physical exam, more symptoms, more review of symptoms, random blood sugar, great. Okay, great. Let's go to another case and see how far we will deal with it. Abdullah, he's 84 years old. He's a non-hypertensive. He has presented together, walking, ambulating, together with his daughter. She was a doctor. For the last 10 days, his daughter has noticed that he's having slow speech. And for that reason, she got him to the emergency room. And over there, CBC chemistry, thyroid function, ECG were done and showed no abnormality. The thyroid came the next few days, and as well, it was fine. On physical exam, the blood pressure was stage 1 to 2, with slightly raised pulse. It was regular at that time. However, he was noticed that he's slow moving, slow walking, together with talking slowly in relative to what we used to get from him. Thankfully, he was not tachypneic, and examination, including the ENT exam, chest exam, precordium, the carotid pulses were unremarkable. Still, for this patient, how likely that such a patient may be maybe an emergency, and how far we do need further information really to tell that emergency is possible in this case. I'm eager as well to read from you, please. Okay, very high, still need some information. Okay, what information you like to have it? Okay, more cardiovascular examination. Okay, what other? Neuro exam, that's great. A neurological exam as well. Great. Okay, so do you like to have more about his vitals? Okay, that's great. So you need some more examination, full exam or a neuro exam, and as well, more likely that this may hide an emergency. Let's have the last case and then we will comment on all. Khadija is a 70 years old housewife, presented walking with her two daughters, apparently very well, ambulating, talking freely, not in pain at all. She's not known at that time to have any chronic or recurrent problem. And she presented with a history of just mild trauma. The door was just hatched on her finger, and she got an abscess. Okay, this is just a representative figure. It is not her own. 10 days ago, she was seen in a clinic and as well in the ER 2 or 3 times. She presented during the last 10 days to different clinics and emergency rooms. The abscess was noted over there, incision and drainage was done, and was prescribed some antibiotic during the last few days. She presented with the antibiotic and was asking for dressing for her abscess. In physical exam, the vital signs not noted, unfortunately. The wound was having some little pus, slightly tender. The fascia seems to be slightly gangrenous, I would say blackish in color, a little deep fascia. How far this case, the third case, may be an emergency? And what information extra you would like to know from this about that case? Okay, still in the chat. Okay, great. So how likely and whether any information you would like to know about the patient? So it is less likely, very high. Okay, we are here more variable. Okay, so very variable. Still we are evaluating low emergencies. Some may be high. Some more information. Any further information you would like to know about the patient? Blood sugar, RBS, very high. Yeah, not known. So most of you would like to know her blood sugar. That's very great. Okay, let's go to the cases now and see. Before that, let me present to you the primary care model in clinical thinking. How we do in primary care, we may think to detect emergencies. As we just presented here, that safety will be major. And for safety, we have in primary care to be as safe as maximum to minimize this 40% of harm that we may share in. And of these, we tell that there are 4 issues I have to put in mind. The first one is the reason for attendance, why my patient is presenting to this clinic. I need to know that. Okay, is he coming on regular follow-up and the follow-up is presenting or no? I know him that he's a chronic case and he's present today for something else. And if he's coming for the chronic follow-up, okay, is he having any new symptom or not? So we have to put all that in mind. So the number one, I need to know and make sure the reason for the attendance of the patient. And if he is coming for chronic regular follow-up, I need to make sure that there is no new symptom. And if any, I need first the timing of that symptom, whether it is the reason for attendance or it is the new over the chronic. I need the timing of that symptom, when it has happened. Is it recurring? Is it stable, the same? Is it raising up or all over the time? So it is the timing of the start and how far this symptom is changing on the time, from the time of the start till now. Okay, so number one is the reason for attendance. Number two is the timing, when it has started, the symptom, and how far that symptom is changing since it started on the time scale. Number three, I need to take the vital signs, and we have to have the extended vital signs, which I'm going to go through in a minute. And then fourthly, we need to follow guidelines. So to follow what on that guidelines, okay? We need to follow the symptom or the major symptom or sign I'm seeing in my patient. If my patient is coming with trauma, I need to follow guidelines of trauma. If I'm getting in my examination that he is having an irregular pulse, for example, I need to follow guideline of irregular pulse. So I may end up following 2 or 3 guidelines for one patient. Oh yes, because we are dealing with symptoms and signs. We are not dealing here with a presumed syndrome or a presumed diagnosis. We have to be very careful. We need not to follow on the first start before assuring a diagnosis. We need to not to follow diagnosis guidelines. We need to follow symptom or sign guidelines that will be much more safe. We may follow chest pain guideline, but we are not going to go for example, chronic ischemia guidelines. We are having to follow high blood pressure guideline, not chronic hypertension guidelines. So this has to be put in mind. The good, wise choose of guideline. So what are these extended vital signs I'm pointing to? The first vital signs, we are having about 13 vital signs that we have to put in mind that may help me in a safe approach to my patients and to recognize emergencies very early. The first one is the general look, how he looks like, his gait, sick looking, his color. And for our patient just a few minutes ago, Abdullah, his gait was affected. The temperature, we need to make sure that the temperature is within the range or not that an urgency range. It is not that low below 36 and it is not that high above 39, because by itself it may be an urgency, or it may as well indicate that there is a septic workup or a serious infection is going on. The pulse, unfortunately, we are relying on a pulse of sphygmomanometers or an oximeter, but this is not a good idea really to rely on. This will be good indicators to have to screen the patients, but for an evaluation of the patients, we need at least a few seconds of taking hand on hand to appreciate whether the pulse is irregular or not. The blood pressure, and to make sure that it is not an urgency levels. It is not 180, for example, plus, and it is not that low. And the respiratory rate, it may not be enough really to tell that my patient is not tachypneic, okay? Because many of the patients, especially that young patients, very young patients, fragile patients, those who are just 6 months of age, or old patients or obese patients, okay, to recognize that they are tachypneic easily. So we need really to have the respiratory rate counted, especially on those presented with general symptoms presentation or with symptoms related to the upper abdomen or chest. The weight change, and the weight change will be more crucial in children, but however, the weight change in adult is as a serious indications that we have to put an eye on, whether an increase or decrease, a 5 to 10 kg loss or added during the last few weeks will be an alarming signs that we have to put an eye on. And the pain, and we have to make sure that the pain is tolerable or not. But however, any unexplained pain is a vital sign that we have to look for a cause. Unexplained pain, we have to look for a cause for that pain. The dysfunction, the patient may come with gustatory dysfunction, with eye or visual auditory dysfunctions, with sensation dysfunctions, with eye field or visual field dysfunctions. The language, his language is changing, or his behavior is changing all over. All these may hint for serious problems that's going on. It might be cold, but however, until I reach an explanation, I cannot really make sure that my case is not an emergency, neither serious.
Dr. Badr,
Oh yes,
5
Dr. Ammar.
5 minutes
Sure.
left.
Yes, please. Thanks. The number 9 is the RBS. When I'm going to take an RBS, is it mandatory? No, no. But for the cases that the clear diagnosis and explanation for the presentation of the patient or for the symptom or sign I'm seeing is not that clear enough. Okay, so I need to have an RBS. Or if there are multiple of, or one of the vital signs are in the emergency levels, then I have to have an RBS taken. The same applies for oximetry, and in children, and elderly, okay, we need not to miss the feeding, okay, and to make sure that because in elderly, we may, as families, okay, will say, oh, he is having loss of appetite, and we will pass it as very, very normal for his age. But no, we have to put that in mind. This is a serious issue that may hint us or direct us to an urgency. The growth chart in children is one, and lastly is the risk factor. The extreme of age is a risk, patient being a smoker or alcoholics, having a chronic disease or family history of premature serious disease or death is as well a sign that may direct me to look for any serious or emergency. How to put all this how to put all that in the view? I look for the timing. If the patient is having a recent symptom or recently increasing or changing symptom, then we are labeling this as an acute or subacute. The patient is having a recurring symptom, though it is not changing. Okay, still it is a chronic or recurring. It is a chronic issue. And if it is chronic or recurring, a possible serious diagnosis might be hiding in that case. We need not to miss that one. And if it is so, we need to act as soon as possible. And how to act, it is not the place for it. But if the patient is having a symptom which is acute in its presentation or changing, then a possible emergency is high, and especially if that one is affecting the vital signs that we have just mentioned in the last slide, and on that we have to act now. Back to our case, Ahmed, if we apply all that, the general look is fine. The temperature was not taken, unfortunately, but he might be having a high fever. And for that patient, yes, later, just an hour after that, the patient was called, temperature was taken, and RBS was taken, and the patient was, and urine domestic as well. and for that, a DKA diagnosis was assured for that. Yes, DKA in primary healthcare may present in non-acute, non-emergency looking, just might be as very subtle presentations. And we have to put in mind the next day, at the same night, the patient was admitted in the ICU. Abdullah, okay, if we apply that, the general look is a hint, and the patient having at risk is as well is a hint, though the other issues are not that affected and they are okay, then we have not to rely happy on the change of look and his risk to develop cardiovascular diseases. For example, a CT was done in order for that. His neuro exam was fine though, and it has the CT has shown huge subarachnoid hemorrhage. Yes, subarachnoid hemorrhage may ooze slowly and may last for a couple of days, and the presentations might be very odding without a real headache. And let's be really in the picture that elderlies, they are not presenting their symptoms clearly to their neighborhoods. Khadija, this is very straightforward, and we know all of us that once we go through all through all these or a few of them, we get that this patient RBS was just 600 plus and blood pressure was 200 without no symptoms at all. Okay, this is very common in the primary health care. We have to put an eye on that. We have to pick them very early, and importantly, we have to deal with them maybe differently than the acutely presented very high RBS and very high blood pressure. In conclusion, and before that, we get to recognize all that, then it comes how to approach them. Maybe it will be good for another session. But the least lesson that we do rise up here, that recognizing emergencies in primary care, unfortunately, may be modest and masked and large. We as primary healthcare providers must follow a structured, safe approach in picking up and recognizing them and suspecting them, فضلاً عن and approaching them safely. And it is a must in newly presenting or increasing symptoms. شكراً جزيلاً دكتور عمار.
Thank you, Dr. Badr. Since Dr. Badr is joining us online, we will take the questions of this session after each lecture. So we will take one question from the attendees here and one question from the online. So please write your question in the chat and we will take it. نبدأ بالحاضرين إذا ممكن، إذا في أحد عنده أي سؤال. If anybody has any question. Any questions from the audience? Okay, let me ask you, Dr. Badr. Are these parameters enough to recognize emergencies, or what percentage of emergencies can be detected by these parameters that you mentioned? Are there any studies to demonstrate that?
No, there are multiple studies that have just studied one or two or three parameters, unfortunately. But this model is presented by the speaker from his practice, and as well allocating most of the studies that have talked about the how far the regular emergencies, which are regular vital signs, may pick up as a model, and how far random blood sugar may be a must for every presenting new symptoms, and how far oximetry. So these are only individual queries and questions have been studied. These, unfortunately, will not fulfill the criteria of the deficiencies of time and resources in primary health cares. And this is not the usual that we are seeing the patients, and the usual that we are seeing the patients are a bit differently. So we have to put that in mind. And this is open for everybody really to study it. Shukran, Dr. Ammar.
Any question from the online? Okay, another question, Dr. Badr. Are there any way, or are there signs or symptoms that we teach our patient to help them in recognizing emergency? For example, if you have somebody who has chronic diseases or even healthy, are there?
This is well written in the literature about how to at home recognizing emergencies, but this will not fit really in the health institution or medical institutions. All of that, we know that there are emergencies by heart. For example, having trauma, bleeding, loss of consciousness, change of consciousness, very high fever, the chest pains, the pains, whatever the severe pains all over there. So these were presented and well documented in the literature, but they will not be enough at all, really, because most of the emergencies that we are seeing in primary health care, I would tell, are lacking all that. And among that, what I have just presented, 3 cases presented now, they are not among those criteria documented in the literature.
Okay, here is a question from the audience. Should vital signs be taken for every patient coming to the primary care?
It's a must. It is a must. It is a must.
Even if the patient come for dental clinic or for dressing only, in every visit.
It is a must. It is a must. I would tell how far dental presentation, acute dental presentation, or recurring dental presentations may indicate a systemic disease. Just Google that, and you will see in the literatures many of the articles written about that.
Okay, another question from the audience. Do you advocate or do you recommend applying triage principles in primary care like the Canadian triage system?
It's not enough for that, because those who are coming in the primary health care are presented not only for emergencies to be rolled in or rolled out. So we have to put all this in mind. And we have as well another query raising whether my patient is having a serious problem or not. Because in the triage of the emergency rooms, we are just ruling in emergencies and we are ruling out non-emergencies. But in primary health care, we need to rule in emergencies, we need to rule in serious problems, and we need to rule out nothing.
Okay. Any more questions regarding this topic? Here is a question. What percentage of emergencies presented to primary care are related to medications or wrong prescription?
In Saudi Arabia, I'm not aware about. Just I've been through one of the postdoctoral theses, and that it was studying in primary health care. It was studying the errors in prescribing done by one of the pharmacologists. It was studying the errors of prescribing antihypertensive medications, and the error were huge in prescribing double medications of the same category, or the wrong dose, or maximum more than the maximum dose, or under minimum dose, and or prescribes with unusual frequencies. All that were hampering up to about 34% in that study. And this is very huge. And I'm talking just about antihypertensive medications. This is just will shed a light and give you an example how far the medications prescribing error. But are these harmful or not? This is another issue.
Okay, thank you, Dr. Badr, for your nice presentation. And we would like to see you in the future face to face.
أسألك دكتور عمار، شكرا جزيلا، مع السلامة.
Okay, now let's go to our next speaker, who is Dr. Shukri Saif. Dr. Shukri Saif is a well-known cardiologist from Bab and Cardiac Center, and he is the chairperson of developing guidelines in E1 cluster. He will talk to us today about early management of acute coronary syndrome. Dr. Shukri.
السلام عليكم ورحمة الله. صباح الخير جميعا. I'd like to start by thanking the organizers for their invitation. I'm going to talk about how to recognize and manage ST elevation myocardial infarction and non-ST elevation acute coronary syndromes, and what are the key points in the management of acute coronary syndromes and the available pathway in the Eastern Health Cluster. Chest pain is a very common symptom and accounts for about 10% of non-injury related visits to emergency rooms. And many of these patients do not have any serious conditions. In fact, 83% of those that present to emergency rooms with chest pains are actually discharged with non-cardiac diagnosis. Unfortunately, 2% of those are diagnosed erroneously. In other words, 2% of these 83% will have a cardiac problem, but are discharged by mistake. In the situation in emergency rooms, triage is a must, and the same can be applied to any urgent care setting. Triage really will prioritize who are the people who require immediate attention in comparison to a patient who has non-urgent problem that can wait up to 4 hours, whereas someone presenting with chest pain is expected to be managed within 10 minutes. And therefore, triage is an extremely important concept in any urgent care setting or emergency room. Once the triage person, and that can be a nurse, a physician, whoever it may be, recognize that this person has chest pain or equivalent symptoms, that person requires immediate management. And that management consists of 2 elements or 3 elements: vital signs being taken by a nurse, as well as an ECG. The nurse does not need to have an order of a physician to be able to do that ECG. That should be part of the protocol in any emergency room or urgent care setting. The nurse herself, once the patient is complaining of chest pain or dyspnea equivalent to chest pain, that requires immediate vital signs. And the vital signs here are 5 simple vital signs: temperature, pulse oximetry, blood pressure, and respiratory rate. So I don't need the 13 extended vital signs that Dr. Badr talked about. The ECG, and then an immediate assessment of the patient as well as the ECG by the ER physician or by a general practitioner if you're in an urgent care setting. This is actually the chest pain assessment pathway that is applicable in all the urgent care setting and emergency room. And you basically need to compute in your brain 2 issues. Is this chest pain suggestive of acute myocardial ischemia? And is the ECG showing the signs of ST elevation? If the answer is yes, then you need to think of ST elevation, acute myocardial infarction. In ST elevation, acute myocardial infarction, there is an occlusion of an epicardial coronary vessel, and we need to restore the blood supply in that occluded vessel as soon as possible, because each minute that passes by will damage a certain amount of myocardium, which cannot be repaired afterwards. So the sooner we diagnose and manage the individual, we reduce not only mortality, but reduce the long-term consequences of acute myocardial infarction, that is heart failure. We reduce all the complications of acute myocardial infarction. And the pathway, it includes documentation, and it actually guides you with the steps that you need to do. I will start with an example. This was a 39-year-old smoker who had chest pain that started at 5:30 in the morning. He went to a clinic first, we're not sure where, but he left there at 6 o'clock, then went to a local hospital and arrived at 7:03. Documentation of timing is extremely important. This patient, it took him more than 2 hours to reach the cath lab. Now, the protocol in this emergency room was that this emergency room will manage all the patients with primary coronary intervention. That's mechanical revascularization of the occluded artery. And the agreement is that the patient should arrive in the cath lab from that emergency room within 80 minutes from his presentation to that emergency room. So if he arrived in that emergency room at 7:03, that person would have been expected to be in the cath lab no later than 8:23 in order to allow another 40 minutes for the procedure to be undertaken, so that the first medical contact or arrival to the emergency room till his blood supply is restored is less than 2 hours. That's the benchmark for the quality performance for this type of situation. You have 2 hours from presentation in the emergency room until that blood supply is restored. So we need to think critically, and every second makes a difference. Here, you can see that, I don't know, where is this pointer? Okay, you can see that there is ST elevation in the precordial leads here, lead 1, V2, V3, V4, and there are some reciprocal changes. And this is typical for an acute anterior myocardial infarction. The management that has to be provided in any emergency room setting or urgent care setting is exactly the same. You need to give the first line medication once you've excluded any contraindications, and once you've confirmed that this is the most probable diagnosis, or this is the diagnosis. Aspirin, 324 milligrams, analgesia in the form of morphine if it's required. You need to give an antiplatelet, either ticagrelor 180 milligram, or if you don't have ticagrelor, then clopidogrel 600 milligrams. We need to give high dose statin in that situation, 80 milligrams. And we need to give intravenous and fractionated heparin, not any form of low molecular weight heparin. And this is all described in the pathway. It's even the dose is written, so that in the pathway we've written the dose and the steps that have to be done, so that it really makes life easy for any physician or nurse to follow. As it happened in this patient, the reason for the delay is that the patient developed a cardiac arrest. You can see that he started having non-sustained ventricular tachycardia that led to VF cardiac arrest and required CPR and required 3 DC shocks. And this often delays the transfer to the emergency room. And this emphasizes the second most important aspect of emergency management: preparedness to manage acute cardiac arrest. Cardiac arrest always acute. So you need to have ACLS trained staff, nurses, physicians, every single person in any emergency room or urgent care setting must be trained and certified currently in ACLS practice. It's absolutely no good to have had certification 100 years ago and the certification has lapsed. It has to be current. That's the only way to maintain competence to be able to manage such emergencies. Of course, we always ask ourselves when a patient presents with chest pain, is this the diagnosis or could there be an alternative diagnosis? So we need to go through an exercise to exclude other potential diagnoses, such as pulmonary embolism, dissections, etc. The idea for those emergency rooms or urgent care settings that have in the protocol in the cluster to manage the patients with primary percutaneous coronary intervention is that these patients will be directly referred to the cath lab via the HITERA phone, having once they've been given the aspirin, ticagrelor, clopidogrel, rosuvastatin or atorvastatin, heparin, and they need to be attended by ACLS trained team, and they need to be escorted to the cath lab. This patient, when he arrived to the cath lab, he was fully conscious, fully oriented, his vitals were stable. The idea when the patient reaches the cath lab is that they should undergo coronary angiography immediately. And there are several benchmarks here expected. If that person came directly to DMC emergency room, his presentation time until the vessel is until the blood supply is restored to the occluded artery is expected to be less than 60 minutes. If that person went to an urgent care setting or within the Dammam area, that his arrival to that urgent care setting until that blood supply is restored is expected to be less than 90 minutes. And if that patient went to a hospital or an urgent care setting outside Dammam where they have an agreement for primary coronary intervention, the benchmark is 120 minutes. Now, 120 minutes doesn't mean that it takes me 120 minutes to get him to the cath lab. I need to allow 40 minutes from that time for the procedure to be done. So if he was in DMC, then from arrival in the emergency room until that person is expected in the cath lab should be within 20 minutes. If he was within the Dammam area, that would be 50 minutes. And if it's outside Dammam area, that timing is 80 minutes. So that's the time expected from presentation in that medical facility until that person reaches the cath lab. In the cath lab, in this patient, the LAD was totally occluded. He had a stent. The wiring time was 9:52. So that's the time the blood supply was restored. So if we want to calculate the actual critical timing for this patient, then we subtract the time of reperfusion, that's 9:52, from his first medical contact in the private clinic, which was 6 o'clock, for the hospital that saw him first, that's 9:52 minus 7:03. And for the cath lab itself, it's 9:52 minus 9:15. So these are the times that are when we try to look at the quality of the care we are provided. This is the outcome. This patient did well. He was discharged home on the 27th without any problems. I'm going to skip this patient just for the sake of time, but I'm just going to, if that patient presented to a hospital or an urgent care setting that is too far to transfer the patients for primary PCI, then that person would have been eligible for thrombolytic therapy, which is available in two forms, either alteplase by an accelerated pathway or retiplase as two separate dosages. Everything else is similar in the management, except that these patients, you need to go through a checklist for any contraindication to thrombolytic therapy to make sure that you do not give something that could worsen some other pathologies. Again, for the rest of the management is almost the same. And these patients, they also need to be monitored by ACLS trained nurses. And the difference is that after 90 minutes from administering the thrombolytic therapy, you need to assess whether the patient clinically has responded or not. So whether the chest pain has resolved, whether the patient has any rhythm problems, whether the patient is compensated and has no heart failure, and whether the ST segment elevation that was in the ECG at presentation has at least resolved by 50%. If the answer is yes, that person requires angiography within the next 24 hours. If the answer is no, then that person requires immediate angiography because the likelihood of the vessel to have been opened is very low. And that person requires immediate transfer to the cath lab for further management. This patient did go to the cath lab and he did well as well afterwards. Just one more point about after the cath lab, after revascularization, all the patients will have medical management in a standard way. And these includes management of lipids, management of blood sugar, monitoring up to 24 hours in the CCU, and then secondary prevention, which consists of dual antiplatelet therapy for at least 12 months, ACE inhibition or angiotensin receptor blocker, beta blocker, statins. If the patient is smoker, then he needs to be referred to smoking clinic. And all patients, we hope that will be referred to rehab to modify their future risk. Now, if we go back to the emergency room, if that patient ECG did not really suggest ST elevation MI, then that person we will label that person as not a STEMI. So when a patient does not have a STEMI, could that person have non-ST elevation myocardial infarction? Could he have unstable angina? Or could he have non-cardiac chest pain? Any of these three possibilities still exist. So in order to try to separate the cardiac from non-cardiac, we need to do something called heart risk score. The heart risk score is an app that you can download to your Android or iPhone device. And it incorporates several things: the age, the history, the electrocardiogram, risk factors, and troponin levels. And you can classify patients into three categories: low risk, intermediate risk, or high risk, depending on the score. So just show you here in this you can see 6 weeks risk of major adverse cardiac event. If the risk is less than 3, is around 1%. If the risk is, if the score is 7, then the risk is around 50%. And if it's between 4 and 6, the risk is around 15%. So clearly, this is a very low risk group, and they are unlikely to have any significant problem. These two categories here have, or at least the ones which have a high risk score is an extremely high risk group. We'll look at an example: 74-year-old man. The age by itself is a major risk factor and carries a high burden in the risk score. So this man is already known to be diabetic, hypertensive. He's known to have coronary disease. He's had a previous intervention. He's gone to the emergency room of a local hospital with chest pain. His troponin was positive, and he had a definite diagnosis of non-ST elevation MI. So once you have a non-ST elevation MI, how can we risk stratify this person? We need to risk stratify that by a score called the GRACE risk score, which is a dedicated risk score for classifying non-ST elevation acute myocardial infarction. This includes age, heart rate, blood pressure, whether the person has had manifestation of heart failure or not, his creatinine, ST deviation, and biomarkers. So we can classify persons as being low risk or intermediate or high risk depending on their GRACE risk score. A score below 108 has an in-hospital mortality for the first month of less than 1%, whereas intermediate, that's 109 to 140, the mortality is between 1 to 3%, and if it's high, the risk of in-hospital death is greater than 3%. So clearly, we need to prioritize the high, then the intermediate, and then eventually the low. Again, we have a non-STEMI pathway which describes to you the steps that you have to do, and it starts by actually what is the GRACE risk score here. Right at the top, You need to calculate the risk score, and depending on the risk score, you manage the patient. The initial management is very simple, but it is distinctly different from the STEMI management. Here, you need to exclude some other potential secondary causes of myocardial ischemia. You need to think about, is the patient anemic? Does he have any? Many of these patients are elderly and they have comorbid conditions. They could have contraindication to anticoagulation. If none, then that person will start either unfractionated heparin or low molecular weight heparin. We'll start the patient on aspirin. We need to check the lipids and start statin therapy. We need to assess renal function. We need to look for signs of heart failure. We need to assess the echo. If there are no contraindication to beta blockers, we will start the patient on beta blocker. And if the blood pressure is high, we will put the patient on medication. And if required, we'll add nitrate. And then depending on the risk score, we will consider that person for coronary angiography. The timing of coronary angiography depends on the risk score. So if the patient presents in shock or heart failure or have persistent rest angina in spite of medical management, or he's hemodynamically unstable, that person is expected to undergo immediate angiography. If the patient has a risk score of greater than 140, then the timing of angiography is within the first 24 hours. If it's intermediate, that's 109, but below 140 within 72 hours. And if it's slow, then that person is by definition elective and can be scheduled at any time. In this setting, this patient had triple vessel disease and could have been managed by surgery or PCI. Subsequently, he requires, again, standard management, dual antiplatelet therapy, management for with ACE inhibition, ARB, beta blocker, statin, again, referral to smoking clinic if that person was smoker, and to rehab. Just a final note on the KPIs that we collect, and we collect these KPIs. These are required KPIs required by the Center for National Health Insurance, and this includes the benchmark for or the time it takes from presentation to doing the first ECG. The expected benchmark is 10 minutes, and this is all the hospitals in the cluster and all the urgent care are expected to comply with this. Other things for those that are participating in the primary PCI, we are monitoring their door to balloon time for Abgay, Ras Tanura, Qatif, Inak, Safwa. These are 120 minutes. The MAM network urgent care, the door to balloon is 90 minutes. And then for Jish and Qatif network, urgent care centers and hospital, 120 minutes. DMC itself is 60 minutes. Again, whether people are doing the GRACE risk assessment, whether how many of the other aspects of this pathway involves screening individuals who are at risk for developing acute coronary syndrome and referring these to the health coach. And this is the website for entry of the this data is REDCap, and there are coordinators, designated coordinators, and they have access with the username and password. If anyone would like any further information regarding this ACS pathway or has any issues, they can either contact me or contact a project manager, Johar Balghanem, who is assigned to this pathway. Thank you very much for your attention. I'll be happy to address any questions anyone wants to ask. Yeah, I'll be happy to.
Thank you, Dr. Shukri, for your nice presentation. I have a couple of questions here from the online. The first question is, What about failed thrombolytic in peripheral hospital and cardiac center need more than 3 hours of transfer? If they give the patient a thrombolytic therapy and it was failed, and they will take more than 3 hours till they reach to your hospital, what can we do?
That's the only practical management available. So once a patient fails thrombolytic therapy, the only thing you could do is transfer that patient for rescue PCI, and that's it. It doesn't matter. In some hospitals, the interval or the transfer time is long, but unfortunately, we don't have more efficient rapid transport. We don't have air transport that could bring these patients by helicopters. When that happens one day, we will have much more efficient evacuation. But today, the only available is the ambulance, and once you diagnose a patient as failed lytic therapy, that person needs to be transferred to the nearest cath lab for rescue PCI.
Okay. Another question. Can you give us more details about the heart score? Because it may differ from, the assessment may differ from one doctor to another. I think they mean in the history mainly, whether this is a typical chest pain or not typical.
The history is very simple. Either it's suggestive or not suggestive or maybe. So you have to make a clinical judgment sometimes. Either someone comes to you with a history that is classical, then you give him a score of 2. If the history is not suggestive, then the score is 0. If the score maybe, it's 1. So it's very simple. I mean, you, as a physician, you have to make a judgment. You have to make a decision. Is this a classic history, or is this no, it doesn't really suggest, it's not characteristic. So, or if you're not sure, then you give a score of 1.
Okay, any question from the audience here in the hall? I have a question, doctor. In our primary care centers, we don't have a troponin. So if a patient comes to me with a typical chest pain, but his heart score is less than 3, for example, he has no other illnesses and he is non-smoker, how do you recommend to give him the cocktail, the aspirin, and the other medications that should be done in case of non-STEMI or unstable angina, or we should withhold this medication till we reach to the hospital? We have only ECG, and the ECG was unremarkable or not suggestive of ischemia.
No, that management should only be started once you've diagnosed. So if you do not have troponin, then you should close your place, because an urgent care center should have troponin the same way they should have an ECG machine. Either you do the service properly or you close it. It's worth a waste of time. So if you don't have it, then you cannot operate an emergency service. You cannot operate an urgent care service, full stop. So you need to insist, all the physicians, they need to insist on their management that they must provide these basic investigations. And when they are provided, they should be respected and not abused. One of the problems today is that these investigations are available even in emergency rooms, but they are available for a few days a month. But because physicians also abuse them, they do them routinely for all patients, which is not required. The quantity that you should have for a month expires in 10 days. And that means that you do not make efficient use of these resources. So physicians must utilize these resources appropriately, and they don't need to be repeated. Or I only need one. If the person has the onset of symptoms until presentation is very short, I don't need to order a troponin. A troponin here, a majority of the type of the troponin is not really the very high sensitivity troponin, and therefore you should not request this troponin unless around 3 hours have passed from onset of symptoms, because otherwise, if you do it very early, it will be negative. You don't really know whether this is just because you've done it very early or it's truly negative. So I would wait until 3 hours have passed. And if it's negative, I don't need to repeat it. That's it. It's negative.
Thank you very much, Dr. Shukri, for your presentation. And we welcome you. We would like to see you in the near future, inshallah.
Thank you.
Assalamu alaikum. Can I share one of my and one day I received a case with chest pain who was high risk elderly patient, well known to my one of my patient to my clinic. She presented with chest pain for 3 days, severe burning in nature, radiating to the back, central chest pain. She's hypertensive, high-risk patient, multiple strokes, not well controlled, out of her medication actually for her blood pressure. And her vitals were stable apart from high blood pressure, stage 2. Upon examining the patient, there was a rash. When I exposed her chest for auscultation, there was a rash. It was a herpes zoster rash. This just solved the puzzle of her chest pain. It's most likely due to herpes zoster and not to ischemic pain. However, to be safe, I did observe the patient in the observation room. We did for her ECG, it was normal. We did for her cardiac troponin as well, and it was normal. However, when I did the heart score, it was in the moderate because the patient have high risk. And in my judgment, the history, I score her as a +1. So we were hesitant whether to call for the patient, whether to send her for admission and observation since she is high risk. Although she was a little bit improved on paracetamol IV and oxygen, just low flow. So
Shall I comment, because otherwise it's a long story.
Yes.
I mean, in this situation, doing the heart score is totally inappropriate. You have a diagnosis. You have a herpes zoster is the cause of the chest pain. And therefore, this patient does not even justify doing an ECG or doing a troponin. That's a wasted 2 investigations. And I would certainly not bother to calculate the heart risk score, because here the patient has a clear diagnosis. So common things are common, and we need to use common sense. Here, the patient has pain related to herpes zoster, and she needs to be managed for that neuralgia. But I would not really bother about doing a heart score or troponin or an ECG unless you're concerned about something else. The hypertension is not controlled because the patient is not taking their medication. You need to improve their compliance.
Yeah, okay. Thank you very much.
Okay, thank you.
Assalamu alaikum wa rahmatullahi wa barakatuh. I'll be the third speaker of today morning session about urgent cases in primary care. My talk will be about bronchial asthma flare-up or exacerbation. The objectives of my presentation are to differentiate the severity of flare-up and patient at risk of asthma-related death, to discuss how to manage flare-up, and to propose a stepwise approach to manage asthma flare-up or exacerbation. Let's start with the case. Mr. Muhammad is a 46-year-old man. He is living alone, smoker, known case of bronchial asthma, presented with a complaint of worsening cough, dyspnea, and chest tightness for 1 day, also complaining of low back pain after carrying heavy objects 2 days prior to presentation, which was not relieved by paracetamol and topical diclofenac. I would like to ask, is there anything more in history you would like to know about this patient? Whether in, or let's, If you want to participate, write in the chat, and if anybody from the audience attend or of the attendees want to participate, anything more in the history would like to know. NSAID consumption, ECG reading, smoker, medications, fever, RBS, non-asthmatic. What is his job? Okay, nice. Now let's proceed to the examination. His initial vital signs were blood pressure 126/82, pulse rate was 96, respiratory rate 28 per minute, temperature 36.5, and oxygen saturation 93% on room air. His weight is 89 and his height is 183. His chest showed, or auscultation of the chest showed pan-expiratory bronchi. Anything more in the examination? Distress, X-ray, peak expiratory flow, ECG. Okay. Now let's ask these questions. What is the severity of this attack? Let's assume the patient did not take non-steroidal. He is working in a factory where he exposed to some chemicals. Peak expiratory flow rate is, let's say, 65 or 70% of his personal best. And that's it about the history and exam. There is nothing else remarkable. So let's ask the first question. Is this patient at risk for, what is the severity of this flare-up before we go to the next question? So what do you think? Is it mild to moderate, or is it severe, or is it life-threatening? Moderate, severe, severe. Majority are saying severe or moderate. So most likely this patient will fall between the moderate and severe. Now let's ask, is this patient at risk of asthma-related death, and why? Now the next question, is this patient at risk of asthma-related death or not, and why? Why he is at asthma-related death? Okay. Now let's proceed to the next question. How would you manage this patient in primary care? And would you prescribe non-steroidal for this patient or not? First, please, will you manage this patient in primary care level, or you will refer him to the hospital? How would you decide? Now, let's proceed to the presentation, and we will answer all of these questions. The definition of flare-up is worsening of asthma symptoms and lung function from the patient usual status. The problem with bronchial asthma flare-up is that even patient with well-controlled or mild asthma may progress or may present with severe flare-up or even life-threatening sometimes. These are the usual risk factors, the risk factor or the precipitating factors for the bronchial asthma exacerbation: smoking, exposure to chemicals, respiratory infections, exposure to pollutant, and some medications like non-steroidal and beta blockers. Before we start managing any patient with flare-up, or before the patient come to us in a flare-up, we need to provide patient, or we need to educate patient or we need to prescribe a written action plan for the patient. This action plan should contain at least 3 points. Self-monitoring of the patient, whether he has symptoms or not, and what is his peak expiratory flow rate at his usual state. This is an important information because we will base many of our assessment regarding severity, and we will base our management based on his best peak expiratory flow rate. The other point that should be included in the asthma action plan is how to respond to in case of flare-up. This should include what medication should we give and how to take them, what are the doses, when to take oral corticosteroid. And the third point is when to ask for help, or when to see the patient again for reassessment, or when should the patient seek for help. Regarding the action plan, it was found that patients who are taking inhaled steroid with formoterol, which has an active rapid action. These patients, if they increase the frequency of this medication, it will prevent progression to severe flare-up, hospitalization, or need for oral steroid, better than if the patient is taking inhaled corticosteroid with LABA, or if the patient is taking salbutamol alone. And this table will show you what action should the patient do with each plan of management. For example, if he is on low dose inhaled steroid with formoterol, in this case, the patient should be instructed to increase the frequency of the medication when he has worsening of symptoms. If the patient is taking only SABA or salbutamol, he should increase the frequency of this medication. And according to the plan of management of the patient, there are different actions. For example, if the patient is on maintenance steroid and taking salbutamol as a reliever, in this case, we need to quadruple the dose of inhaled corticosteroids. So we should design our written action plan according to the patient condition. Patient should know when to come to the hospital. As we said, that these are the 3 main components of a written action plan or a good action plan. So the patient, if he has a worsening of symptoms, he should increase the reliever, and as well, he should increase the controller, and he should review the response. If the patient did not show improvement within 48 hours, or if his peak expiratory flow rate is less than 60% of his best, in this case, the patient should come to me in the clinic. And our plan or our role here is to continue reliever and continue controller, but we should provide the patient with the optimum dose, and we may consider adding prednisolone orally if it was not started by the patient, and the patient, of course, should book an appointment with us. Regarding the action plan of asthma patient, if the patient was able to manage his asthma at home, this does not mean that I should not see the patient again. I need to see the patient within 1 to 2 weeks in order to see the level of control of this patient, whether he is in a good control and partial control, or he is uncontrolled. The other point I need to review is what was the trigger or risk factor for this asthma flare-up. We should review the plan or the action plan, check the compliance of the patient, inhaler technique, and if the patient is well controlled on the action plan that was given to him ahead of time, we may taper the increasing or the quadrupling or doubling the doses of inhaler and controller after 2 to 4 weeks. It was found that self-monitoring and written asthma action plan and education led to a lower risk of admissions, ER visits, office visits, and missed days from work and nocturnal awakening symptoms. Please note here that we should not go back to the usual, or we should not taper down to the patient usual doses of medication if the patient was uncontrolled before he presented to me with exacerbation. Now let's talk about the stepwise approach. For any asthma patient that come to me or who come to me in the clinic, I need to proceed through these 5 steps. First of all, we need to assess the patient initially to make sure that he is really asthmatic and not having another disease. After that, we should ask ourselves, is this patient at asthma-related death? We should assess the severity of this flare-up. We should manage the patient in our setting if we can, and after that, we should decide whether to discharge the patient or to dispose him to the hospital or refer him to the nearest emergency department. Regarding the initial assessment, you will see that so many patients who comes to you in the clinic labeled as asthmatic, but actually, if you review the history or if you take proper history and do proper assessment, you will discover that some of these patients are not really asthmatic. They might have COPD, for example, because they are chronic smokers. The second question that we should ask ourselves in the initial assessment is this a bronchial asthma exacerbation or something else? Because even asthma patient can have other comorbidities or other acute conditions. So we should ask about the onset and precipitating factor, the severity of the symptoms, and the medications, mode of delivery, and compliance of the patient and response to this medication. If the patient has no clear precipitating factor or he is not responding to medication if they were delivered properly, in this case, we should consider other possibilities. And the third question that is important to us is, could this patient have a COPD or not? This is regarding the initial assessment. After that, we should assess the severity of this asthma attack. But how? There are several factors. If one or more of these are present, this will make the patient at higher risk to have asthma-related death. These include history of ICU admission or intubation in the patient life due to asthma, of course, or history of hospital admission or ER visit in the past year. If the patient is currently or recently stopped oral steroid, in this case, he will be at higher risk of asthma-related death. If he is not currently using controller medication like inhaled steroid, bronchodilator overuse, more than 1 canister per month, poor compliance to medication, and food allergy. And finally, if the patient has psychiatric or psychosocial problem, for example, he is living alone, he cannot ask for help if he has worsening of his symptoms, or if he has difficulty of accessing primary care or healthcare facilities. If the patient or the family are failing to appreciate the asthma severity, in this case, this patient is at higher risk to develop asthma-related death. What should we do if the patient is at higher risk to die from asthma? First, we should instruct the patient to seek medical care early. He should not wait till he develops exacerbation. After that, he come to us in the clinic. Other point, we should be aggressive in managing these patients. We should have a lower threshold for ER referral. We should involve a relative in the management of each exacerbation, if possible. We should put a label on the patient file or medical record that this patient has so and so factor for asthma-related death. And finally, we should consider referral to a pulmonologist in order to control his asthma properly. Now let's come to the third point in the assessment, which is the assessment of severity of exacerbation. It was found that signs and peak expiratory flow rate are better in predicting asthma severity in comparison to the symptoms alone. Three important points to assess in patients presenting with asthma exacerbation. The first point is the general appearance of the patient. Is he conscious? Is he using accessory muscles? Is he cyanotic or not? And the second point is the vital signs, including the oxygen saturation. on room air. And the third point is auscultation, whether he has rhonchi, what is the phase of this rhonchi, and whether he has any other sound in examination, like repetition, which may suggest other differentials. After that, we should do the peak expiratory flow rate and compare it to the patient best, which is better than comparing the peak expiratory flow to the expected. After that, we should look for signs suggestive of other differential diagnoses like heart failure, pneumonia, foreign body inhalation, and so on, especially in children. As I said before, that peak expiratory flow rate and physical exam are more reliable in predicting asthma severity in comparison to the symptoms alone. According to this table, we should classify asthma severity. For example, if the patient is speaking normally, has no cyanosis, no altered level of consciousness, his pulse rate is less than 120, respiratory rate is just mildly elevated, oxygen saturation maintained 90 to 95% on room air. He has expiratory rhonchi and his peak expiratory flow rate more than 50% of his best or of the predicted, and he has no single feature of any of the severe feature or the life-threatening feature. In this case, we should consider this asthma exacerbation as mild. But this is not the end of the story. Also, we should assess the response of the patient to our management. For example, if the patient is not well responding to our initial management, in this case, we may consider referral, or we should consider other differentials. This is a graph that shows the predicted peak expiratory flow rate. If we don't have the best peak expiratory flow rate of this patient, we may go to the graph like this. But I would tell you, here in Saudi Arabia, I reviewed the literature. There is no there are no studies conducted to determine the normal or the predicted peak expiratory flow rate for our community. Unfortunately, I found only one study that measured the peak expiratory flow rate, and it was done on healthy people attending primary care long time ago. And the conclusion of this study that our peak expiratory flow rate values are lower in comparison to British people. In our patient, if we, how to use this graph, we should determine the age of the patient. In this case, he was 46 years old, and we should know the height of the patient. This patient was 183 centimeter. So the predicted peak expiratory flow rate of this patient is around 640. Now we should divide the patient peak expiratory flow rate in the clinic when he come to me in flare-up. We should divide it by this best predicted value of peak expiratory flow rate, and it will give me a percentage. If the percentage is less than 50, this indicates that this patient has severe asthma exacerbation or flare-up. Now, regarding the management, which is the fourth step in the stepwise approach, is management. Like we should give the oxygen to keep the oxygen of the patient between 92 and 95%. We should not overload the patient with oxygen, especially if we suspect that this patient might have a COPD or asthma COPD overlap. The other point in the management is to give oral steroid, and as soon it should be given as soon as possible, ideally, or it should be given within less than 1 hour of patient arrival to the primary care center or to the healthcare facility. Usually, we will give prednisolone 40 to 50 milligram, and the patient will continue on this medication for 5 to 7 days. Preferably, it should be taken in the morning. And the third management, or the third line of management, the third medication in the management is the salbutamol or the Ventolin. Either it should be given either through spacer or through nebulizer, and these are the doses. I will not go to discuss them one by one. And this dosage should be or can be repeated every 20 minutes. for up to 1 hour, and then we should assess the response of the patient. If our assessment of severity is severe or life-threatening, in this case, we should be more aggressive. As we said, oxygen, systemic steroid. And in this case, here, the systemic steroid should be a must, whether oral, if the patient can take medication safely, or we can give parenteral medication, like hydrocortisone, 200 to 400 milligram IM. After that, we should give the bronchodilator, like salbutamol plus ipratropium, and these are the doses, whether through spacer or nebulizer. If the patient is not responding, we may consider giving him, or if the patient is in life-threatening asthma flare-up, in this case, we may consider giving magnesium sulfate, 1 to 2 gram IV infusion over 20 minutes with close monitoring, close cardiac monitoring. I want to mention here that during the COVID era, the SINA guideline or the Saudi Initiative for Asthma, they recommend to prescribe through spacer, not through nebulizer, preferably patient spacer, not through nebulizer, to prevent transmission of infection from one patient to another. After that, we should decide whether we can discharge the patient safely home, or we should refer the patient to the hospital. How to decide? The patient should meet all these discharge criteria. First, the patient symptoms should be improving, and his vital signs should be improving also. His peak expiratory flow rate should be more than 60% of the patient best, or predicted if we don't have the patient best. Oxygen saturation should be more than 92% on room air, and he should have adequate resources at home. For example, he has enough inhaler, and he is using spacer, not only the usual inhaler technique, or he should have nebulizer. We should make sure that patient can come to us if he has sudden worsening of symptoms, and there should be enough family support. In this case, we can discharge the patient safely home. Otherwise, we should refer to the hospital, especially if the patient has severe or life-threatening flare-up, as we mentioned before. If the patient's symptoms are severe and he is not improving, in this case, we should refer to the hospital. If the patient is not responding or deteriorating despite our treatment. And finally, some patients we may refer to the hospital. For example, if they have no enough family support, or he has psychosocial problems, he cannot appreciate the severity of the symptoms, or if we have one or more of the risk factors for asthma-related death, in this case, our threshold for referring the patient should be lower. If the patient showed partial response, in this case, we should continue our management in the primary care center. We should not let the patient go until we make sure that he is fine and fitting all the discharge criteria. After continuing management in our primary care center, if the patient is still not showing all the discharge criteria, in this case, we need to refer the patient to the hospital. We should not discharge the patient home and we don't see him again. We should see the patient preferably within 1 to 2 days, or maximum 1 week. In this case, we should discuss the medication plan, like bronchodilator, salbutamol, PRN should be given, not regularly. And he should be on a controller, at least inhaled controller. And we should consider oral corticosteroid according to the patient condition. We should provide an action plan for the patient. And when the patient comes to us in the clinic, we should decide whether to continue or stop oral steroid. We should assess patient for improvement, review the action plan to make sure that it fits this patient. And we may consider stepping down of the controller. As we said, we should increase the dose in each asthma flare-up. So if the patient come to us in the clinic and follow up, we should decide whether to step down after 2 to 4 weeks or continue the controller at the same high dose for more than that, usually 3 to 6 months. After that, we may consider stepping down. So to conclude, A action plan is very important and should be provided or given to the patient before he develop asthma exacerbation. We need to assess each patient for his risk of death due to asthma. Third point, we need to determine the severity, and we should assess the response of the patient, and we should act according to these two parameters. And finally, we should ensure close follow-up of this patient. If you want to get some ideas or some samples or templates for asthma action plan, you can visit these websites. And in some websites, you will see also action plans written in Arabic, like in this case. These are the references of my presentation. And let's go back to the questions. Do we have questions from the audience?
I received one question here from the audience, from the online audience. The problem with us in the primary health care, mostly that our patient is not having their own best, and the devices is not available. So how we can overcome this?
It depends on the patient condition. If the patient has very mild disease, in this case, we will I will try to measure his best in my primary care centers, and I will give him a piece of paper, or I will document that in the file of the patient. Otherwise, if the patient can afford it, or if he has moderate to severe disease, in this case, I will advise him to buy a peak flow meter in order to know the patient best. This is regarding asthma, and the idea here, it should be bought only once, and there is no need to buy strips, for example, like in the case of glucometer. So he will pay only once, and after that, I will help him much in his management.
Okay, thank you, Dr. Ammar. There is another question related to the COVID-19 vaccine and the effect as a triggering asthma.
I have no idea about this answer, but I don't think the COVID vaccine has any effect on asthma exacerbation. Of course, since asthma is considered one of the allergic reaction, and vaccinations will induce the immune response, he might get some sort of worsening of some symptoms. But I did not come over any study to show that COVID vaccine is related towards asthma outcome. Okay.
Okay, thank you, Dr. Ammar.
Thank you.
Now we will have a break for 10 minutes.
We will have the opening ceremony now, so please be seated in your place. After that, we will have the break. Okay.
بسم الله الرحمن الرحيم. Your Excellency Dr. Khalid Al Abdel Karim, Assistant Deputy Minister of Primary Care. Your Excellency Dr. Abdurrahman Al Qahtani, Vice President of Transformation for Health Holding Company. Your Excellency Dr. Fahad Al Atabi, VP of Academic and Clinical Training at Eastern Cluster. Distinguished guests, ladies and gentlemen, it's a great pleasure to welcome you all today to the opening ceremony of the First Care Continuum Conference. Let's begin our ceremony with a recitation of verses from the Holy Quran.
بسم الله الرحمن الرحيم.
ألف لام ميم را تلك آيات الكتاب والذي أنزل إليك من ربك الحق ولكن أكثر الناس لا يؤمنون الله الذي رفع السماوات بغير عمد ترونها ثم استوى على العرش وسخر الشمس والقمر كل يجري لأجل مسمى يدبر الأمر يفصل الآيات لعلكم بلقاء ربكم توقنون وهو الذي مد الأرض وجعل فيها رواسي وأنهارا ومن كل الثمرات جعل فيها زوجين اثنين يغشي الليل النهار إن في ذلك لآيات
صدق الله العظيم. Now we would like to invite our scientific committee chairman, Dr. Nazih Al Khatem, to present his speech.
السلام عليكم. بسم الله الرحمن الرحيم والصلاة والسلام على أشرف الأنبياء والمرسلين محمد وآله وصحبه المنتجبين. Ladies and gentlemen, on behalf of the Eastern Cluster and Family Medicine Academy and on behalf of the Conference Scientific Committee, I welcome you today to this unique event, the Care Continuum Conference, the first CCC. Nowadays, the Kingdom witnesses a huge national healthcare transformation that make healthcare leaders and professionals carry health responsibility for our community. And all understand that individuals and families are at the heart of the healthcare services. We are honored to be a part of this responsibility by handling not only the educational part, but also the exchange experience between family physicians and other specialties. Today and tomorrow, we are promising you to be in a joyful, rich journey of updating knowledge and improving practice through Family Medicine Review and Update Conference. You will receive extensive discussion in 23 topics from 23 experts from family physician and other specialties, and from in and out the region. And we have two main panels discussion talking about the successful transformation of healthcare system and primary care team-based. The topic will be presented in unique, bright, practical way and support every family physician practice. While concluding, I will take this opportunity to thank each one of you and express our gratitude in your attend and participate in our Care Continuum Care Conference CCC. In the few minutes, you will see the short film talking about how this idea created and established. Thank you.
استمراراً لجهود المملكة العربية السعودية في تحقيق التحول في القطاع الصحي، والذي يعد أحد أهداف المملكة لرؤية 2030، وبهدف رفع جودة الخدمات الصحية المقدمة للمستفيد في رحلته من مراكز الرعاية الصحية الأولية إلى المستشفى. يطلق تجمع الشرقية الصحي اليوم ملتقى الرعاية الصحية المستمرة، والذي يقدم دعوة لتوطيد جسور التواصل بين أطباء الأسرة وزملائهم في التخصصات الطبية المختلفة في المستشفيات، ولتقديم خدمات صحية متكاملة للمستفيد من مراكز الرعاية الصحية الأولية، حيث تعتبر المحطة الأولى للمريض لتتم معاينته وتقديم العلاج له من خلال طبيب الأسرة في المركز، بهدف تخفيف العبء على المستشفيات. كما تتميز مراكز الرعاية الصحية الأولية بهويتها الجديدة بجودة الكفاءات من الكوادر الصحية، إلى جانب التجهيزات الطبية اللازمة في المراحل العلاجية الأولى، وأيضاً بتطبيق نموذج الرعاية الصحية الجديد والذي يخدم بشكل مباشر المستفيد. يهدف الملتقى لترسيخ مبدأ الخطة العلاجية المشتركة بين الطبيب في مركز الرعاية الصحية الأولية والطبيب في المستشفى، وهذه دعوة للجميع للمشاركة في تحسين جودة رحلة المستفيد من الخدمات الصحية المقدمة في منشآت تجمع الشرقية الصحية.
Now let's invite Chairwoman of Care Continuum Conference, Dr. Nada Al-Bunayyan, to present her speech. Please.
Assalamu alaikum. Good morning, everyone. Our special guests, Dr. Khalid and Dr. Abdurrahman, Dr. Fahad, all healthcare, Eastern Health Cluster leaders, and our guests, around now 10,000 subscribe and attending this course over the online. Good morning, everyone. It's my pleasure and privilege on behalf of the Family Medicine Academy and Training Department to welcome you all for attending the Care Continuum Conference. Ladies and gentlemen, Saudi Arabia is witnessing tremendous development in healthcare transformation, which is not only reaching but exceeding international level. Such a development is achieved as all the healthcare teams are working together side by side to contribute to the Saudi Vision 2030. The vision focuses on preserving people's health and integrity by investing in primary care to prevent diseases and any of their complications. However, for both family physicians and our colleagues in other specialties working together in one multidisciplinary team is a goal that has not been achieved yet in order to optimize individuals and patient journey. Both teams are to be fully aligned and shared responsibility in giving care to the patient in an optimized and lean system. From this concept, in the Family Medicine Academy in Eastern Health Cluster, present to you the Care Continuum Conference that target the consultants and specialists in family medicine and other specialties to be the first step in building the bridge between primary care and secondary care teams. We welcome you all to challenge your practice through discussing authentic life complex situation from the primary healthcare clinics and hospitals to apply evidence-based best practice. We hope that everyone here will have a joyful and fruitful experience and be motivated to take all necessary steps to get closer to achieving the Saudi vision. Thank you.
Thank you, Dr. Nada, for your inspirational speech. Now we would like to invite Assistant Deputy Minister of Primary Care, Dr. Khalid Al Abdel Karim. تفضل.
Assalamu alaikum wa rahmatullah. Good morning, everybody. Thank you for this invitation. I'm really have much pleasure to participate today in this conference. I'm very happy to have this conference, inshallah, on an annual basis. We believe such a conference will add a lot to improve the primary care and to have a better integration and coordination of care between the levels of primary, secondary, and tertiary care. It's always been mentioned and known to everyone that the health cluster in the Eastern region is a role model in implementing the model of care, having a better outcome and achieve so far a lot of targets, as well as the Family Medicine Academy in the Eastern region. It's well known with its, let's say, very good products of family medicine residents and consultants who are really serving the region. And we feel really the impact of their contribution in the primary care. One of the good things that we see always, and in particular in the Eastern region, that the family physicians are really presenting in the primary healthcare. They are not in the hospitals, just waiting the referral from the our colleagues, general doctors in the primary healthcare, but they are presenting there, improving the primary care, and we feel the difference in the performance. We believe with the existing model by the health cluster in the Eastern region, with a good of collaboration between the primary and secondary care, having the health zones and networks, more integration, more coordination being witnessed so far. And we believe this is really getting us more close to the transformation aim that everyone is looking for, to have one integrated system, one system that can accommodate all the resources and using the resources in the right place. I'm really interested to see the rest of the schedule today, and I'm really happy to be part of the panel discussion and to talk more in details about the transformation, about the plans that will happen soon, inshallah, in primary care. Thank you so much.
Thank you, Dr. Khalid, for your insightful speech. Now, a speech of the patron of this conference, Dr. Abdulaziz Al-Ghamdi, CEO of Eastern Cluster, presented by Dr. Fahd Al-Ataibi, VP of Academic and Clinical Training at Eastern Cluster. تفضل.
السلام عليكم ورحمة الله وبركاته. الحمد لله والصلاة والسلام على رسول الله، سعادة وكيل الوزارة المساعد للرعاية الصحية الأولية الدكتور خالد العبد الكريم، سعادة نائب الرئيس للتحول لشركة صحة القابضة الدكتور عبد الرحمن القحطاني، سعادة قيادات التجمع، زملائي مدربي ومتدربي أكاديمية طب الأسرة، ضيوفنا الكرام، أيها الحفل الكريم، السلام عليكم ورحمة الله وبركاته. باسمي ونيابة عن الرئيس التنفيذي للتجمع ومجلس إدارة التجمع الصحي، يطيب لنا جميعا أن نرحب بكم في تجمعكم تجمع الشرقية الصحي في ملتقى الرعاية المستمرة الأول، والذي تنظمه أكاديمية طب الأسرة في هذين اليومين، شاكرين لكم الحضور والمشاركة في هذه المناسبة العلمية. لقد اهتمت حكومة مولاي خادم الحرمين الشريفين وسمو ولي عهده الأمين في رؤية المملكة 2030 بعدد من الأهداف المتعلقة ببرنامج التحول الصحي، بغرض المساهمة في تحقيق مستهدفات محور مجتمع حيوي ضمن الرؤية، وذلك من خلال إعادة هيكلة القطاع الصحي في المملكة ليكون نظاماً صحياً شاملاً وفاعلاً ومتكاملاً، وتعزيز قدراته ومكانته للارتقاء بالخدمات الصحية. ويأتي في مقدمة هذه الخدمات قطاع الرعاية الصحية، والذي يعتبر الركيزة الأساسية لبرنامج التحول في القطاع الصحي الذي نعيشه ونفخر بأن نكون جزءا منه. ومن منطلق رؤية تجمع الشرقية الصحي بأن نحدث تحولا صحيا رائدا عالميا لرعاية صحية شاملة محورها الإنسان، وإيمانا كذلك برسالة التجمع بتقديم وقاية ورعاية صحية متكاملة يسهل الحصول عليها بآليات آمنة ومرنة ومستدامة ومبتكرة تعزز دور الرعاية الأولية وتمكن المستفيدين من العناية بصحتهم. ومن هذا المنطلق والإيمان أتت فكرة إقامة هذا الملتقى تحت رعاية أكاديمية طب الأسرة وبمشاركة نخبة من المتحدثين بغرض تبادل المعرفة والخبرات في هذا المجال والوقوف على أبرز التحديات في مجال الرعاية الصحية الأولية والتوصل إلى النتائج والحلول، إضافة إلى بحث سبل التكامل بين مستويات الخدمة في مختلف مراحلها لتحقيق مفهوم الرعاية المستمرة الشاملة. وفي الختام أكرر شكري وتقديري لكم ضيوفنا الكرام ولجميع المشاركين والحضور على دعمهم وحضورهم ومشاركتهم، كما أشكر الزملاء القائمين على هذا الملتقى ممثلا بأكاديمية طب الأسرة بالتجمع واللجان المشرفة والمتحدثون الكرام وجميع الإدارات المشاركة في الإعداد والتنظيم، سائلين المولى أن يوفق الجميع في هذا الملتقى وأن تعم الفائدة وأن يحفظ بلادنا وولاة أمورنا وأن يديم علينا الصحة والأمان. والسلام عليكم ورحمة الله وبركاته.
Thank you, Dr. Fahad and Dr. Abdulaziz for giving us continuous support. Now, appreciation. Dr. Fahad, please join us to appreciate our sponsor for this conference. Appreciation for the exclusive sponsor of Care Continuum Conference, Lilly Company, that did a great support and contributing to succeed this conference. Please, Dr. Mizna Kurdi, Marketing Manager, and Dr. Najd Al-Qasimi, Product Specialist, to join us and receive your certificates. Thank you so much. Thank you, Dr. Fahad. Last but not least, thank you all for attending, especially family medicine physicians, and hopefully you have a beneficial and informative scientific sessions. Thank you so much. Okay, now you will have a break for 10 minutes and then we will resume our scientific sessions. Thank you.
Excuse me, gentlemen, ladies and gentlemen. Our next session will start after 1 minute, okay? Our next speaker will be Dr. Abdulaziz Rabia. He is an assistant professor and consultant of emergency medicine with subspecialty in trauma, emergency medical service, and disaster medicine. He is the head of emergency medical services at King Saud University Medical City in Riyadh. Dr. Abdulaziz.
Assalamu alaikum wa rahmatullahi wa barakatuh. So, thank you for inviting me to your respectful conference. Thank you to the Academy of Family Medicine, led by Dr. Nada Buniyan. Thank you to the organizing and scientific committee. It's a great pleasure and honor of myself to participate in the first conference at the Eastern region. So, what I will do today is I will speak about cases in trauma. I will speak about some cases in the pre-hospital land that you may face in your practice, in your clinical practice, at your family center. So, and I will go through the questions. It's a life-threatening cases. So I will try my best to give you some hints about how to deal with these cases. Just to before start, I have no conflict of interest to any of the materials that I will present in my presentation today. I will go with this one later on. So a little bit about the pre-hospital trauma. So the good pre-hospital trauma will lead to a good hospital trauma. So it's not a separate entities. They are both depend on each other. So the tips and challenges in a pre-hospital trauma management can be summarized into 3 categories. So a trained staff. So we need a trained people in the pre-hospital trauma or in your family practice setting. That includes either training in special courses like pre-hospital trauma life support or like an advanced trauma life support courses, the ATLS and PHTLS courses. And studies have shown that a good training leads to good outcome. Scene time is another challenge for the pre-hospital trauma management. There was a discussion about doing the golden hour or the golden 10-minute. So both under studies, but in summary, we need to transport these patients as fast as possible to a tertiary hospital with the service provided there so they can manage these cases. It's important for the hospital trauma service management to get notified early. So give them a call that we are sending patients on. So we did this management and it's coming to your way either by ground ambulance or if we have an air ambulance later on in the future, by air ambulance. So that's my quote. The good pre-hospital trauma care is a crucial and must be given an equal support to a good trauma care hospital. Okay, so we do not ignore the pre-hospital trauma care. If I will ask the respected audience about how do they feel when they have a bad trauma in their center? So anyone can answer that. So anyone had an experience with a patient with a car accident or gunshots or fight or assaults? Not prepared for that. Yeah, that's probably the big factor. We're not prepared, right? So the preparation is the key. Okay, that's one. Any other comments or maybe in the audience through the online? Yeah, Dr. Rida. Yep. It is a stressful condition. And another thing that and why it's a stressful, I will quote on that, is because everything is acute. It's different from the medical conditions. Like you have this patient who's bleeding, the arm is amputated, or there is like a degloving injuries or multiple injuries, okay? And you have to be ready and prepared to receive these things. Okay, so I'll move on to the first case, which is a 37-year-old male brought to your practice by ambulance officers after he sustained a rollover high-speed car crash. He was wearing seat belt and airbag deployed at that time. So from the history, there are 2 different points that will make me worry, actually. So number one is Airbag was deployed, okay, and it's a rollover car. By only these 2 points, I should be worried that this injury is serious, okay? On examination, his blood pressure is 110/70, pulse 120 per minute, oxygen saturation 97% on room air, and his respiratory rate is 21 per minute with a blood glucose level 8 millimole. Am I worried about this vital signs? Anyone worried about this vital sign from the audience, either in the presence or on the online? Or you're happy with this vital signs and the mechanism of action? I think I will be worried. The blood pressure is borderline and he's tachycardic. Yes, I will be worried. Okay. And there is a good history of rollover. So, and you saw in examination, there is an obvious head injury, bleeding from the right ear, and that will point to me that there is something going on upstairs in his brain. Okay, there is a bleeding from the ear and there is a head injury sign. So how do you approach this patient? So as Dr. mentioned here, be always ready, okay? The trauma management start from preparation. If you are prepared well, you will manage this patient well, inshallah. Know your PPEs, set your monitor area, make a small trauma bay at your practice, check the equipment, make a list of the trauma equipments and provide it to your practice. Get help at your practice. Get help at your practice if you need it by asking for education, asking for courses, try to improve your care at your practice in case of trauma. So how do you approach this one? So it will be an airway, assess the airway if the patient is talking to you, collar, make sure that the patient has a C-collar and the neck is immobilized properly. Check the breathing for any decreased air entries or any tracheal deviation, any wounds. Know your blood pressure, keep repeating the vital signs. If there is a bleeding, control the bleeding, and you can do the EFAST, which is Extended Focus Assessment Sonography of Trauma, which is also part of the C nowadays. This patient has GCS of 9, pupil 3 millimeter on the right side, and left side there is a 4 millimeter, and there is an obvious head injury. Are you worried about this disability examination? Yes, I will be worried. GCS is approaching 8, so that means he will lose his airway soon. And there is inequality in the pupil. That means there is some bleeding going on in his brain. No other injury in the exposure. So that the issue in this case is very obvious, big issue, head injury, base of skull, low GCS. So the aim and the number three is to transfer this patient. This is another issue you will face. So what you need to do at this case, you need to secure that airway, intubate this patient. You can use, if you are able to intubate, you can use a ketamine, which is a good medication for a patient with multi-trauma injuries. There was a big discussion about ketamine and head injury. Is it a contraindicated or not? Studies have proven it's not. You can use it. Confirm the tube placement by using the capnography, the yellow small device on the top of each tube, and transfer the patient to appropriate trauma center. As I said, the contact communication is a key for successful trauma management. And if you're transferring a multi-trauma patient, make sure that you have a trained person with the patient, either a trained medical staff who can deal with the airway or a trained paramedic staff. So the take-home message from this case is know your ABCs, manage the patient accordingly, and transfer the patient to trauma center. Second case is a 28-year-old male brought to your practice by his friend. He was playing soccer and he was hit accidentally to the left chest by another player. He's complaining of a chest pain and shortness of breath. So are you worried? Yes, I will be worried. Left-sided chest pain, post-trauma. Is it a pneumothorax? Is it a hemothorax? And you have to think about that one also. On examination, vital signs, blood pressure 80/65, pulse 130, respiratory rate 30, oxygen saturation 85%. Are you worried about this vital signs? Obviously, yes, I'm really worried about this one. So with the history, with this vital signs, again, the chest is a big problem. If you examine the chest, there is a decreased air entry on the left side, and the trachea is deviated to the opposite side, to the right side. So again, collecting this information, it's pointing to a tension pneumothorax, which is another killer in trauma patients. Okay. So how you would approach this one? Primary survey, then manage this tension pneumothorax that we developed. And tension pneumothorax, it's a clinical diagnosis. Don't waste your time waiting for a chest X-ray, asking for a chest X-ray. No, I need to chest X-ray to confirm the diagnosis. No, you don't need that, okay? Just go ahead and start managing. If you have a fast scan in your practice and you are trained to use it. It will take only 5 seconds to see if there is a pneumothorax or not, if that will make you happy. And the treatment is a needle decompression. So the fastest scan, you will see 2 sign, which is loss of sliding sign, and there is the barcode sign that will point out to a pneumothorax. But you don't need it for this case. It's a clinical diagnosis. So how you treat the tension pneumothorax? Step 1 is you do a needle decompression. In the previous era of trauma, they used to use the needle at the second intercostal space mid-clavicular line, but the new update of ATLS guidelines at trauma societies to use the needle at the fifth intercostal space at the anterior axillary line, and puncture the hole, gush of air will come out, then follow that with a chest tube if possible. If you leave it without chest tube, it will reaccumulate again. So just do a needle and a chest tube. So the lesson learned from here is examine the chest always as a part of your ABCs. Don't miss the tracheal deviation. I've noted many of the pre-hospital staff, they miss the tracheal deviation. The trachea can give you lots of hints about a pneumothorax, and you can use ultrasound for confirmation of diagnosis if needed. The third case is a 31-year-old male involved in a high-speed motor vehicle crash, brought to your practice complaining of lower abdominal pain. Car accident with lower abdominal pain, that will point to something going on there. Blood pressure is 90/55, pulse 125, oxygen saturation 99%, and blood glucose is 9 millimole. Again, the same question you should always ask yourself when you're assessing the patient is am I worried about the vital signs here in trauma patient? Yes, I will be worried, right? It's a blood pressure 90 and pulse is 125 in a young male. Examination, it's intact primary survey, but when you did a pelvic exam, the pelvis was unstable, okay, by pushing on the greater trochanter. So what will be your next step here? So you have unstable pelvis. So anyone can help me with this, what you will do for this patient? So you have a problem with the blood pressure and you have a problem with the pelvis. So anything you can do to help that? So immediately think about the pelvic fracture. If you have X-ray facility, okay. If you don't need it, okay. Apply pelvic binder. We have this advanced pelvic binder on the right side, the one with the orange strap is there. That's very advanced. If you have it, good. If you don't, use the old traditional way, which is using the bed sheets on the left-hand side. There's a problem in application. So people, they apply it at the anterior superior iliac spine, and that's wrong. So it is on in the greater trochanter. So some people they call it a trochanteric pelvic binder. So don't apply it on the anterior superior iliac spine, just apply it on the trochanter. And if you have a facility of a blood transfusion, transfuse the patient immediately because he is bleeding. Unstable pelvis equal bleeding, okay? So if you have a blood, transfer. Giving a fluid is kind of waste of time, okay? At the cellular level, at the coagulation level. So it's good if we start practicing of putting some O negative, O positive blood in your center. So once you need it, you can use it. And there is a good review about using a pre-hospital blood in saving patients with a trauma injuries. Then transport to a trauma center where there is an interventional radiology available, because the only way to save this patient life is through the interventional radiology. Because as you know, the pelvis is a network of blood vessels, either arteries or veins. Patient can bleed up to 5 liters inside their pelvis. So the best way to control it at the immediate time is binder, interventional radiology, then take the patient to OR and fix the damages there. So listen here is apply the pelvic binder, think of a pelvis as part of your C. So C is circulation, bleeding control, ultrasound, and pelvic exam. Think of pelvic binder as trochanteric binder. In terms of log roll and checking the back, don't do the traditional 90 degrees. So don't log them all the way to the left-hand side or to the right-hand side. Maybe just log them to enough degrees that will be comfortable for you to put your hand under the back and look at it. Perform a rectal examination and vaginal examination if possible to check if that bone, which is fractured from the pelvis, penetrated the rectum or penetrated the vagina, okay? Then case number 4 is, and the final case is a 19-year-old female involved in a motor vehicle crash brought to your clinical practice with obvious degloving injury to her right thigh with active bleeding. So, and her physical examination, her blood pressure is 110/75, pulse 110, oxygen saturation 99%. Again, I will be worried about this blood pressure in a young 19-year-old girl, okay? And the thigh itself, patient can lose up to 2 to 3 liters from the injuries there. So I will be worried about it. Her primary survey is intact and her EFAST is negative. So what you should do in these cases with active bleeding is bleeding control. So the best method is just a direct pressure over the bleeding area. If that doesn't help, you can apply a tourniquet. You can apply a tourniquet. We have 2 types of tourniquet, either the one in the black, which is what there is a handle. You can apply it and keep turning the handle till you hear a click and just fix it in this position. Or you can use the old traditional way, which is again the sheets and the stick, and just keep closing it till you can't advance it. A tip here is 2 tips here. I apply it proximal to the wound. The second, apply after application, write the time. So you apply it at 9:15 and write 9:15. It's important for the surgeons and the tertiary team when they manage this patient. So mark the time, keep the tourniquet visible. So when you transfer the patient, at least you can see it, okay? Don't hide it under the bed sheet because you don't want to lose it. Check the arm every 2 hours, but hopefully by 2 hours, the patient is in a definitive care. And do not remove or loosen the tourniquet until there is an appropriate service is available for the patient. So the take-home messages here is apply pressure and application of tourniquets. Any question? I'm hoping that these 4 cases helped. I'm open now for any questions either from the audience here or online. Thank you so much. Okay, so we'll do it at the end. Thank you so much.
Thank you, Dr. Abdulaziz. We will take the next speaker, Dr. Rual Mu'min. He is a consultant emergency medicine in John Hopkins Health Institute or healthcare system. He is also an examiner and scientific reviewer at the Saudi Board of Emergency Medicine. He will talk. Dr.
Assalamu alaikum, everyone. Because I'm an emergency physician, I cannot, keep still. I have to move. I have to discuss the case and start my presentation. Can you have? So my presentation today is approach to actively seizing patients, and excuse me, clicker. Yeah. So when I was a young physician and at the very beginning of my career, it was very intimidating when you have actively seizing patients. I got, mental block. It's difficult to control the situation. It's very stressful, and everyone will have the same experience unless you have an algorithm for active seizing patients. So our goal today, our objectives today will have an algorithm for approaching seizing patients. We will prioritize critical actions and think what can you do next. Also, we'll discuss the life-threatening differential diagnosis other than seizure. We will go over different second-line agents. So this topic always, stressful for everyone. We'll start the topic today with a case. You receive a call from EMS from my friend, and they are, having an actively seizing patient. He's a 31-year-old man. They told you they gave him lorazepam IM, 2 milligram IM, and the patient is coming. At this time, the most important priority here is to protect the patient from physical harm and direct all your effort to stop the seizure. If you don't stop the seizure, basically it's difficult. You cannot do anything. So your goal is to control the situation and stop the seizure. Once you have those patients, the first 5 minutes are very critical. And I would you just think of those things. First, protective measures. The second thing, direct history and focused physical exam. Those, steps would direct you to the correct diagnosis. So in the first 5 minutes, most of the time, you just receive the patient. Let's say you have a patient, the same one, 31-year-old man at the UCU or emergency department. And most of the time, they are in post-ictal state. And usually, we get them. And if you have those actively seizing patients and or in post-ictal state, you just put them on the left lateral position and get the suction, try to clear the airway and open the airway with simple procedures. Just head tilt, jaw thrust, and open the airway. Get, an oxygen by non-rebreather mask, and always keep it a habit. Any patient who's not well, is not responding very well, get a blood sugar and AKG. Those are critical actions. Those would save the patient. And for those patients with seizure, the main thing is benzodiazepine and benzodiazepine and benzodiazepine. This is the first line management. As I said, most of the time they are in post-ictal state, and some of us will not give anything because they are not seizing, and some of us will give a small dose of benzodiazepine. But if you have someone who's actively seizing, we usually shy away from the appropriate dose. The good dose of benzodiazepine, of namely lorazepam, is 0.1 milligram per kg, maximum of 4 milligrams. And you can repeat this one. There are so many, there are different articles, and this is one of those. It shows that most physicians underdosing diazepam in case of refractory seizure or status epilepticus. Why? Because we usually shy away and we used to give like a small dose. So always think of the appropriate dose of benzodiazepine, 4 milligrams of lorazepam, and also you can repeat that again. Still, we are in the first 5 minutes. You direct your team, your nurses, get an IV access, get an blood work. I need AKG and blood sugar. So during that time, just go and take good history from the family, the surroundings, the paramedics. History is a critical key here. You should ask about history of fever because those patients might have meningitis or history of a trauma. So patient might had a trauma and then seizure, or maybe a trauma after the seizure as a sequelae of seizure. Also consider immunocompromised patients. Most of us would think immunocompromised HIV or transplant patient, which is correct. But keep in mind, there are different conditions like SLE, rheumatoid arthritis, multiple sclerosis. Those patients on high doses and chronic doses of steroids, and some of them on biological treatment, those are by definition immunocompromised. And they are at risk of what? Space occupying lesions or infections, opportunistic infections. So always think of those patients. Toxicology, ask about toxic ingestion. There are so much toxic ingestion here, but we underestimate those people. During your exam, check for drug marks, examine the patient quickly, and history of alcoholism. Those patients might present with alcohol withdrawal seizure, and this is significant. The history will direct you to different directions. Also, nowadays, everyone is want to lose some weight. They use herbal medicine. Herbal medicine by themselves are toxic or might induce electrolyte imbalance, and those patients might come with seizure. The most common missed ones, older people. You have an elderly who's staying home, they have a caregiver, but still they are malnourished and they are on multiple medications. They take antihypertensive medications, and that induce electrolyte imbalance. So those patients might have hyponatremia, hypocalcemia, or hypomagnesemia. If you don't get that history, you won't be able to treat it. So, and should be done within 5 minutes, not more than this. You just, exercise your skills of taking history. In Saudi Arabia, heat stroke is, a big thing. We usually see them, but we don't diagnose them properly. And the most important thing is cardiac arrhythmias. People might present with ventricular tachycardia, or they have twitching movement, but we say this is seizure. If you don't get an AKG and connect them to the monitor, if you don't see the ventricular tachycardia, you will just misdiagnose those patients. And just imagine if you think this is seizure and you misdiagnose those patients, you will spend the whole time, with wrong management, and they will keep seizing, and it's going to be devastating for the patient and for yourself, for the team. So early recognition is the key. Always consider other differential diagnoses in seizure patients. Always ask yourself, is this really seizure or something else? Again, in the first 5 minutes, this is very critical. Utilize them very, very well. Protective measures, as I mentioned, direct history, focused history, and direct physical exam. Now, what other differential diagnoses with directed management that you can think of? Any thoughts? So I mentioned most of them, but what if you have a pregnant lady? And some of people, they have big body habitus, and you don't see the pregnancy, the abdomen. If you don't check the blood pressure, and if you don't, they are pregnant, you will not give them magnesium. You will miss this diagnosis, and you will just difficult for you to treat. TP patient who are in INH, they might present with seizure, and the treatment is B6. Whatever you give, unless you give B6, it's not it's not going to stop. Electrolyte imbalance, as I mentioned, hypoglycemia, D50, simple things, but it's the treatment. So now we said most of seizure patient, they come to us, luckily stop spontaneously. What if you have an active seizing patient to your place, to your department, to emergency department? By all definitions, anyone present to emergency department or urgent care unit actively seizing, this is status epilepticus, because no one will come from their homes and arrives to your department with active seizure. They are beyond 5 minutes. And by definition, this is status epilepticus. And you shouldn't think, I'm gonna just, save some time. Once you go over the first 5 minutes, you order benzodiazepine and you request the second dose of benzodiazepine, you should ask for the second line anti-seizure agents. Their brain is on fire. They have electrical activity burning their heads. You need to stop it. You need to save them. And you should think in parallel if you have an algorithm. Once you order benzodiazepine, ask that nurse to prepare it. At the same time, ask someone else to prepare second line agents. Here we have different second line agents. Classically, the most common one is phenytoin. Phenytoin is one of the recommended medications as a second line agent. It's a good medicine. It's effective in stopping actively seizing patients. However, just keep in mind there are some critical side effects of this medicine. In case of extravasation, it leads to soft tissue necrosis. This is, I would say, okay side effect, but the most important side effect is cardiac arrhythmia and hypertension. You don't need to add more, problems to your problem list. So just be careful. And phenytoin, you infuse that in 25 to 30 minutes, not faster than this. It's risky medicine. You have another one, phosphophenotoin. This is, I would say, better version of phenytoin, okay, but still has the same side effect, although it's less, cardiac arrhythmias and hypertension. Another medicine is valproic acid. It's a good one. However, there's another side effect here, thrombocytopenia and liver toxicity. Keep in mind, patients with metabolic disorders, those are very difficult patients. When they come seizing, they don't stop. And if you give them this medicine, you might face some risk of side effect because they are at risk of liver toxicity. Nowadays, my favorite medicine is the rising, shining star of anti-seizure medication. It's levetiracetam, namely Keppra. So Keppra is one of the new medications. It has good safety profile, and it's easy to to prepare and infuse. The side effects of Keppra is rash and nausea. You can infuse Keppra as quick as 15 minutes, and it has good safety profile. Always we can use propofol and phenobarbital. This meta-analysis showed compared Keppra, levetiracetam, and phenytoin, and levetiracetam has similar efficacy in stopping status epilepticus, similar to phenytoin. However, it has better safety profile. So Keppra is comparable to phenytoin, and it's safer, has better safety profile. And this is applicable to pediatrics. The same thing, you could use Keppra in pediatrics and has the same efficacy and good, safety profile. You started your benzodiazepine and second line agents, the patient's still seizing. What can you do? So once you order second line agent, you should mentally prepare yourself, for the third step. If you don't do this, you will get locked in and you can't do anything. So prepare yourself for the third line, which is coma induction and intubation. You need to put their brains in rest. You need to stop the electrical activity for those patients. If you decide about intubation, then you have different options of sedative agents. You could use propofol. Propofol is one of the preferred medication. It's easy to switch on and switch off. And those patients usually have, I would say, higher blood pressure because they are actively seizing. And it's a good medicine, and it has anti-seizure activities as well. Also, you have midazolam and phenobarbital. Some people might ask me, you could give midazolam, on the first tip. Yes, but the dose here is different. The first one was like, anti-seizure dose, but here is anesthetic dose. It's much higher than the first one. Now, because you want to induce sedation and coma, and you want to stop the seizure. If you decide for intubation, always you need paralytics because those patients are stiff and difficult to open their jaw. You need to loosen them up. Most of articles, they have no preference between succinylcholine and rocuronium. However, we are always think beyond. When you have a patient with a status epilepticus and they, have been seizing for 30 minutes or more, they are at risk for rhabdomyolysis and hyperkalemia. Succinylcholine wouldn't be a good choice in this case. Just use it, just use your experience and, examining the patient well. Also, in patients with neurological diseases or muscular dystrophy, those patients, they have much of electrolyte imbalance. Again, succinylcholine wouldn't be a good choice for them. Although most of articles, they have they don't prefer, there is no superiority of one of those medication on the other. And yet still, I would recommend rocuronium. Once you intubate those patients and you sedate them, your job is not done yet. Still, you have many things to do because they might, paralyze them. They are not moving. They don't show you the physical movement. They are not jerking. They don't have convulsions, but they have electrical activity in their heads. So whenever you intubate those patients, you should ask for EEG and ask for neurological consultation for possible adding another anti-seizure medication. Also, after intubation, look for clues. Those patients, they might be sedated, but they are not doing something that give you hints. If they are laterally gazing, looking to one direction, okay, this is a sign of seizure. And also look for subtle movements. When they have twitching finger, this is also a seizure. And also look for the vital signs. If they have ongoing abnormal vital signs despite of all your management, they are seizing, they are suffering from their inside, they are still have brain activity. So you need EEG after induction and intubation. This is the algorithm that I discussed. This is presented from American Epilepsy Society. This one would give you a guide, and you are mentally prepared once you have a seizure patient. I would recommend you read this one once. It will stick. It will stick, in your head forever, and it helps you a lot. So this is in the first 5 minutes. You go for the protective measures, and after 5 minutes, you go for the second line agents, and then induction and intubation. This is very helpful, and it gives you the doses, the alternatives, and the options. In emergency department, we always, create things for us. We cannot read much. This is a simplified version of the algorithm. However, the first one on the right, this is the official one. The other one is simplified. You can go for the protective measures, and in emergency, you can see our mentality. We think, parallel, hand in hand. We think of second line and airway at the same time. That gives you a hint. Once you decide about intubation, once you decide about second line agents, you prepare for intubation in case you need that if the patient, still actively seizing. So the take-home message, most seizures are stopped spontaneously, lucky us, except when they are not. When they are actively seizing, they are in a status epilepticus, and you need to drop the kitchen sink on them. You need to stop the seizure. And when you have actively seizing patient, use the protective measures. Put them on the left lateral position and put them in oxygen. Try to open the airway, suction the airway, and prevent aspiration of the last night meal. So the first step you go, benzodiazepine. You start with lorazepam by any route, IM, IV, IO. You can start it anywhere. Also consider repeating a second dose of benzodiazepine, and then you go escalate. You have progressive stepwise action. You give a second line agent and intubation and airway. If this is typical seizure, patient has seizure, and this is typical presentation, you can, just do few blood work. But if this is atypical or new presentation, think of toxicology, head injury, head pathology, infections, and in those patients, fire the CT scan, get the LP needle, and throw on them antibiotic and antiviral medications while you are doing workup. Don't lock in one diagnosis. Think, what if this is not seizure? Namely, notably, the most important thing is cardiac arrhythmias. Think of special population, older people, they might present with electrolyte imbalance. Also, immunocompromised patient, pregnant ladies. Think of those as a different category and widen your differential and fire the CT scan because they have something bad. In summary, most seizures are fine and they are short-lived and easy to treat, except when they are not. Thank you. And those are the resources. You can just go there. And if you need the algorithm, I would strongly recommend to just go over it once or twice. And it's a good tool for teaching resident and anyone in training program. Thank you so much. Yeah.
Thank you, Dr. Rawa, for your nice presentation of this topic and to make it simple. Our next speaker is Dr. Ali Al-Faraj. He is a consultant family physician and subspecialized in minor surgery. He held also a master's degree in medical education. He is currently the head of academic affairs and training department in Katif Health Network, and he will talk to us about the burn assessment and care. Dr. Ali.
السلام عليكم ورحمة الله. بسم الله الرحمن الرحيم والصلاة والسلام على محمد وعلى الطيبين الطاهرين وأصحاب المنتجبين. Thank you so much for the scientific committee of this conference to invite me to present my topic. I'll try to focus on primary setting practice on our approach of burn assessment. The main objective is to differentiate in our talk today is to differentiate between different types of burn and when to refer and when you can manage burn at your clinic, and skill-wise to highlight some clinical skill to approach advanced burn life support. This in order to achieve appreciation and importance of burn in a clinical setting and decrease uncertainty of the clinician. In our practice, someone asked, what's the magnitude of our problems? This just a study, a local calculation in my clinic over maybe three to 4 years. We found that 40% of visitor in our clinic is wound debridement. Almost وجدنا تقريبا 18% of our visitor to clinic wound debridement 80% plus minus 2% كلهم بيرن يجوا. فstill this is very significant presentation or percentage in our practice. So overall تقريبا 180,000 death per year of bear. Non-fatal burn injury is leading cause of morbidity. This is from WHO to 2021. Skin burn are common in Saudi Arabia and more prevalent among females. Most skin burn occurs at home. The most causative agent is hot water, predominantly affecting the hands. The level of awareness of first aid of burn patient among healthcare worker was insufficient. And this is really very important. We have to figure out these problems. So we will talk about the assessment of burn regarding depth, size, site, age, and comorbidity. Regarding the size, there is a new classification of burn assessment. It's no more they are classifying the burn first degree or second degree. They are classifying the burn now according to the depth, the anatomical structure of the involvement. So the superficial, if the burn involving the epidermis, it's called superficial burn. And the second degree or the second level of burn is involving the epidermis and the superior part of the dermis, which called superficial partial thickness. And the third one is deep partial thickness. And the fourth one is full thickness. And the fourth degree burn is involving the skin's subcutaneous tissue and the underlying tissue. So this classification, if you figure it out, it's more dealing with insurance company, because if you have a superficial burn and superficial partial pain, there is no need for surgery, but deep partial thickness burn and full thickness burn is dealing for surgery. So this is very important. So the first level of burn, there is no need for surgery, and the subsequent level of burn, there is a need of surgery. So most likely this classification goes with the maybe insurance company and the cost of the burn. But still we are using the first and degree burn. But this is the most important to keep it in mind, that the new classification of burn has been modified based on need or doesn't need for surgery. This table summarize, for example, this is the two levels. There is no surgical involvement, and the third levels of burn, they need for surgical involvement. Actually, practical-wise, we are managing actually the superficial burn, superficial partial thickness, and deep thickness burn. We are capable in our practice, in our setting, we can manage such level of burn. I don't advise for the full thickness burn and deeper injury, I don't advise to keep the patient in your practice, refer him immediately to the specialized center. We know all, it's not easy to have an accessibility for burn center or plastic surgery accessibility. So we will try to utilize our resources to treat the 3 levels of burns. The second type of assessment of burn is extent of burn. So the first one is the depth of burn. The second one is the extent of burn. All of us know the modified Land-Broder chart. This is more accurate than the rule of nines, but evidence-based, even the expert burn plastic surgeon, he will be able to assess the burn estimation or the extent of burn 60%. They will be able to correctly, accurately assess the burn. So what about of non-expert? The percentage will be very low. So they are in United States, they are using some highly modified, sophisticated technology in order to assess the extent of burn and the depth of burn. But we don't have the luxury for these resources. We'll go with first degree or burn involving the epidermis, only involving epidermis. It's, as you see, it's a painful lesion, red and dry, blanchable with pressure, no blisters, healing within 3 to 6 days. Such type of burn, very easy to be treated in our practice, no need for referral. What we need is to use basic first aid available in all the clinic. This is a painful, red and wet and webbing, blanchable with pressure, blister, healing within 20 to 21 days. So the first one, there is no blister. The second one, there is a blister. It's painful. And this one is not dry. The first one is dry. This one is wet and exudating. So this is superficial partial thickness burn. This is deep partial thickness burn. It's painful to pressure only, cheesy to white, wet or waxy dry, blanchable with pressure, sluggish, healing within more than 21 days, usually require surgical treatment. Believe me or not, sometimes we are facing some patient in our practice, some of them refusing to be referred to the hospital with such degree of pain. And I'll show you at the end one case we came encounter in our practice. We have been treated with such degree of pain. And this is the full thickness pain. So it's involving the epidermis, the whole dermis tissue. So it's characterized by painful to deep pressure only, waxy white to black, no plunging with pressure, dry. Healing will be rare unless surgically treated. So keep in mind, in our practice, still we are facing some patient, especially pediatric population, with child abuse presenting with burn. These will be very characterized with, for example, very circumscribed lesion, not the typical presentation of non-abusive burn. For example, this one واضح يعني إن علامات lighter. This is very, very suggestive of abusing. And still, believe me, this is presented in our practice. And just keep in mind on such cases. So what are the criteria of minor burn? It's a partial thickness burn, less than 10% of total surface body in patient 20 to 50 years old. Partial thickness burn, less than 5% surface body under 10 or over than 50 years old. Full thickness bear less than 2% surface body in any patient without other injury, isolated injury suspicious of inhalation or electrical injury. So, does not involve face, hands, perineum, or feet, does not cross major joint, is not circumferential. So why I'm mentioning the criteria of minor thermal bear? This is our scope of surface. In a primary healthcare, really, we are able, and based on our resources, based on our skills, based on our training, we are able to manage such bear, the minor thermal pain. So treatment of bear, including these 10 categories, especially try to assess the patient, ABC, airways, breathing, circulation. Then you start with calling. Remove anything covering the patient, such as clothing, ring, watch. Apply about 12 degrees centigrade temperature water. This achievable by mixing. It's a good idea to keep a saline in your refrigerator. By mixing the saline in your refrigerator with a saline putting in a room temperature, you can achieve this temperature, 12. So dipping the lesion or the bear on a water with 12 degrees centigrade, this will be very helpful. Apply room temperature water for 10 minutes if you don't have that one. Cover the bear with gauze, not more than 30 minutes. Avoid use of cold or ice or putting ice. So cold water is preferably not indicated. Putting ice on the bear, this will worsening the situation. So pain management, essential to be started initially and during dressing. Overall paracetamol, you can use paracetamol orally or IV. Painkiller avoid, rarely we are using in our practice. Elevation of upper and lower extremities above the heart level will be very helpful in relieving the pain because it will decrease the edema. Avoid use of bifidone, clean with tap. In my advice, in my practice, in our community, I advise to use, I try it with so many patients. Bifidone is very helpful, especially if you came with a patient with contaminated bear. Try to use the bifidone initially, swab it with water. This will be very helpful, at least at the beginning, at the time of presentation. This will minimize the risk of infection. Remove the debris and the necrotic tissue as possible. And debridement, remove debris, sloughed necrotic tissue, including blisters, prevent infection. These will prevent the infection and will empower the effect of topical antibiotic. And it's clearly what is the difference between before and after. Blister, it is not advisable to rupture or aspirate the blister. The blister can be found in partial deep thickness bear. It's not advisable to aspirate or rupture the blister. You will increase the risk of getting the infection. Avoid rupturing aspiration. Unruptured unresolved blister for several weeks may indicate deep or full thickness. So maybe your initial assessment, this is partial thickness, but if you have a blister persisting more than, for example, more than a week or 10 days, think about deeper bear, full thickness bear. This is most likely you will have such a bear. Chemoprophylaxis, superficial bear sometimes. So in general, let's make it short. Chemoprophylaxis is not indicated to be used in superficial bear. And in literature review, also they are mentioning it is not advisable, it is not recommended to use it, even in superficial partial. But believe me, in our community, in our most of presentation of bear, we need to use the topical antibiotic. So sometimes if you have with the follow-up, if you have suspicion of bear, you have to take even as a biopsy. In a bear center, they will take a full thickness biopsy if they have a resistant infection. So sulfadiazine, this is the traditional medication. I prefer not to use it for so many reasons. Now the evidence of using such a medication, it will increase the frequency of increase the pain, and subsequently increasing the pain will increase the frequency of dressing. So there are so many alternatives for that. We have the sulfurcil now available in our practice, so you don't use it. Honey containing dressing, there is an evidence for that. If you have reviewed, there is evidence, but I don't prefer to use such a medication with deep full thickness bear. This is we are dealing about risk of infection, about dealing of so many complications. So there is no rule for topical steroid in initial treatment for minor bear, as these may increase the risk of infection. This is unfortunately very bad practice, using of corticosteroid with bear. It's not indicated at all. So dressing in our practice, this is all available in our centers, right? Fusidine, gauze, crab bandage, and the cifratol or the mesh contained antibiotic, all available. So managing of minor thermal bear is very applicable by using these. So if you have the pain, you perform your cleaning, you did your debridement, so you are ready now to apply the dressing. What is the dressing? Dressing is putting the topical antibiotic, fusidine available, or polysporine. It's the best if it is available. Then put non-adherent gauze, which is this one. موجود في العيادات مظبوط موجود عندنا. Then apply above this mesh, apply some gauze. Then you can wrap the whole bear with a crab bandage. So if you find that the amount, the volume of exudate is very significant, you can make 2 layers of gauze. There is also in our practice osmotic absorbent gauze. You can use it. This gauze will absorb the fluid very, very effectively. So in order to make the dressing 2 or 3 times a day, by using such type of gauze, you may need it for once. So when you stop your dressing, when you discharge, you say to your patient, okay, go home. You can do your dressing home by epithelialization. It's a very clinical, you can see it. It's characterized by islets, this one, whitish topped papules. This is the sign of healthy healing of the bear. So this is the sign. You send your patient safely and he can manage the bear at home. So what are indications of referral? When I should refer my patient? Most minor thermal bear, you should refer to burn center, which is not available in our practice. Delayed in epithelialization for more than a week in adult and 2 weeks in pediatric. You did your job very well. And after 2 weeks, there is no epithelialization. This is indication for referral. You are dealing with some deeper pain, more extent, more than what you assessed previously or initially. Full circumference bear, in order this one, to avoid any limitation of movement, especially if the bear around the joint. Wound infection, wound scar, partial thickness of bear greater than 10%. Face, hands, genitalia, major joint, full thickness 4-degree bear, electrical bear, chemical bear, inhalation injury, and bear without concomitant with concomitant trauma fracture. This is most indication for referral to the secondary care or burn center. This is a 65 years old, presented diabetic patient, presented with a thermal pain. حط رجله في ماء حار ما يحس diabetic neuropathy and he get this burn. Initial assessment كانت deep partial thickness to full thickness burn. We advise this patient to be referred to the hospital, refuse. We try our best to refer him, refuse. So we stuck with this patient. We apply all the concept of a dressing, we use all the resources which I mentioned before, and over 3 months of debridement, dressing, use of antibiotic, this patient end with such this one. Take home message, there are significant problem in family practice. Still, there is decrease of awareness of clinician to manage the bear. We need to empower our skills, our knowledge in order to deal with bear. يعطيكم العافية, and this is my references.
Thank you, Dr. Ali, for sticking with time. Unfortunately, for the sake of time, you can ask the speakers directly. We will have. So I will invite the moderator of the next session, Dr. Anadar Buniyan.
الأسئلة حتكون إن شاء الله مع السيشن اللي بعده وحنبدأ بالجلسة الآن. الوقت ماشي. لو سمحت خلها. لا خلينا نتقابل, هي جلسة ستي. السلام عليكم. على ما يجهز السيتنج, فكرة الحلقة هذه احنا ودنا نسمع منكم عن your perception عن effective transformation. لذلك احنا دعينا our special guest دكتور خالد عبد الكريم, دكتور عبد الرحمن القحطاني, دكتور محمد الأحمري, الدكتور رياض الموسى. We will sit together, we will talk about transformation, and احنا يعني our hope ان احنا نسمع ايضا منكم ونكون كوسيله تواصل. هي it's a good opportunity to hear from each other في ال 45 دقيقه الجايه ان شاء الله. دكتور خالد, دكتور عبد الرحمن, I would like to invite you. دكتور رياض, دكتور محمد, نشكركم جزيلا صراحه على الحضور, وان شاء الله تكون يعني جلسه يعني fruitful باذن الله. نبدأ بسم الله الرحمن الرحيم. احنا بدنا بأسئلة بسيطة بس نودنا نسمع من دكتور خالد. ترانسفورميشن، يعني كنت حاضرة مؤتمر كان في ترانسفورميشن في كندا it took them 5 years إلى أن اكتشفوا كيف يقدرون ينجحون فيها. وكانت المسج اللي قاله في المؤتمر إنه احنا ما اكتشفنا هالشيء الا لما عملنا الاينمنت بين البرايمري كير والسكندري كير. فودنا نعرف احنا اكثر في ترانسفورميشن الان في السعوديه، لان ما شاء الله احنا بدينا من 2018 وكان في بريبريشن حتى قبلها سنتين او ثلاثه للليدرز وخطه كانت يعني تقريبا واضحه. ودنا نعرف احنا وين وصلنا خصوصا بعد الجائحه وكذا.
شكرا جزيلا. طبعا الرعايه الاوليه مثل ما تفضلتي دكتوره هي موضوع من ضمن المبادئ او البيلرز الاساسيه في الترانسفورميشن، والبليف في الرعايه الاوليه ودورها معروف جدا في اي نظام صحي. حتى يكون عندك نظام صحي ناجح لابد يكون عندك رعايه اوليه متمكنه وقويه. الرعايه الاوليه مشكلتها الجميع يؤمن باهميتها وقوتها، لكن في الدي تو دي بزنس قد لا تكون برايورتي. يعني احيانا انت تكون عندك ضغط هائل بسبب وضع الرعايه مثلا العنايه المركزه، ضغط هائل بسبب نقص معين في جهه في الرعايه الصحيه، مما يعني انه تروح كل الجهود او ريسورسز لهذا الحل الآني، وبالتالي الرعاية الصحية تبقى على نفس مستواها أو لا تتحسن بشكل كثير، أو مع الزمن أيضا قد يضعف مستواها. ففي رحلة التحول معروف لدينا نموذج الرعاية، ونموذج الرعاية defined very well مستويات الرعاية والأنظمة اللي لابد تكون موجودة. فأنا مؤمن أنه مسألة التحول دائما نضع في اعتبارنا خلينا نتكلم يمكن 4 أشياء حتى يعني نمضي قدما بشكل صحيح في الرعاية الأولية. الأول، لابد أن تدخلاتك اللي تقوم فيها تتماشى مع المبادئ الأساسية للرعاية الصحية الأولية. إذا قمت بتدخلات معينة تتنافى مع هذه المبادئ اللي هي تؤسس مسألة الاستمرارية الرعاية، سهولة الوصول للخدمة، تقديم الرعاية بالشكل الصحيح والشكل الفعال مع ضمان أن التكلفة بتكون ضمن المعقول، فهذا أحد يعني المبادئ أو المبادئ الأساسية المعروفة للرعاية الأولية لابد أنها توضع في الاعتبار. الأمر الثاني هو موضوع نموذج الرعاية. إحنا أوريدي عندنا نموذج رعاية، المهم أن نبني خططنا دائما تتماشى وتكون ضمن هذا النموذج، والنموذج تعب عليه وأعد بشكل ممتاز، وبالتالي هو الآن المنهج الواضح لنا. النقطة الثالثة، لابد أن لا نغفل النظام الحالي الموجود مبني على تجارب، فيه ميزات وفيه عيوب. إذا شفنا النظام الحالي وجدنا أنه ما هو فعال في أشياء معينة، لا يعني أن كل المكونات الموجودة في هذا النظام لابد أن تتغير. والدليل أنه شفنا هذا النظام تحت ستريس كان جدا فعال في أزمة كورونا، كيف خدمت المراكز الرعاية الأولية وكيف أدت بشكل كبير. لذلك احنا لابد ان نضع عندنا يعني سيتويشن اناليسيس قوي لكل الممكنات القويه في الرعايه ونستفيد من الدروس. ايضا الامر الثالث ولازم نضع في الاعتبار دائما لما نشوف تجربه بلد ناجح في الرعايه الاوليه يجب ان نستفيد من دروسهم. ايضا يجب ان يكون عندنا حلول ابتكاريه وانوفيشن في الرعايه، لكن يجب ايضا ان لا نكون نتعاطى مع الموضوع بسطحيه، ان نريد ان يعني ننسخ فاينل اوتكم من جهه من نظام ونعتقد انها ممكن تطبق غدا في النظام، لانها بنيت بناء على انظمه ومسارات وتجارب ولوائح قد لا تتوفر في نظامنا الحالي ولا يمكن ان تتوفر في نظامنا الحالي بسبب الاختلاف جذري في المجتمع او التنظيمات، وبالتالي لا يمكن ان تصل الى هذا الشيء. فلازم ان دائما يعني ان نضع في اعتبارنا كل هذه الامور.
يعطيك العافيه دكتور خالد. دكتور عبد الرحمن، إذا ممكن أن ذكر الدكتور عن نموذج الرعاية، وإحنا العنوان المؤتمر الكير كونتينيوم، إذا ممكن تطلعنا يعني وين وصلنا الآن وإيش دور الموجودين معنا يكونوا فعالين في الدور اللي أنتم قاعدين تقدمونه.
شكرا دكتور ندى. طبعا زي ما ذكر الدكتور خالد، هو نموذج الرعايه الحديث او نيو موديل اوف كير هو عباره عن مبادئ برنسبلز هدفها انتجريتد كير، كوردينيتد كير، الاهتمام بالصحه السكانيه، التاكد من تفعيل دور المواطن وتمكينه والاهتمام بصحته. فهي المبادئ يمكن كلها مبادئ اساسيه جميع الدول وجميع الانظمه الصحيه تحرص على تطبيقها. السؤال كيف نقدر نستفيد من الممكنات الموجوده في السيستم حاليا بحيث ان نطبق هذا النموذج الصحي الحديث. الان السؤال على وين وصلنا، مراحل كثيره، والنموذج هو امتداد لعمل سابق اصلا موجود في النظام الصحي السابق، وفيها كثير من البنيه التحتيه او الانفراستراكشر الموجوده سابقا تخدم وتساعد اصلا انه يطبق النموذج الحديث بطريقه اسهل. يمكن زي ما ذكر الدكتور خالد، يعني يمكن بعض الاماكن وبعض الدول عندها بعض الاجراءات او بعض التشريعات قد تمنع هذا النوع من الانتجريشن وهذا النوع من الكوردينيشن يتم بطريقه سهله. لكن عندنا عندنا اشياء مميزات كثيره ممكن تساعدنا نفعل الدور. اذا رجعنا يعني فلسفيا على موضوع النموذج، هو نموذج الرعايه الحديث هو كان عباره عن الاساس او البلو برنت اللي على اساسه كنا نبغى نبني النظام الصحي. لما تبني النموذج، لما تكون عندك البلو برنت جاهز وتقرر انه هذه الطريقه الجديده اللي حنقدم فيها الخدمه، طريقه تعتمد على تمكين المواطن، تعتمد على الاعتماد على البرايمري كير ليس كجيت كيبر بقدر ما هو ذا مين انتجريتور للسيستم البرايمري كير. وهذه نقطه مره مهمه، احنا هدفنا ان البرايمري كير يكون هو المين انتجريتور للسيستم بشكل كامل. لما تيجي تبني هذه المبادئ احنا نتفق هذه المبادئ اللي نبغى نبني عليها السيستم وتكون مبنيه على البوبوليشن هيلث. كل التحول اللي جاء بعدها او الخطط او البرامج مبنيه على هذا البلو برنت. الجميع اتفق انه نحتاج نمكن المريض، ونيد انتجريت الكير بين البرايمري والسكندري، نحتاج انه يصير في جود كير كوردينيشن، نحتاج نهتم بالصحه السكانيه. معناته عشان نسوي كذا نحتاج انه نقسم السيستم الحالي الى تجمعات، والتجمعات ما تكون مستشفيات مختلفه عن مراكز، لازم تكون كلها اندر وان امبريلا. طريقه البيمنت حتختلف على هذا الاساس، طريقه التدريب والاتش ار حتبني على هذا الاساس. فهو في النهايه تعرف اولا وش البلو برنت حقك، كيف تبغى تسوي، كيف تبغى تقدم الرعايه الصحيه، واتفقنا احنا بنقدمها بالطريقه هذه اللي تكلمنا عنها. وكل شيء ياتي بعد النموذج هو عباره عن ممكن لتفعيل النموذج اللي هو الطريقه الجديده لتقديم الخدمه الصحيه. فالتجمعات وصلت مراحل كثيره في تطبيق النموذج وتفعيل كثير من المبادرات، وبدانا نشوف نتائجها. فيعني هذا شيء فعلا يدعو على شيء يحمس كثير ويدعو للفخر صراحه، خاصه في تجمع الشرقيه. انا اعرف معنا كثير يعني بالالاف في المؤتمر هذا من باقي التجمعات، وكلهم خير وبركه. لكن اللي شاهدنا اليوم في التجمع فعلا شيء مبهر وشيء رائع جدا.
يعطيك العافيه دكتور عبد الرحمن، كلمات محفزه يعني. بتوجه للسؤال نتورك اكزيكتيف دايركتورز، بما ان سمعنا يعني نموذج الرعايه وايضا الاساس هو البرايمري كير، فودنا نعرف يعني الدور اللي الى الان في الشرقيه وخصوصا تميز التجمع الحين وين وصلنا فيه، برضه ودنا نعرف
طبعا استكمال الحديث الزملاء الافاضل، اطرح يمكن مثالين مهمه من الشبكه، ثم personal experience، ثم اختتم بفكره عن الاور فيوتشر امبروفمنت. فهذه امثله من الواقع، والامثله كثيره حقيقه في برنامج التحول الصحي. من اهم الامثله يمكن نطرحها الان اللي هو الكرونيك ديزيزز. اعتقد هذه من اهم الانيشيتيفز يعني عملنا عليها في الشبكه في المراكز الصحيه كانتجريتد يعني كير بين المراكز الصحيه وبين السكندري هوسبيتال. فمثلا الكرونيك ديزيزز في المراكز يمكن حاليا نغطي حوالي 20,000 مريض، يمكن 20,000 مريض اوفر يمكن 29 برايمري هيلث كير سنترز في شبكه الدمام الصحيه. To make sure انه there is a continuum ولا continuous care, we built 2 teams اللي هو care coordination، وكذلك المالتي ديسيبلينري تيم اللي هو عباره عن يعني مجموعه من الفرق زي الفود كير والديابيتك ايديكيتورز والأوبثو. So we have 2 teams in each primary health care. أعتقد هذه crucial. The same 2 teams, they serve the same patients في primary care. The link here comes with our secondary hospital where we have specialized centers. Again, we have a diabetic center. We have around يمكن 25,000 diabetic patients. Around يمكن 27,000 hypertensive again. So those patients are covered by another multidisciplinary team. هنا يجي اللينك بين البرايمري وبين السكندري هوسبيتال where we try to تعرف في البرايمري care we have 2 teams. يمكن every 3 months they do the same investigations يعني refill. في السكندري hospitals we try to do discharge back to the primary care. واعتقد هذه one of the improvement projects in we have post discharge services at the secondary hospital to make sure those patients sent back to the primary care. A trick comes between the link between the primary, how the primary and the secondary hospital works, and I will give you my personal experience. The second example is the complex patients, okay, where we have so many complex patients at secondary hospitals. يعني يمكن the same يعني footprint or the same patients we see them at the primary care. So we have decided each أي مريض with 5 visits or more than 4 to 5 visits, we prepare a medical report and we send them back to the primary care, to the nearest primary healthcare center. So these are very crucial 2 examples. We want to make sure we have a continuous care, but the link is the challenge. So from my personal experience, we started the MAM network to integrate the clinical services between the primary and care without governance. يعني خلينا نقول بدينا قلنا خلاص البرايمري دي كان انتجريت بالسيرفيس مع تحت الإدارة الطبية، تحت الأوبريشن under nursing etc. We found out بعد سنة إنه ما في governance. Okay, we want to do the integrated care between the primary and between the secondary, but there is no leadership. أعتقد very crucial to make sure we have a continuum care is to build the integrated leadership team before the clinical services. So يمكن الدكتور هيعلق حتى على الموضوع هذا. We started with a new executive director for the primary care and community health. This is 2 weeks ago. And we said, okay, now we have 2 executives. They can sit in the same table and they can discuss the true integrated care with the empower of the CEO for the care. So I think this is a promise that we're going to see in the future. So our future plan, to summarize up, is to improve the transfer to the primary care and the feedback, and of course, considering the rejection rate in the future. So we will build a system between the OBD and the primary care. The other, I think, is to build post-discharge services, again, between the secondary and between the primary, and this will enable decision makers to make sure we have a correct journey between the secondary and between the primary. And finally is the virtual care. This is something we really look at it as how to really integrate it as a future step. This is what I feel.
يعني شكرا دكتور احمدي. بس انا يعني فعلا النقطه اللي ذكرتها موضوع انه بدانا الانتجريشن وبدانا نشتغل، بعدين اكتشفنا انه نحتاج موضوع الجفرنس. بياكد لك انه هذا تطور طبيعي لجميع التحول اللي صار في العالم كله. كثير من الدول مرت وكان يمكن وزير الصحه النرويجي ذكرها بالنص، انهم لما بدانا في الكلينيكال ترانسفورميشن بدا الشغل، بعد فتره بداوا هم الكلينيشن نفسهم بدا الناس يطلبوا انه يصير فيه تغييرات ادمن وجفرنس عشان تضبط الموضوع وعلشان تضمن استمراريته. فهذا احنا دائما ناخذه بطريقه ايجابيه، انه تطور طبيعي، معناته انه فعلا ان شاء الله احنا في الرايت دايركشن. ويعني بس حبيت اعلق على النقطه هذه. الله يعطيكم العافيه.
يعطيكم العافيه، صباح الخير جميعا. اولا دكتوره ندى واللجنه المنظمه شكرا للدعوه والاستضافه، الله يعطيكم الف عافيه، وان شاء الله يكون مؤتمر سنوي وحافل بكل النشاطات. وفاء الخير ان شاء الله بالاخبار اللي يوم امس، ان شاء الله تكون بكره مع تقليل الاحترازات يكون الحضور ان شاء الله بشكل كبير بشكل مباشر اكثر من الحضور الفيرتشوال. خليني ابدا بالتيك هوم مسج او الختام. يعني ليس سرا انه الركن الاساس في الوقت الحالي للتحول الصحي هو التدعيم الاكبر لخدمات الرعايه الصحيه عن طريق طب الاسره، واعتقد هو الحجر الاكبر في الوقت الحالي، والضغط والدعم الكبير راح يكون موجه لتقديم الرعايه بشكل امثل عن طريق خدمات الرعايه الصحيه او مراكز الرعايه الصحيه الاوليه. النقطه الاخرى، الخدمات الصحيه تمر بشكل على مستوى العالم كله بشكل مستمر بخدمه تطوير لا تتوقف، وراح تحمل فيها الكثير من التجارب والأخطاء، ومن ضمنها أكيد أي خطة تحول ممكن توضع. غير ممكن أنه يكون في خطة تحول توضع بين يوم وليلة ويصير التغيير بشكل مباشر، يعني مو سويتش هي. فهذه لاحظناها أيضا في العملية اللي على أرض الواقع الآن جالسين نقوم فيها في إجراءات التحول أو الترانسفورميشن، وإيش يتبعها من تغيرات على الأرض اللي تحتاج أكثر. تحتاج من الجميع يكون في بيشنس، في صبر، والصبر هذا إن شاء الله مثل ما تفضل وقال دكتور عبد الرحمن في مؤشرات تبين عندنا أن نحن في الاتجاه الصحيح بمشيئة الله. تنظير أو وضع أو الحديث، يعني موضوع الترانسفورميشن، المؤتمر أو الكونفرنس يومين، يمكن يحتاج أسبوع عشان الواحد يتكلم في كل النقاط الرئيسية. ومثل ما تفضل برضو دكتور خالد وقال الأمور موجودة وممكن الاطلاع عليها كلها، لكن أنا بسوي مثل ما قال دكتور محمد، بعطي بعض الأمثلة اللي تبين وين إحنا كنتوركس وصلنا في التحول، أو إيش الخطوات اللي اتخذناها وشفنا فيها إيجابية. كشبكة القطيفة الصحية كان في اجتماعات سابقة طبعا مع شبكة الدمام تحت مظلة التجمع الشرقية لأجل إيجاد أفضل الطرق. أول ما بدينا في بداية 2019 كان وضعت خطط لعمل الانتجريشن، كيف نسوي تكامل بين المراكز الصحية والمستشفى. مع بداية عام 2020 وبداية الجائحة كان الاعتقاد السائد أن هذا راح، يعني وجود الجائحة راح يدمر كل أسس التكامل أو الانتجريشن. وبصراحة هذه من المفاجآت السارة اللي يعني أخذنا ثمارها. الجائحة أنا من رأيي الشخصي كانت سبب من أسباب تسارع الانتجريشن بروسيس أو عملية التكامل بين المراكز الصحية والمستشفيات، وهذه شفناها بشكل واضح. أنا أتكلم كمثال جالي مثلا في شبكة القطيف لما بدأت، ويمكن الكل عارف أنه بداية الأزمة كانت في محافظة القطيف، وكان في لوك داون في أول بداية الأزمة، وعلى مدى شهرين كان في تكامل بشكل منقطع النظير. تعلمنا منه دروس كثيرة بين المستشفى والمراكز الصحية، ساعدنا وبشكل كبير حتى بعد ما انتهى الحجر أنه نسرع في عمليات التكامل بين المستشفى والخدمات المقدمة فيه والمراكز الصحية الممتدة على المحافظة. كثير من الخدمات استحدثت، أنا أعتقد قبل الجائحة كنا نتكلم عن شهور أو سنوات اللي ممكن نحتاج أن نفعلها، لكن الجائحة خلتنا نسرع فيها، ووجدنا أن الإيجابية وردة الفعل والتجاوب حتى مع المرضى والجمهور والسكان كان بشكل كبير إيجابي، شجعنا أن احنا نمشي بخطوات إضافية. فأعتقد الجائحة كان لها أثر إيجابي من هذه الناحية، على عكس ما كان متوقع وسائد أنه ممكن تأثر في عملية التكامل. النقطة الأخرى المرتبطة بالأمثلة، الكوردينيشن أوفيس أو الكوردينيشن كير اللي يتكلم عليه أخوي أبو ظافر، احنا عملناه بطريقة مختلفة، يمكن الآن لسه ما اكتملت، لكن احنا عملناه بطريقة مختلفة بالشبكة. جزء من الانتجريشن اللي اعتقدناه مهم من أجل، وهذا برضو يدخل في موضوع الجفرنس، كل اللجان الرئيسية اللي موجودة في مستشفى القطيف كمستشفى رئيسي على مستوى الشبكة، خلينا كل اللجان الرئيسية اللي تخدم الشبكة يدخل فيها إدارة المراكز الصحية أو ممثل المراكز الصحية، سواء رئيس إدارة المراكز الصحية أو الصحة المجتمعية أو ممثل له في كل اللجان، من الإكسكيوتيف كوميتيز اللي موجودة في المستشفى إلى كل اللجان العلمية. وهذا ساعد بشكل كبير على تحقيق شكل من أشكال التوازن والتواصل. الكوميونيكيشن هو دائما السر، لما يكون في تواصل بشكل ممتاز راح يساعد على تفعيل الخدمة وتحسينها بشكل أفضل. إيجاد قيادات موجودة من داخل إدارة المراكز الصحية أو من الفاميلي فيزيشنز، وبعطي مثال منها الدكتور علي اللي قدم قبل شوي. دكتور علي هو فاميلي فيزيشنز كونسلتنت وهو رئيس الشؤون الأكاديمية في الشبكة، وهذا طبعا عامل مساعد في وجود مثل قيادات تؤكد موضوع الانتجريشن بين قيادات المراكز الصحية أو قيادات الفاميلي فيزيشنز والمستشفيات، عشان يكون في integration between the primary and secondary visits. الcoordination office، وهذه this is let's say the main items that we are working on it now، اللي هي مركز خدمات، تقديم خدمات مشترك بين المستشفى والمراكز الصحية، تساعد على كل طبيب صح، كل طبيب أسرة يحتاج يعرف مريضي وين، مريضي ايش صار فيه، مريضي لما يدخل مستشفى ايش يحتاج. وجود مثل هذا المكتب داخل المستشفى بقيادة الفاميلي فيزيشنز داخل نفس المستشفى للتنسيق والترتيب ومتابعة كل الريفيرال والفيدباك والريفيرال باكس للمراكز الصحية، أنا متأكد أن هذا راح يكون له أثر إيجابي كبير. وجود عيادات تخصصية على مستوى كل المراكز الصحية اللي موجودة في الشبكة، أكثر من 18 عيادة تخصصية في الوقت الحالي، كلها هذه أسست مرة أخرى على شكل من أشكال التكامل والتنسيق بين الخدمات الرعاية الصحية الأولية وخدمات الرعاية الصحية العامة في المستشفيات. هل احنا وصلنا إلى مستوى نقدر نقول مرضي؟ يعتمد على التقييم، لكن احنا اعتقد لازلنا في بداية الطريق، راح نستمر ونحتاج ان احنا نتعلم من اخطائنا السابقة ونستفيد من الفرص اللي موجودة، ودائما في فرص تحسين مستمرة. اعتقد ان شاء الله ان احنا في الطريق الصحيح بدعم المقدم من الدولة مع التحول الصحي اللي جالس يصير الآن. اعتقد راح نصل الى مرحلة متقدمة ان شاء الله في تقديم خدمات صحية عالمية، مثل ما كان مواجهة المملكة لجائحة كورونا كانت على مستوى عالمي ومثال يضرب فيه على مستوى العالم كله.
يعطيكم العافية. طيب قبل ما يعني توجه للجمهور، في سؤال هنا جاني من الجمهور اللي اونلاين. صراحة هو يعني أكثر من مرة ذكر، بما أن الآن تذكرتوا في الجائحة وقفة أطباء الأسرة، يعني أطباء الأسرة يعني consultants ودرسوا على مناهج قوية و they are competent وأثبتوا نفسهم في الجائحة. لأن الأطباء يقولون أنا أقدر إلى الآن أنا I cannot fully يعني أقدم الفول مانجمنت بلان بسبب نقص الريسورسز. أبسطها يعني واقعيا، وأنا منهم، أبسطها وصفتي، يعني وصفتي فيها أدوية قليلة جدا ما بقدر استخدمها، ومع الاسف احول البيشنت عشان ينكتب دواء يعني اسمحوا لي لجلسه الصراحه يعني. وهذا الشيء يسوي لنا فرستريشن، انا يعني من عيادتي يسبب لي احراج مع البيشنت. نفس الشيء بالنسبه للاشعه السي تي، احنا عارفين الانديكيشن حقها، لكن ما اقوم احولها للنيورولوجي مثلا للسي تي مثلا. فهنا الاطباء الاسره يعني اكثر من سؤال يطالبون يقولون خلونا يعني يكون لنا بريفليج معين او على حسب بالضبط النيدز فور اور بيشنت وعلى حسب مستوانا احنا كاطباء. وات دو يو ثينك؟
اذا تسمح لي دكتور خالد يمكن يعلق بشكل موسع على الموضوع، لكن مؤكد موضوع البريفليجز اللي تمنح للاطباء الاسره في طلب بعض الخدمات سواء كانت سي تي او ام ار اي او اي خدمات داخل الفحوصات تكون تخصصيه، هذه بدات وموجوده وكلها تتعلق بقديش بريفليج انت ممكن تعطى بالاتفاق، ووجود الاكسكيوتيف دايركتورز كاداره مراكز صحيه وكلينيكال سيرفيسز في المستشفى على طاوله واحده، الغرض منه ايجاد ايش البريفليجز اللي ممكن الطبيب يحتاجها ويسويها. بخصوص وصفتي اعتقد هذا حديث يعني، او خلينا نقول اللوجيستيك والريسورسز بشكل عام. صحيح هذه احد التحديات اللي تواجهنا كلنا، لكن هذا جزء من اللي كنا نتكلم انه في عمليه تطوير مستمر. وصفتي بدات كمشروع واعد، الكل شاف اثاره ايجابيه، صحيح يمكن غير مكتمل، لا زال في بعض الادويه ناقصه، لكن اتمنى ان شاء الله ان في المستقبل القريب تكون وصفتي تغطي كل الادويه والاحتياجات اللي يحتاجها سواء كان المريض في المراكز الصحيه او في المستشفى. يمكن التحدي الاكبر اللي موجود الان وراح يعمل الفارق الكبير في حال وجوده اللي هو يكون في يونيفايد HIS، وجود يونيفايد يعني ملف طبي موحد، وانا متاكد ان هذا موجود في يعني من ضمن الترانسفورميشن بروسيس. هذا راح يصنع الفارق لما يكون في ملف واحد عندي في المستشفى وفي المراكز الصحيه، وانا اطلع عليه كطبيب واشوف ملف المريض. هذا راح يعزز كل الخدمات او التحول اللي جالسين نتكلم عليه، بوجود تقديم خدمه واحده للمريض عن طريق سواء الرعايه الصحيه الاوليه او الثانويه او الثلاثيه.
شكرا، الله يعطيك العافيه. السمة الأساسية عندنا في الرعاية الأولية، لو فكرنا دائما نقول احنا عندنا مراكز رعاية أولية كثيرة ومتوزعة في كل مكان، 2300 مركز تقريبا وأكثر. دائما if you get there ما تجد كل الممكنات لك. أنا أتكلم الآن كطبيب أسرة، أنه تجد الشيء الذي تستطيع أن تقوم فيه بدورك بشكل كامل. تفضلتي دكتورة قلتي ما في الأدوية ككل. الشيء الثاني في صعوبة في وجود الفحوصات من التحاليل أو الأشعة. خلينا نتكلم قبل إيش كان وكيف التحول اللي صار. أنا أتذكر في قبل يمكن 5 سنوات كان في المراكز الرعاية الأولية بالضغط ما في إلا كابتوبريل وثايازايد بس. فكيف كان يحول المريض فقط تو كنترول هيز بلد بريشر للمستشفيات. الآن احنا نشوف الميديكيشن ليست تحسنت، لكن ما زال فيه يعني طريق انك تطور هذه الليست. الكلام الآن ليش احنا عندنا نقص؟ أغلب من يقيم الرعاية الأولية يقول أنا أقدر أشوف العلة واضحة، العلة هي عدم وجود ريسورسز، لكن في روت كوز أناليسيس أكثر أنا أعتقد المشكلة في شيئين، وأشكر الزملاء أنهم they highlighted هذا الموضوع. يعني يمكن تعلمون أنه أحيانا في بعض المناطق موجودة الريسورسز قد لا تستخدم، يعني موجودة في مخازن المنطقة ولا تستخدم والمراكز تحتاجها. ليش عندنا مشكلة هذه؟ ما عندنا leadership، ما عندنا قيادة فاعلة. ولذلك لما يكون عندك قيادة أتكلم طبية فاعلة في الرعاية الأولية سيطلب الطبيب أنه يكون هذه الأشياء تكون موجودة. الآن يعني يمكن تفاجئون أنه ما نجد أحيانا حتى طلبات، يعني في مراكز إحنا نشوفها أنا أستغرب كيف يعني يقدمون رعاية للمستفيدين في هذا المكان، ما عندكم شيء كيف؟ ولم تجد منهم أي طلب. لذلك وجود أطباء أسرة المستويات إدارية متوسطة في التجمع سيكون لهم الدور مثل رئيس قسم الجراحة في المستشفى. لا يمكن تكون قسم جراحة كله جراحين بس ما عندهم رئيس. لا يمكن قسم باطنة يشتغلون كلهم بس ما فيه رئيس القسم. الرعاية الأولية مهم يكون عندها هذا الليدرشيب، ولذلك لما يكون عندك قائد طبي يشرف على أكثر من مركز، هنا أولا بيوضح حاجاته، وحاجات المراكز قد تكون متشابهة في أشياء لكن قد تختلف بناء على حالة منطقة جغرافية معينة. هذا واحد. اثنين، قد الزملاء في المستشفيات يقول احنا فتحنا البريفليج للزملاء في طلب الأشعة وطلب كذا، لكن بدينا نشوف طلبات غير واقعية وأثقلت كاهل المستشفى. احنا الريسورس حقتنا خلصت. لما يكون قائد طبي سيكون يشرف. الآن لو في قسم جراحة مرة ثانية أرجع أعطي المثال، لا يمكن رئيس قسم الجراحة يقبل إن كل المرضى يعملهم بس عملية هيرني. لما يشوف إنه الحالات مثلا في القسم لا تخدم دور القسم، سيتدخل مع القسم الموجود فيه وبالتالي يؤدون الدور الصحيح. وجود إدارة طبية فاعلة على مستوى إدارة متوسطة ستخلق هذا الفرق، وهذا يمكن الجانب نلمسه في مستشفيات موجودة عندنا في المملكة أو رعاية أولية موجودة عندنا في المملكة في قطاعات أخرى. الشيء الثاني وهو المشكلة المفقودة عندنا ليست فقط الرعاية الأولية، ولكن دورها هو الرعاية الأولية هو الأكاونتابيلتي. يعني نقول لك الليدرشيب والأكاونتابيلتي. أنت لما تتنوم في قسم الطوارئ، استشاري الطوارئ مسؤول عنك حتى إما أنك تتنوم في المستشفى أو تخرج بالسلامة. لما تتنوم في المستشفى، استشاري اللي أنت منوم تحت اسمه مسؤول عنك حتى أنه أنت تخرج. مشكلتنا في العيادات الخارجية في الرعاية الأولية أو حتى في التخصصية، المريض بنفسه هو من ينسق حالته. المريض لا يوجد أحد مسؤول عنه، وبالتالي يكون أحيانا هو أسير لتوفر مواعيد، أسير لموظف تسجيل مواعيد. قد حالات تتأخر، حالات تفقد بسبب هذا الشيء. لذلك كانت فكرة ليست جديدة موجودة في كل الدول، قد يكون من الصعب سابقا تطبيقها، وهي التيم بيس كير. وهذه الآن احنا نسميها يمكن بالعربي طبيب لكل أسرة، واحنا وي اكسباندد في هذا النموذج. هو من قلب نموذج الرعاية وهو طبيب الأسرة. واحنا انا ما ودي لان احنا في طبعا الفاميلي ميديسن اكاديمي، لكن لا نريد ان نغفل وانا فاميلي فيزيشن دور زملائنا في التخصصات الاخرى في الرعايه الاوليه، النيرسينج، الكير كوردينيتور، الهيلث كوتش، وايضا الاذر سبيشالتيز اللي ممكن يكونوا معنا ككوميونتي هيلث. احنا الان نبني فرق في الرعايه الاوليه بحيث يكون كل طبيب، وممكن حتى يكون في طبيبين او التريننج ريزيدنت يكون معاهم مع نيرس ثابته، مع يدربون على الكيس كوردينيشن والهيلث كوتش سكيلز، بحيث نكون اسايند على مجموعه من الناس، عوائل او اشخاص من 1000 الى 2000. طبعا هي حسب في لها اكثر من تفاصيل وبنش ماركينج. بهذا الشكل انت كشخص ومستفيد يوجد طبيب وممرضه مسؤولين عنك. You can call them, you can ask them. مو بس كذا، هم if you don't come they should approach you، لأن احنا حنقيم أداء الفريق على حسب الأشخاص المسجلين معهم. هل أنت عملت لهم التدخلات الصحية اللازمة؟ عملتهم التشيك اب اللازم؟ المرضى اللي عندك مثلا عندهم زيادة في الوزن، ما هي الجهود اللي عملتها أنك تنقص؟ المرضى اللي عندك أو الأشخاص المدخنين، ماذا عملت أنك تخليهم they stop smoking؟ الأطفال اللي طعموا. فبالتالي أنت تهتم. والمريض مثلا اللي عنده متابعة مع تخصص دقيق، هل رعايته مثلا هو يحتاج أن يتابع مع نيورولوجيست، لكن still he will get common cold, he might get diabetes. فلازم يكون في good coordination. أنت كطبيب الأسرة أنت الطبيب الأساسي across السيستم، الناس تعرفك. فبدينا إحنا نضع هذا الكونسبت. اليوم إحنا نتكلم، بدأنا في 2020 ومشروع هو مشترك، وهو في الموديل اوف كير مع الزملاء في الشركة القابضة، وبدأنا ب60 فريق وسجلنا تقريبا حوالي 50,000 شخص. قبلها كان في كذا بايلوت صغير وجدنا في إحدى المناطق وبدأنا فيها أنه سجلوا 5,000 شخص في 5 تيمز. تخيلوا لقينا منهم حوالي 1900 دايبتك. ليش 1900 دايبتك؟ هل هو البريفلنس اوف دايابيتس واصل 60%؟ لا، لأنهم هذول هم الفريكوينت فيزيتورز. It means احنا we wasted chances ان نفحص الناس الهيلثي. We wasted chances ان نمنع حدوث المرض. فاحنا just dealing with sick people، وهذا مو دور الرعايه الاوليه، دور رعايه وقائي قبل لا يكون علاجي. احنا عندنا في الاعمار العاديه مشكله في السمنه، عندنا مشكله في المنتل هيلث، كثير من الناس عندهم انكزايتي وديبريشن. فانت لابد يكون عندك وصول للناس وتكون سهول الوصول لهم وتبني الثقه. طبيب الاسره يستطيع بناء هذه الثقه بالكومبريهنسيف ابروتش عنده وقدراته والسكيلز اللي تعلمها، انه يبني العلاقه الطويله هذه مع الاسره. وبالتالي وجدنا انه هذول الدايبتك كثير منهم ما عندهم ريسنت A1C، واللي عندهم ريسنت A1C ما يشكلون الا يمكن 16%، و16% اغلبهم انكنترولد وما فيه البومين تو كرياتين ريشيو دم، والليبيد كنترول واز نوت دان ولا تيستد حتى. فبالتالي هذول الناس احنا نتابعهم ويثقون في الماركت و they come to take their medication لكن they are not receiving care، وبالتالي احنا we are not sparing them من الكومبليكيشنز. لكن لما اكون انا accountable على هذا الشخص واعرف ان هذا الشخص مسؤول عنه، if a lady مثلا she developed breast cancer وهي عمرها 57 سنه وانا الشخص الاكاونتبل and I never afford her test للماموجرام وهي تتابع معي وشي trusted me, she's not a physician, she doesn't know ايش المفروض تعمله. ليش احنا نبني فقط الحملات التثقيفيه للناس ونعتقد انه هذا هو المفروض يفهم ويقرا بعدين هو يجي؟ لا، انا المفروض اللي اوفر الكير. اليوم ما ابغى يعني اطيل عليكم، ولله الحمد وصلنا الى 1500 فريق في الرعايه الاوليه اكروس المملكه، وعندنا مسجل تقريبا 1,300,000 شخص. البلان القادمه الان ان هذا الموديل هو الاساس، ومع الوزير توفيق الربيعه ويعني نبارك له الثقه الملكيه انه اصبح الان وزير الحج والعمره، وايضا مع الوزير المهندس فهد الجلاجل داعمين لهذا المشروع، وذكر انه لابد يكون لكل اسره طبيب. فالان دور اطباء الاسره مهم زي ما قلنا في الليدرشيب وفي هذه الاكاونتبيلتي. بدانا نحرك كل الانظمه الالكترونيه انها تؤدابت هذا النموذج ونطور انظمه الكترونيه. بدانا نحرك كل التشريعات. السباهي بكره سيقيم المركز على وجود هذه الفرق. اداء، فكل هذا قاعدين نشتغل الان بهذا الشكل. تطبيق صحه الان if you open it now، ما اقول لك بيكون open it now، وتدخل على صحتي وتدخل على سيرفيسز تلقى شيء اسمه ماي فيزيشن او طبيبي. هذه الحين بدات ايقونه الناس المسجلين مع فرق if you log in بتلقى دكتورك. في الريليز اللي في الاسابيع القادمه جاي if you are not registered وحتدخل حتلاقي المراكز and you'll browse وتلقى اسم طبيب الاسره ايضا صورته اذا يبغى، وتلقى ايضا التمريض اللي معاه. انا ما نبغى ان الجلوري يروح للطبيب، لان كثير من الاكتيفيتيز هذه calling الناس reaching them out asking them for vaccination ما هي فقط دور الطبيب. احنا نبغى زملائنا ايضا دورهم مهم في التيم انهم يكونوا recognized ف they will be there. حتى ممكن احيانا تحجز موعد فقط مع الممرضه للتطعيم. الريليز اللي بعده وكلها ان شاء الله فتره قادمه والان يشتغلوا عليها you will be able to communicate with your physician مثل ما هو موجود في تطبيق صحه. you send messages تسال طبيبك تقول له والله انا من زمان ما عملت كذا، فهو يرد عليك من خلال تطبيق انات. او العكس، الطبيب ممكن خلاص انا عملتك تيست I don't need to get you out of your work عشان اعلمك النتيجه وانت تتبهدل عشان تلقى موعد. انا I will send you اول ممرضه will send you result is okay، ادويتك موجوده. او even you can broadcast your مثلا female patients اللي في certain age group تبلغهم عن انه this is the time مثلا للبريست كانسر، مثلا تذكرهم بالحمله. او ممكن وقت الازمه سيزن ترسل برودكاست فيها محتويات علميه تقول لهم يعني اذا كنت انت من الازمتك بيشنت. ففيه بريك ثرو كبير ودعم كبير للرعايه الاوليه ان شاء الله قادم فتره قادمه. البلر الاساسي هو فيه طبيب الاسره وزملائنا الاخرين. باذن الله كل هذه الاشياء بتغير منظومه الرعايه، وبالتالي we will provide the resources. لكن you can't provide resources وتشتري كميات وما في احد موجود. لابد ان يكون في ناس موجودين تعرف انهم they will utilize the service. اسف على الاطاله بس انا اخذني الحماس.
يعطيكم العافيه، دوم الحماس ان شاء الله. انت ذكرت قيادات وانا ايدك عليها القيادات المتوسطه وكذا، لكن برضو اختيار قيادات ذات كفاءه والفاليو حقتها تكون فعلا الكوميونتي يعني نيدز. يعني في بعض مش بس what was their taught they will do. يعني لازم يكون عندهم فعلا يعني الحرية في وقراراتهم تتأخذ يعني على يعني بناء على حاجة المجتمع. وهم ترى هذا الشيء محير للقادة في الفئة المتوسطة، أنهم بيكونوا في الساندويتش ترى. يعني أنا ما دافع عنهم ولا أقول، ولكن أقول خلينا نحسن الاختيار قد ما نقدر. أو في هنا سؤال، إذا ما في سؤال من الجمهور باخذ سؤال من دكتور بدر المصطفى إذا سمحت، إذا أنت معانا تحب تسأل.
معكم دقيقة بدقيقة. السلام عليكم ورحمة الله، أرجو أنكم تسمعوني.
صوتك واحد.
حياكم الله. أنا يعني يسمحوا لي الإخوان وهم أصحاب وكذلك أيضا رفقاء لي تعليق على كل ما ذكر. أنا كطبيب أسرة طيلة ال3 أو ال4 عقود الماضية يعني يصعب علي تلخيص أين المشاكل، ولكن نعم أتفق مع الإخوان أن هناك مشكلة قيادة، ولكن مشكلة القيادة أن طبيب الرعاية الأولية في وزارة الصحة لا يشارك في القيادة أبداً ولا في اتخاذ القرار، وإذا شورك فيها فإنما هو شكلياً ليس أعلى من ذلك. ولكن غير ذلك الطبيب الممارس، طبيب الأسرة الممارس لا يشارك في القيادة إلا بشكل متواضع جداً، وهذا على مستويات كثيرة. يعني أنا شاركت كل الأمور تقريباً إلى كنت في اللجان الوزارية قرب وكيل الوزارة قبل الأسبق، ولكن لم أجد لطبيب الرعاية الأولية ممارسة وتمثيل فعلي. هذا الأمر الأول. الأمر الثاني، نحن لا نستمع إلى الاحتياجات الفعلية للممارسين. هذا الطبيب الممارس الذي يكدح سواء في هجرة أو سواء كان في مركز صحي متطرف أو فوق جبل وتلة، الذي لا يلقى حتى إلا الحمار، المراجع لا يلقى إلا الحمار. هذه مراكز صحية أنا زرتها، إلا حمار أو دابة يستطيع أن يصل إليها. هذا المركز الصحي الذي لا يوجد فيه إلا 3 ممرضات أو 4، بعضهن يحسن وبعضهن لا يحسن، أو 4 أو 3 أو 2 أو طبيب واحد، وينتظر منه أن يعمل برو أكتيف كير وري أكتيف كير، وأن يغطي إدارة، وأن يغطي ريسورسز، وأن يغطي إدارة مراجعين، وأن يغطي كذلك إدارة فريق صحي. هذا ليس ساحر، هذا ما هو ماجيك يقدر يسويه الطبيب حتى نطلب منه كل هذا أو المركز الصحي نحتاج أن نمنهجه وأن نمكنه من ذلك. أنا أتفق أن هذه الأمور، لكن طبيعتنا في الإدارة طبيعة انفعالية أكثر منها طبيعة استباقية. الأمر الأخير، نفقد الرقابة المستمرة الفاعلة. هذه الرقابة ضرورية. المراكز الصحية متشتتة، الممارسين فيهم ذو طبائع متفاوتة جدا، التغطية فيها متكررة، الشخص الواحد يغطي مهارات وأماكن ومواقع متفرقة، يجعل التركيز والمهارة في عمله الآني ضعيف، غصبا عنه ضعيف. فما لم يكن هناك تسديد، الرقابة ليست فقط لتفقد الثلبات ولكن للتسديد والتمكين، هذا كله نحتاجه. نعم أتفق كذلك أن الريسورسز عندنا مي قليلة. أتفق مع اللي الدكتور خالد لما قال قبل شوية روحوا إلى المخازن وحتشوفوا، وهذا تجاربي الفعلية كلها موجودة وتشير إلى ذلك. نعم أتفق معه تماما، ولكن لنا أن نسأل ليش، إيش الصورة، إيش المشكلة في الموضوع. أنا فقط هذا الذي أحببت أن أضيفه. شكرا لكم جميعا، وكنت أحب أن في مثل هذا اللقاء نستمع إن صح التعبير للأطباء الممارسين الموجودين معنا إيش يقولوا. شكرا.
إذا تسمح لي دكتور أعلق على موضوع الريسورسز، بعدين أترك يمكن تعليق للدكتور عبد الرحمن. أعتقد أنه جزء من الألم اللي نسمعه هذا جزء تاريخي، وحقيقة برنامج التحول الصحي هو موجود لحل الثغرات السابقة، فهذا أعتقد يجاوب جزء كبير من الألم اللي يمكن احنا على مستوى الليدرشيب we feel it every day. أعتقد طب الأسرة بدون مشاركتهم حاليا لن يحدث ترانسفورميشن على مستوى البرايمري كير. واعتقد ذكرنا في البدايه انه ايجاد governance وليدرشيب ليفل على مستوى السكندري هوسبيتال سو كروشال للسكسس فور ذيس ستوري. فاعتقد يعني هذا جزء كذلك. اعطي بس مثال للريسورسز allocations. اعتقد هذا common complaint انه everyone says ما في resources. اعتقد الجائحه كانت مثال انه we can use our resources. اوكي، يمكن الدكتور ذكر بدايه الجائحه في القطيف، احنا نقول كذلك شبكه الدمام وهو مركز كورونا، جزء كبير كان من الموظفين، يمكن 80% من الموظفين في مجمع الدمام كانوا محجورين في القطيف، صح؟ we lived يعني we successed بالريسورسز الموجوده، اوكي ولا لا، وفتح المخازن. we success to اذا كانت هناك رغبه willingness للليدرز to do it they will do it. This is a crucial. اعطيكم مثال للتو resources allocations. عندما يكون هناك willingness للليدرز، اعتقد كان عندنا surgical services we were planning to move جزء من بعض الماينر بروسيجر جمع الدمام الى مركز الفيصليه، واعتقد هذا كان unique experience. طبعا if you talk to the surgical department في المستشفى they will not listen to you، يقولوا وش وديني اروح المركز، صح ولا لا؟ That's one. The other one is the emergency. I will detail them quickly. Emergency department عندنا urgent care في المراكز، صح ولا لا؟ عندنا emergency. Our complaint كان جزء كثير من المرضى سيتاس 4 5 يجي لكل المستشفى، وحنا we need to push them back to the primary. يمكن كان أفضل حل phase 1 is to have both surgical department على community hospital وال ER admin في الهوسبيتال to admin الurgent care والsurgical units في primary care. That's phase 1 is to integrate them, to push them there to the primary to get accountability, to get experience, to get engagement مع primary care. Okay, لا hoping إنه phase 2 we will hand over these minor procedures to the family physician consultant plus the urgent care to the family physician. We success. يمكن كفاءة الإنفاق يعني كان جزء من النجاح، هذا كان جزء مشارك في كفاءة الإنفاق. أعتقد we success big time to حتى في السيرجيكال ديبارتمنت الدي ام سي تشوفه يداوم في المركز الصحي. جديدة هذه، صح ولا جديدة؟ كذلك يفتح السيستم، نفس المريض اللي يحوله من هنا يشوفه نفس الفايل، نفس السيستم، نفس الاكسس. اعتقد الريسورسز allocations are not a big issue اذا كان في good leadership to move resources للبرايمري كير. Again, I will end with this example. جزء كبير ويمكن جزء اكثر الجميع يعلم انه مركز الفيصليه كان من افضل المراكز على مستوى المملكه. شلينا جزء كبير من العيادات من المستشفى وديناه هنا. عشان انا اجيب مثلا بعض الاجهزه يقول لك يبغى لك سنه شوي، قلنا اوكي يعني طلبنا قلنا خلاص عندك جهازين انت تشوف جزء من المرضى المفروض ما تشوفه في المستشفى، طيب خلينا ناخذ الجهاز نوديه الفيصليه and we start from there. I don't think انه resources is a big issue اذا كان فعلا في رؤيه للانتجريشن الكامل يعني. وكذلك خلي الناس في الكوميونتي دي work في البرايمري في البدايه، ها اعتقد هذه جزء كبير في الريسورسز يعني كجواب للدكتور.
يعطيك العافيه دكتور.
كنا نودي بس اعطيه نقطه. انا اول شيء اشكر الدكتور بدر مصطفى، هو من اعلام طب الاسره باي ذا واي، وجوده معنا شرف وحديثه عن تجربه فعلا ما ذكر الدكتور هذا من الاشياء المهمه جدا. ولذلك الان يمكن مع زملاء في الشركه القابضه دائما عندهم حاجه يسموها النتورك. when they develop anything عندهم نتورك اوف اكسبرت، وطب الاسره لها نتورك. كثير من الاشياء تبنى باطباء من وليسوا من مناصب اداريه، من البراكتس المميزين يجلسون من كل مناطق المملكه ويختارون. احنا مثلا في التحاليل نقول اطباء الاسره غير ممكنين او لا توجد تحاليل. اول شيء بداناه من المنيو ست للتحاليل اللي المفروض تكون موجوده طبيب الاسره حتى يتمكن من اداء الوظيفه. جلسوا الزملاء وعرضنا عليهم درافت وقلنا زيدوا او نقصوا حسب ما ترونه. اطباء اسره براكتسنج وليسوا في مواقع اداريه ولا شيء. في الاخير they came with a list. هذا لسه الان هل هي موجوده في كل مركز؟ لا، بس هذا حق الان موجود لهم، وبالتالي رفعت الى اداره المختبرات الوزاره وابروفد. فالان هي مانديت على المراكز او التجمعات انها توفر لطبيب الاسره البراكتسنج هذه المنيو اللي انا كفاميلي فيزيشن اشوفها مكتمله بالنسبه لي اني ادي دوري. فهذا شيء مهم. الشيء الثاني مرة أخرى لما احنا نتكلم عن نتورك اوف بي اتش سيز عليها قيادة طبية متوسطة سيكون محاسب. أرجع لطبيب الجراحة مرة ثانية، الاستشاري أو رئيس قسم الجراحة يحاسب على أداء العمليات عنده والعيادات والتنويم والموربيديتي والمورتاليتي. أنت ستكون قيادة متوسطة ستمكن أنك تتكلم وتطلب، أيضا ستحاسب على أداء كل المراكز هذه الأداء الطبي. كيف نقوم بمتابعة العمل؟ 3 أشياء أساسية. أولا نعتمد على السيلف ريبورت، احنا نبغى نسمع منك. الآن عندنا برنامج مستعد ان تقريبا every BHC هذا يوميا في تشيك ليست نطلب من المركز انه ترانس بيرنت يقول ايش عنده نقص، واحنا نعرضها في القياده والتحكم ونشوف والله الايتم هذا ناقص على كل المراكز، هذه مشكله سنترال من الوزاره، او لا هذا الايتم ناقص فقط في تجمع معين معناه في مشكله في التجمع. فبالتالي احنا دائما نطلب منهم انه ما نبغى ليست تكون كومبليت، نبغى تقول ايش المشكله الموجوده. ايضا نبغى من مستوى الاداره يعطونا ريفلكت عندهم، فهذه هي السيلف ريبورت. ثانيه نقوم بعمل اوديت يكون ستراكتشرد بالطريقه الصحيحه، ونبني لها مستويات داخل التجمع داخل المديريه وايضا على مستوى الوزاره. الثالث هو الداتا اكستراكشن. الان بدات تتقوى مراكز قياده التحكم في المملكه، صار عندنا داتا ساينتست، وممكن شفتوا برنامج اللقاحات كيف يعني كان المانجمنت حقه بشكل انه وي نو ايفريثينج سنجل فاكسين وين كان وايش صار، بناء على مركز قياده وتحكم فاعل. فهذه كلها يمكن مثل ما ذكر الدكتور من حسنات الجائحه ان بينت لنا عندنا ريسورسز. انا واز يعني اونرد اني كنت ان شارج في الماس تيستنج في البدايه ومراكز تاكد، ايضا عيادات تطمن، وي بيلد المستعد في عيادات تطمن، وكنا نشوف الريدنس افري داي وما زلنا نشوفها، نعرف افري داي هاو ماني بيرسون واز ريفيرد، هاو ماني بيشنت واز سيرفد، هل احنا لنا حاجه نبقي المركز ولا خلاص ما هي الريسورسز الموجوده. اضافه في التطعيمات الان نتابعها بشكل كبير وشفنا البروجرس اللي فيها، فاحنا عندنا ريسورسز فقط good governance good leadership good utilization of resources حيكون جدا رائع. سيبقى شيء قليل ناقص، هذا يبنى ويطلب بالشكل الصحيح. شكرا لكم.
يعطيك العافيه. احنا قبل ما نختم اذا في اي سؤال من الجمهور.
طيب لا. طيب ممكن نتكلم بدون اوكي خلاص. زملاء يعني لا يعني يمكن في الكير كونتينوم، في الكير طيب في طبعا تجارب كثيره حول العالم فيما يخص هذا الموضوع، وتحديدا يعني يمكن من التجارب اللي طلعت عليها التجارب الهولنديين فيما يسمونه الترانسميورال كير، اللي هو في النهايه الهدف الاساسي منه تنسيق الرعايه across the health system levels. ف سؤال the health system policies and guidelines، يعني هل فعلا في communicated يعني stated and clear policies regarding the coordination of the care across the systems، ولا يعني الاجتهادات يعني بتاعت مقدمين الخدمات بالذات في الرعايه الصحيه الاول. الصحيه في جدا بيتم عبر القطاع الخاص، والنظام الصحي معني بهذه السياسات في القطاع العام والقطاع الخاص. اللي بشوف انه في الغالب في تركيز على القطاع الخاص فيما يلي مساله الكير كونتينم او كير اكروس ذا ليفل. يعني هل في يعني اشراك، لانه هذا هدف بالنسبه للنظام الصحي اللي هو تنسيق الرعايه بين مستويات النظام الصحي المختلفه البرايمري والسكندري، فهل في اشراك فيما يلي يعني تحقيق هذا التنسيق في رعايه المرضى across the levels؟
احمد، نقطة على الترانسبيرنسي في النظام الصحي، اذا كانت ترانسبيرنت للموجودين او نعتمدون على الترانسفورميشن او برضو اللي هي الانيشيتيفز وغيرها. والنقطة الثانية واللي خلينا نجاوب هذه النقطة.
ما في مشكلة. شكرا دكتور محمد. نقاط مرة مهمة جدا. النقطة الأولى فيما يخص البوليسي أعتقد أنه بشكل كبير مواضيع التحول والخطط حقت التحول والأهداف، يمكن ذكرت الكلمة الآن على موضوع الديزاين. إحنا we are designing for the future، وأتليست عندنا تصور واضح إلى حد كبير how do we يعني see the future when it comes to the cluster, to the population health, to the integration. وهذا المهم. أنت لما ذكرت قادة التحول، أنتوا قادة التحول، مو إحنا قادة التحول. قادة التحول هو الطبيب اللي في المركز الصحي اللي قاعد يشتغل وقاعد يحاول integrate الكير و taking care of their patient. هم فعلا اللي يحققون التحول الصحي في البلد إلى أن يوصل المراحل اللي يحتاجها. الخطوط العريضة واضحة إلى حد ما at least for me، لكن دائما إذا ما في شيء واضح احنا we are happy to share to discuss. وأعتقد الفورم هذا اللي موجود الآن هو يعني أفضل فورم لمثل هذه النقاشات. وأنا أكد لك one يعني ambitious physician family physician can build a system، يعني no doubt about it. فهذه نقطة مهمة. النقطة الثانية القطاع الخاص. القطاع الخاص له دور كبير وحيكون دائما موجود في الصورة. بس خلني بأكد على نقطة مهمة. احنا هدفنا في الفترة الأولى أننا we fix الأشياء اللي موجودة في السيستم في البابليك سيستم بشكل رئيسي. يعني يمكن احنا في السابق احنا ما كان عندنا في السابق او ما عندنا الآن نموذج رعاية في السابق. ما كان عندنا نموذج رعاية في السابق. الفرق انه النموذج السابق كان يعمل لأهداف معينة وكانت فعلا أهداف ناجحة وكويسة، والآن تحدث النموذج صار نموذج more integrated, more population health based, more and more. كيف نستفيد من النظام السابق انه نفعل النظام الحالي؟ هذا دورنا كممارسين وكقادة تحول موجودين عرض في تعامل انتجريشن هذا. قبل اروح على خاص، انا كنت بعلق على نقطة الشباب في هذا السياق. أنا أعتقد في السابق في العقود السابقة كان في دعم كثير للسكندري كير للمستشفيات بشكل رئيسي، وهذا فعلا أثر على سواء الريسورسز سواء على الثقافة وعلى أشياء كثيرة. الناس ما تعرف المستشفى. الآن إحنا دورنا في المستشفيات، يمكن اللي موجودين الآن من المستشفيات عددهم قليل جدا، لكن دورنا الآن في المستشفيات فعلا كيف نسوي نفس المبادرات اللي تعملت سواء في الدمام او في القطيف. كيف فعلا نبدا احنا ويشفت الريسورسز هذه بطريقه او باخرى، لانه لما ترجع على الديزاين وعلى التفكير انك يو ديزاين فور ذا بيشنت، انت المفروض ما تنظر لهذه الليفلز بنفس الطريقه السابقه، تنظر لها از ان ايبلر للمريض نفسه، وكيف تحرك الريسورسز في المكان اللي يحتاجه المريض. هذه نقطة. بالنسبة للقطاع الخاص زي ما ذكرت، الآن في توجه في القطاع الخاص وخاصة في البرايفت انشورنس، في التحديث حتى حق البوليس الجديدة حيذكر فيه بعض الأشياء لها علاقة بما يخص البريفنشن والكوردينيشن والأشياء هذه كلها. ويعني في يعني تصور يمكن حتى مور اكستريم. يمكن الدكتور هادي أكثر واحد مطلع على بدأوا يفعلوا برامج الفايف بروجكت حقت البوبوليشن هيلث. there might be some mandates على موضوع السكريننج للدايابيتس والهايبرتنشن في البوليس مستقبلا، لكن اتليست الجميع بدأ يفكر بنفس الطريقة اللي تخدم المريض في المستقبل. هذا وشكرا لكم. بالنسبة لي آخر نقطة. آخر نقطة، وهذه نقطة يمكن أنا دائما أقولها لنفسي وأقولها للزملاء، إنه الوقت هذا is very exciting، والدعم اللي قاعد يجينا للتحول في الفترة هذه دعم يعني غير مسبوق. الفرصة فرصة يعني مواتية جدا ويجب الاستفادة منها. إذا ما انتهزنا هذه الفرصة، خاصة as a primary care teams ولا family medicine team ولا مسؤولين عن التحول، معناته فعلا الخلل فينا احنا كاشخاص وكما استفدنا من الفرصه هذه. في دعم على اعلى مستوى، فيها حماس، في دايركشن واضح. اتوقع في النهايه احنا if you fail this program معناته المشكله فينا مش في الدعم اللي كنا نطلبه. شكرا.
نقطة أخيرة ما ودي يعني أطيل. احنا دائما لما نتكلم عن continuity of care ونتكلم عن المستشفى، زملائنا ما يقصرون دائما. انا ابغى يعني لا نغفل شيء في الرعايه الاوليه، احنا community based وليس facility based. لما نتكلم دائما coordinating الناس اللي يجوا المستشفى ويتحولون، ترى هذول نسبه بسيطه في فئه كبيره من المجتمع اصلا ما تحتاج تروح المستشفى. فوي shouldn't ignore them. احنا في الرعايه الاوليه we have to reach them out. والناس الهيلثي ونعمل الانترفنشن ايرلي اون قبل انهم يصلوا لمرحله انهم لازم يتحولون للمستشفى. هذه لابد ان ننظرها. النقطه الثانيه we have to engage الكوميونتي، مثل ما احنا we have to engage الفاميلي physicians والناس اللي يعملوا في الفيرست لاينرز. ايضا community we should listen to them. They should be engaged من في البروسيس لصناعه القرار. وانا اعتقد طبيب الاسره الناجح هو ليس فقط اللي يستمع لشكوى المريض، بل ايضا الذي يستمع لقصته والذي يستمع لارائه عن الخدمه. واحنا دائما نتكلم عن الايديا والكونسيرن والاكسبكتيشنز، فاحنا we have to always engage الزملاء او الناس اللي احنا نقدم لهم خدمه. شكرا لكم.
يعطيكم العافيه عشان الوقت. يعطيكم العافيه، شكرا صراحه لحضوركم، شرفتونا الدكاتره يعني، والطرح اللي طرحتوه. واكيد انا متاكده ان في كثير من يعني في تشوق الان بعد اللي سمعوا منكم. لكن انا باسمي وباسم كل صراحه اطباء الاسره وبكل ثقه نقول yes we are eager للتشينج، واحنا ان شاء الله قد المسؤوليه. ولان احنا يمكن اكثر ناس محتكين في المرضى يعني وشايفين معاناتهم وودنا نسوي لهم شيء. فالجلسه هذه توجذر مع بعض باذن الله تكون فاتحه خير، يعني نحن نقدم حاجه للمجتمع تليق فيه باذن الله. واشكركم مره ثانيه، شكرا لكم. كمان الله.
Assalamu alaikum. It was very interesting session. I'm sorry for being late. We will come back at 1:15 inshallah. We have now the break for praying and lunch. The first floor.
check test. بسم الله الرحمن الرحيم.
السلام عليكم ورحمة الله وبركاته. أهلا وسهلا. Welcome back again. We will start our session with دكتورة أمل العوامي. She will talk about what is new about screening autism and diagnostic dilemma. دكتورة أمل is American board certified in developmental behavioral pediatric from Tufts Medical Center. Currently working as a consultant at Johns Hopkins Aramco Healthcare Center in Dhahran. Welcome, Dr. Amal.
Thank you so much for this introduction. Today we will be have goals. Again, the objectives of my talk will be to introduce the basis for the diagnosis of developmental disorder and discussing also the differential diagnosis of developmental delay presentations in the clinic, and to get more familiar with the details of the developmental and behavioral history taken, which is the bulk of my talk today, and eventually knowing the basic for autism, the management, and the role of the primary care physicians. So the first question, please be ready. The question number one. Choose what do you think the prevalence of developmental disability in the USA? Of course, we will start our own national survey soon, but we don't have really the studies in Saudi Arabia. But in the USA, what do you think the prevalence of all developmental disorder? Is it 5%, 10%, 18, or 22? All right, very good. We'll take 10 seconds. Perfect, perfect. Thank you so much for those who answer. It is 18%. It is really 1 in 6 children, and that include ADHD, autism, CB, intellectual disability, learning disability, blindness, hearing loss, and seizure and stuttering. All of these are considered developmental disorder. That is 1 in 6. So if you see a lot of children, you get to face 1 or 2 in your clinic on a weekly basis. So our case presentation today. So the main presentation is a 3-year-old girl who presented to the clinic with a speech delay and inattention. So she's a product of full-term induced delivery with a birth weight of 2.7 kg, Apgar 9 and 9 at 1 and 5 minutes. She was breastfed for 4 months with a mixed feeding after. She did fine with the solids. She was an irritable infant who cried for hours and was really hard to console. So she was noted to be behind in her speech in the past 1 year. The parents asked the physician and they were told she's too young, and they were assured that she will catch up. And this is the usual wait and see kind of attitude. Let's go into the details of her speech. I know that there is an assumption of a speech delay, but what's going on? In the receptive part, she responded to her name around 18 months. Usually now she responds 4 out of 10 times. She follows 1 to 2 steps order, but usually with gestures like go get the tissue and throw it in the trash. So there is gesture included in it. Expressive, her first word ever was at 20 months of age, but currently she could say 50 words. This is a 3-year-old, remember, with occasional 2-word sentences or phrases. Intelligibility, 50% of her talk is intelligible, but most of her talk is mature jargon, which means 1 word that you understand and the rest you don't understand. So you could see that she is really delayed in her speech development. For the gross motor, she sat at 7 months, walked by 13 months, currently can go up and down the stairs with alternative feet, so she's doing fine. And she is pushing on the floor with the tricycle, so she is not there yet riding the tricycle, but she is learning, she's only 3. With the fine motor, she has fisted pincer grip, and you could see the picture here. What does that mean? And she scribbles, but she is not able to do a circle yet, so she could do lines only. And she uses a spoon, but she is not using fork to feed herself. Social history, here comes the eye contact. Eye contact is not optimal. She needs to be reminded to look at the person that she's talked to. Joint attention is not consistent, really. And from the empathy, she understands emotions and she reacts sometimes to them, but sometimes she laughs when somebody is hurt. She likes other children, approaches them, and sometimes give them hugs, children that she doesn't know. So the level of activity, she is on the run, like driven by a motor, moves from one toy to another, fidget, and hard to play quietly. She is impulsive also. She doesn't recognize danger. She could just run in the street or get lost in the mall. And the level of attention is, she's inattentive most of the time and very distracted, especially when it comes to sound. Play therapy, or play development. As you could see that I am really emphasizing on taking detailed history to know exactly what's going on with this child. So she has a lot of sensory play. She's mouthing toys, she's throwing the toys. She likes active play like running or trampoline and swings. That's her favorite kind of play. She has some functional play. She knows what does it mean when she holds a ball. She tosses it to the other person, but she has very limited pretend play. Remember, pretend play starts at 18 months of age. Like, you know, you're cooking and you're feeding your doll, or the doll is sleepy and you put her in bed and so on. She likes her toys very neat and in a specific place, and she gets really upset if somebody moves them. There is no excessive lining up and there is no unusual play routine. Her emotion development, she has multiple temper tantrums during the day, and that is troublesome for the parents. And this temper tantrum can take more than 15 minutes at a time, more than 5 times a day, but she doesn't hurt herself or others, and usually provoked by if she's not getting her way or transition from one toy to another or one place to another. And screen time, as all 3 years old nowadays that we see, she spent 4 to 5 hours per day on screen, either TV or iPad. She has some sensory issues, and this is something I want you to get used to asking about, because some of these sensory problems are the reason why these kids are very hyperactive and inattentive. So she is scared of sound, and she screams and hides whenever she hears this sound, and she continues to be disorganized whenever a sound is loud. She has also some tactile problem. She doesn't like the sleeves to be short. She pulls the sleeves down on her hand. She struggles with water whenever it gets into her hair and face. So there's a lot of struggle during the bath time. And she was noted to pace, which means that she's running in the house for going and coming without really a purpose. Now, the daily life activity, we always like people to ask about and know the functionality of the child during the daily life activity. And one of them is sleep. How is this child sleeping? If you don't ask, people may not tell you. So that she has difficulty falling asleep. She takes more than 1 hour to sleep. She tosses and turns and she wants to jump and play. She has interrupted sleep. Then if she sleeps by 1 o'clock, she will wake up at 4. She wants to play and eat. And then she goes back to sleep and wake up at 10 a.m. So you could see that's interrupted sleep, and she takes nap very later in the day, like after sunset. Diet, she's a very picky eater. She likes chicken, nuggets, rice, fries, and pasta. What's the common thing between them? They're all beige or white. So she likes the white color food. She has pica, she eats tissues, she eats plastic. And of course, toilet training was not progressing nice. The mom tried, but it did not really go well. And she's not able to take off the t-shirt or take down or pull down the shorts, and she doesn't like brushing her teeth. How about family history and social history? Of course, we have more details asking the question, but I'm just giving you a glimpse of it, really. She has an older sister who's healthy, positive family history of ADHD and speech delay in multiple cousins. The mother was diagnosed with postpartum depression, but she was not treated during pregnancy or after delivery. And the social history, both of her parents, she lives with both of her parents within the extended family. They live upstairs where the rest of the family live downstairs, the grandparents. Parents are first degree cousins. So what are the physical examination parts? So we're done now with the history taken, and you could see how detailed the history, including the development and behavior, and of course the social and family history. But we don't see a lot on physical examination. This kid was on the 75th percentile height and weight, 95th percentile for her head circumference. She had mild hypotonia, and we always see that with hyperlax joint. No dysmorphic features. She has difficult transitioning from the waiting area to the exam room. She was very combative, throw a temper tantrum. She has very limited eye contact inside the room. She's moving from one toy to another, and she was not following instruction, even simple instruction like give me or put this in the box and so on. And she had multiple really temper tantrums during the stay in the clinic. There was no gesture noted. She was not pointing, and she was very self-directed. She was very quiet. There was no words heard. She was just humming some of these nursery rhymes that she was hearing on TV. No response to her name, being called several times by the examiner and by the parents. And she approached the examiner and sat in her lap, although the examiner is a stranger to her. Covered her ears when adult was talking loudly. You remember she has a sensory issues, and she smiled back to the examiner really when the examiner starts singing, "All McDonald has a farm." It's like my thing. I always sing for them. And then she was running back and forth in the exam room. She was really hard to, to contain in a way. So I didn't do any lab, I didn't do any imaging because really these are not indicated in cases of developmental disorder, not as at this time. So in summary, just let's capture what we just said in the past 10, 15 minutes. 3 years old girl, normal gross motor development, delayed speech and delayed fine motor, delayed social development and play skills, sensory sensitivity, hyperactive, inattentive, and impulsive. She has sleep dysfunction, picky eater, delayed daily life activity skill, and she is a slow to warm up temperament. Remember, in transition, she was combating, but later on, she got used to the place and she was moving and even approaching the examiner. So next question, which is the differential diagnosis. So the question says, choose the most likely diagnosis. That's question number 2. So let's wait for you to get some answers. Don't overthink it, just what you think you heard. I know that we're going to be talking about autism, so don't be biased here. Maybe I'm tricking you or something. يلا الحضور, what do you think? Okay. Autism, ADHD, I heard. Anything else? Okay. So I could see that mostly autism is winning with some attention, some social, and mixed also language. All right. So the real diagnosis, I will tell you now. First of all, most likely diagnosis is autism, but it's not the only one, right? You heard a lot of, that's why there is a lot of people who chose something else. You heard global developmental delay, which means they have a delay more than 2 domains. We heard a lot of symptoms of ADHD, right? You heard also mixed language. Obviously, that was the main reason she came, and some sensory issues. I think when somebody is touching the screen, okay. And some sensory processing. So now we will say, why do we have all of this? Can we have all of this really? We will know now. So what is the basis for diagnosis of autism? The basis of diagnosis, any developmental disorder is taken history, taken history, taken history. That's why we spend a lot of time into the details of the history. And then some behavioral observation, obviously, to confirm what you heard and fulfilling the criteria of diagnosis, whatever you think it is the most likely. So let's talk now about autism, because that's our main talk today. So to diagnose autism, you have to fulfill the criteria of either DSM-5 that was produced in 2013, or ICD-10 or 11 now, which is 2018. And they really combined almost the same idea. We have category A and category B. Category A is the social communication domains that you have deficit in reciprocal emotional interaction, which means there is no give and take. There is no non-verbal like pointing and respond to name and requesting. There is deficit in developing their actual relationship, like when they're playing, the kids when they're playing together, they know the rules, right? And if they don't know the rules, then there could be some difficulties. This is category A. You have to have 3 out of 3 to reach diagnosis. Category B is the stereotypical restrictive interest. You have to have 2 out of 4. You don't have to have them all. So it's either you have like ukulele or jumping or stereotypical movements or excessive adherence to ritual and routines, highly restricted interest, like they like only helicopters, they like only dinosaurs. or unusual sensory. It's either hyper or hyposensory issues. So we have to have 2 out of 4. So this is the criteria to diagnose autism, okay? So the guidelines usually for autism diagnosis is based on fulfilling these criteria. And if you are interested, I had the QR code of the European Society of Child and Adolescent Psychiatry. I really like the way they're presenting the way to diagnose and manage, and you could download it on your phone and read it later. Don't read it now. We're going to be talking more. All right, are you done with downloading it? Okay, very good. So DSM-5 autism diagnostic criteria doesn't only go onto the categories that we talk. We said that we have to have 3 out of 3, 2 out of 4, right? We discussed that and we know that. Now, the symptoms present in early development, it has to be there. You cannot like diagnose somebody at 20 years with autism while at the first 5 years of their life or 7 years of their life, they're doing fine, no problem. It just doesn't occur that way. Symptoms causing impairment, any developmental disorder, as well as psychiatry disorders, you have to have some impairment in their social or occupational, educational problem. And it's not better explained by intellectual disability or GDD. I know that they could come together, but it cannot be explained solely by it, okay? All right, so you have to specify after you reach the diagnosis if it is accompanied by intellectual disability, accompanied by language impairment and which type, accompanied by other neurodevelopmental like ADHD, GDD, or behavioral issues, with catatonia, which I have not seen yet, and and associated with any known medical or genetic problem. So you have to specify if these are present or not, or you are working on it. I mean, at the right time of the diagnosis, you may not have all of this information, right? But you have to work on it to reach a full diagnosis. I'm not going to be talking about the details of the severity, but a lot of people say, do we have mild, moderate, severe autism? There is nothing like that anymore. It is the level of intervention that we care about. Is it only requiring some support, requiring substantial support, or requiring very substantial support? And this is a lecture on its own. So, clinical diagnosis based on a clinical history. Developmental and behavioral observation is very important to know the symptomatology and to fulfill the criteria. Evaluating language and developmental level. Physical and sensory exam is very important, hearing and vision, to make sure that we don't have a problem. Assessment of emotional and behavioral difficulties. Information of socio-environmental factors and impairment, if there is any, in the social and education. And eventually we do CARS, which is childhood at autism rating scale, if you would like to. And this is something we could talk about at any time after the lecture if you want to ask more about it. Or we do the gold standard for the diagnosis, which is the ADOS. ADOS is an autism diagnostic observational schedule. It's a play-based kind of evaluation, and I could explain it to you later. So I'm just going to emphasize history observation is the most important. Testing, if need to, ADOS or CARS. Obviously, we do IQ eventually, WISC for verbal, and LITER or TONY for nonverbal. Vineland adaptive is very important. Please bear with me as long as some of the terminologies, I'm sure some of you just heard today, but I am there after the sessions to answer any question. Of course, we're going to do speech and OT evaluation. Other testing, vision and hearing is very important. We don't need EEG, we don't need MRI, and usually lab is not recommended unless you see something on the exam, neurological examination or something in the heart or dysmorphism, then we need to do more. So what are the other associated disorder that comes with autism? As we mentioned, they could have seizures, GI symptoms, some sleep disturbance, and we find that in our case. Genetic, Fragile X, or tuberous sclerosis that can be associated. Some psych, which is ADHD, that we found in our kid that they have symptoms of it. OCD, depression, and anxiety always is there. And also intellectual disability and language disorder. It's all can be associated with the diagnosis of autism. So question number 3. The American Academy of Pediatrics recommend routine screening for autism at which age? Can we have question number 3, please? Gonna get only 10 seconds because I'm running out of time. Yay, good. All right, for the sake of time, I guess we're going to go ahead and give the answer. It is really the B and C. You do it at 18 and 24. This is the recommended time. You got to do screener development at any visit. But for the autism, it is only at 18 and 24. And here are a list of evaluation. Can we remove the question, please? The list of other evaluation that you could do to screen. The main one is MChat. And you could see here, the MChat is there, QR code if somebody wants to download it. This is 20 questions, very quick to answer, very quick to score. And this is like the usual screener for these kids. Management, I'm just gonna go over it quickly. General intervention, we do balanced diet, sleep, rules and routines in the house. Hearing and vision, of course, we have to do these. Referral, which we have to do a full evaluation of the child, like speech evaluation, OT, behavioral evaluation, and IQ testing. Social worker has to be involved to take care of the family and the social aspect. Genetic and neurology, if need to. Of course, don't forget about the academic and school accommodation. Usually there is no medication and there is no special diet. Lastly, I think we have only 2 slides to go. So the journey of autism diagnosis, we reach the diagnosis level at the start and what kind of intervention needed, search for comorbidities, and then indicate the strengths and weaknesses of the child. Informing the parents and supporting them is very important. And this is just a scheme. If you find somebody with developmental disorder or developmental delay that you check in the clinic, please do MChat. If it's negative, then it's fine. If it's positive, we need to do full evaluation. CARS can be done by anybody, including the parents themselves. Do vision and hearing, language evaluation, clinical full evaluation, and usual referral to reach the full diagnosis. So what is the rules of our primary care? Educate yourself and being here and being present to understand more about developmental disorder is the first step. And screen all the children who has developmental in each visit. Screen all the development of each child in each visit. Do the autism at 18 and 24. Refer to speech and OT, even without diagnosis, ladies and gentlemen, please refer them to intervention before reaching the diagnosis because early intervention is needed. And of course, if you suspect autism in particular, there are the 3 specialists who can do the full diagnosis. Please support the family, find resources, guide them where to find the resources. So autism diagnosis is confused with other developmental disorder. Autism diagnosis can be present with other developmental disorder. Autism diagnosis based mainly on clinical history and observation. Diagnosis should be based on DSM-5 and ICD-11 criteria. A well-experienced clinician can reach the diagnosis, but full evaluation needs a multidisciplinary team. So these are the resources that you could provide to the parents. And this is our resources, Arabic one, and this is resources for my talk. Thank you so much.
Thank you, Dr. Amal. The question will be at the end. Now we'll have Dr. Saleh Al-Nas, family medicine consultant and diabetologist, to talk about GLP-1. Welcome, Dr. Saleh.
Assalamu alaikum, Jamia. Thank you for the nice introduction. My talk will be about GLP-1 receptor agonist for people with type 2 diabetes. I'm talking on behalf of Lily, and this is my disclosure. Okay, this is a 54-year-old man with type 2 diabetes for 12 years. He's having occasional nocturnal hypoglycemia. Also, he is having hypertension and hyperlipidemia. His brother and father having myocardial infarction. He's currently a smoker. And this is the physical examination. He's weighing 120 kg and his calculated BMI 45 and his blood pressure 136/82. He's maintained on 2 oral glucose lowering agents, metformin and empagliflozin, and 1 injectable basal insulin, 80 units once daily. Also on atorvastatin 20 milligram, prindopril 5 milligram. Laboratory profiles, the total cholesterol 243 milligram per deciliter, and the calculated LDL 164, and the HDL 34 milligram deciliter. His fasting plasma glucose 130 milligram per deciliter, and the A1C 8%. Okay, so to summarize, and all you know that we should go patient-centered approach to discuss the concern with our patient. So he is obese with 12 years duration of type 2 diabetes. He's also having hypertension, hyperlipidemia, and he's currently active smoker. So exploring his idea and concern, going patient-centered approach, we decide with the patient together the agreement goals. So we determined the ASCVD risk, and we agreed upon a target of A1C less than 7 to be achieved with the patient, and to reduce the weight at least 5% of his baseline weight, to decrease the blood pressure to the target of less than 130/80, and to lower the LDL less than 100 milligram per deciliter, and to avoid hypoglycemia, and to counsel him for stopping smoking. Okay, so back to our patient. He's having type 2 diabetes, hypertension, currently smoking with persistent LDL. So this is from the ACC guidelines. It's recommended if you want to decide your patient to be intensified with the statin treatment to calculate his risk factors. Okay, we calculated the risk of having ASCVD within 10 years. It's high, above 20%. He's carrying 37.8% of having cardiovascular disease. So all you agree that this patient having cardiovascular risk factors. Always go back to lifestyle therapy. We should always reinforce lifestyle therapy. We have the obesity and we have the smoking status. The smoking status is the one equated in the ACC equation, but you have to reinforce all the modifiable risk factors. The obesity, he at least need to lose 5%. 5% of his weight equals to 6 kg. And also to counsel for smoking cessation, and to advise the patient for physical activity, minimum 150 minutes per week, and to substitute, and this is the ADA recommendation, to avoid the refined carbohydrates. So we agree with the patient to stop or to cut rice, to be substituted with lentils, and to cut the white bread. Of course, omitting all carbohydrate is not recommended because some carbohydrates are beneficial, fibers and minerals and vitamins. So what we did with our patient, we cut the white rice and white bread. Back to the equation. So this patient having high risk above 20%, he's on moderate statin, 20 milligram. So which one is high statin? He of course needs to escalate it to high statin. Rosuvastatin 10 milligram, this is moderate statin. So we go with atorvastatin 40 milligram. About the glycemic management, he is on 2 oral medication plus 1 injectable basal insulin. Which one we'll decide with our patient to go with? Is it sitagliptin, a glycolazide, sulfonylurea, GLP-1 receptor agonist, dulaglutide, or to go with basal bolus? So remember that we are aiming to lower the A1C less than 7%, and also to prevent the common or the leading cause of mortality in people with type 2 diabetes, which is cardiovascular disease. So this would affect our choices for intensifying the glycemic management. So I need an agent which has been proven by evidence that lowering the risk of cardiovascular disease. And this is the typical for primary care settings. We have patient not yet established cardiovascular disease, but he is having high risk for having cardiovascular disease. So from the evidence, we have what's called the rewind trial. 2/3 of the study subjects in this trials, the RCT trials, 2/3 of them, they have cardiovascular risk, not yet established cardiovascular disease. And from this RCT trials, dulaglutide reduced the major adverse cardiovascular event by 12%. Upon that, the ADA in 2019, they update their ADA guidelines, and they stated that the level of evidence to support the use of GLP-1 receptor agonist for primary prevention is strongest for dulaglutide. So we counseled the patient that dulaglutide has a weight loss benefit, highly effective at lowering A1C, and the level of evidence to support the use of GLP-1 receptor for primary prevention, those who not yet established a cardiovascular disease, is strongest for dulaglutide. So before deciding about the GLP-1 receptor agonist, make sure that patient doesn't have contraindication for the use of GLP-1 receptor agonist. Hypothyroidism is not a contraindication. The only contraindication about thyroid disease is the MTC, or medullary thyroid carcinoma, or multiple endocrine neoplasia. Pancreatitis, personal history of pancreatitis, previous history of pancreatitis, this is contraindication. CKD or MI, it's not contraindication. So the starting dose, 1.5 milligram. We should counsel the patient about the possible common GI upsets and how to mitigate the risk of GI upset, to eat smaller meals, stop eating greasy, fatty, large meals, and avoiding fried foods, okay, to mitigate the risk of GI upsets. So do all the GLP-1 receptor agonists have the same administration? No. The shortest one to be administered is the dulaglutides, only 3 steps: uncap, twist and unlock, then press and hold. So we made a joint decision with our patient after discussing the treatment objectives, and we initiate low carb diet for this patient, and we initiate moderate intensity exercise 150 minutes per week. We counsel him for smoking cessation, and upon reviewing that his age above 50 and he's having hypertension, dyslipidemia, obese, and he has no risk of bleeding, after considering the patient willingness, we added aspirin, we intensify statin to 40 milligram atorvastatin, and the hypertension treatment also intensified, and we started dulaglutide 1.5 milligram once weekly. And we teach the patient how to inject it in the office. Then regular follow-up was given for the patient every 2 to 3 months. And he was also referred to health coach to reinforce the lifestyle therapy. After 15 months, patient adhered to the low carb diet, to the moderate physical activity. We able to cut his basal insulin from 80 units to 36 units. And the dulaglutides well tolerated, 1.5 milligram once weekly. We kept the 2 oral glucose lowering agent, the metformin, the empagliflozin, and the prindopril was increased to 10, the atorvastatin to 40 milligram, and aspirin. He quit smoking, no further hypoglycemia. He dropped weight from 120 kg to 82 kg after 15 months. His blood pressure to the target, less than 130/80, his A1C to the target, and his LDL reached 98. So we recalculate his ASCVD risk, dropped from 38 to 11.4, which is intermediate risk. And by this, I reach the end of the talk. Thank you.
Thank you, Dr. Saleh, for this nice presentation. Now we will have Dr. Ahmed Al-Alma'i will talk about management of depression in adolescent. Dr. Ahmed is have diploma of child health and 2 American board certification in general and child psychiatry. He is now working as in John Hopkins Aramco Hospital, Dhahran. Thank you. Welcome, Dr. Ahmed.
Doctor, thank you for the kind introduction. I do want to say thank you to the organizers, Dr. Nazir Khatam, Dr. Nada Bunayan, and everybody who's been involved with this conference. You've done a wonderful job. Thank you very much. I'm very honored to be with you here. So I will talk a little bit about depression or management of depression in adolescents. I will talk about practical aspects. Then I'll have a few questions to cover. So bear with me at the beginning. It's not going to be strictly question and answers style presentation. Do I have about, is it 25 minutes, editor? Thank you. All right. So, yeah. I do have my first slide is with the template. Sorry, sometimes I could be technically challenged. So the rest of my slides will be my own without using the conference template. So I'll start with, do I have, yeah, I have it right here. I'll talk about depression. Since we're talking about depression here, I'll talk about the Saudi Arabian National Mental Health Survey, which was published in 2020. And this survey shows, and this focuses on adults, but in general, it shows about 9% lifetime prevalence of depression in females and about 3% prevalence in males. So females tend to have 3 times more of the depression, prevalence of depression than do males. Now, how do we, and again, I will focus on practical aspects and then come to a few questions. But how do we diagnose depression? Now, the way to diagnose depression, obviously we use the DSM-5 text review criteria, right? So we have the 9 criteria and we have to have, I'm not going to go into that in details, but we have 9 criteria and we need to have 5 out of the 9 criteria to diagnose depression. Okay, it's the same for adults, the same thing for adolescents. There's no difference, even the same thing for children. There's no difference in the criteria. Now, there are different other ways to diagnose depression. And one of them is the scales that we use. Some of them is structured, which means clinician administered scales. Some of them could be done by the patient. Now, some of the ones that are administered by clinician include things like Hamilton, and there's a few others, but I'm not going to go into that. Now, and some of those are self-administered, mean the patient can do themselves. Sheehan, Big Depression Inventory, Zhang Depression Scale, PHQ-9 can help you about their mood symptoms. The problems many times with even the ones that are administered by physicians, clinicians, or the patient themselves is, you know, the question answers is something you have to check. You don't always have an accurate picture of what the patient tells you. Sometimes they don't understand the questions. A lot of times, my colleague here, Dr. Amal, did a wonderful job with their presentation. We get a lot of referrals, and you know, from primary care physicians, family physicians. I'm speaking to a lot of you here, family physicians. You do the MChat, and you get the scores. You get referred to myself or Dr. Amal. And a lot of times, it's not necessary. So this scale tends to be very sensitive, and we get a lot of false positives as a result of that. So my advice to you, when you do don't rely just on the scale. Please look further, ask questions, find out more about the symptoms about the patient, whether what the patient answered on the questions matches what you see in your clinic. Okay, so that's really important. A differential diagnosis for depression, there's a lot. So this patient could be going through some adjustments, changes in his life, bereavement, grief. He just lost his mother, his father, somebody else that they could look, symptoms could look very similar to depression. And there's a lot of medical conditions that can look like depression. For instance, hypothyroidism. A lot of patients with hypothyroidism, which you're going to see in your clinic, can present with depression. The good news is once you treat the hypothyroidism, a lot of the depressive symptoms do go away. Okay, myocardium, a lot of patients with myocardial infarctions, CVAs, in particular, front left loop. When they have stroke in the front left loop, they can present the depression is very common in these situations. Cancer, systemic lupus, HIV patients, a lot of them. Chronic fatigue syndromes, a lot of them are treated with antidepressant. They could look like depression. Many medications that you prescribe and psychiatrists prescribe can cause depression. Steroids are very common. Steroids can cause anything, okay? Anything from depression all the way to psychosis. So be careful when you treat these patients, especially with very high doses of steroids. And then finally, vitamin deficiency. We're in Saudi Arabia, okay? Vitamin D deficiency, again, can cause a variety of symptoms. Depression, anything. So be careful. And people don't go out in the sun. It's very hot. They don't go out in the sun. So be sure that patients don't have vitamin D deficiency. What is the easiest way to treat it? Go out in the sun. Okay. Differential diagnosis when it comes to psychiatric conditions is your bipolar. Be careful, and I'm saying this, please remember this. A lot of patients who might present to you in your clinic with depressive symptoms, they could be depression or could be bipolar depression. They're presenting to you with a depressive phase of bipolar. You prescribe antidepressant medications, what happens? They become manic. They might commit suicide in that manic phase. So be careful when you do that. Please take careful history. Back, and I tell all my residents, take careful history from the patients, make sure family history, patient history, make sure that you get at least the basics when you treat the patients. Then anxiety disorders, ADHD, externalizing disorders, life events, all of that, personality disorders, borderline personality disorder, for instance, they have quick highs and lows. They could present to you in your clinic with the very lows, and you think they might be depressed. Well, they could be borderline. They're not necessarily and then depressed. And then finally, the premenstrual dysphoric disorder. Now, females, they get depressive symptoms around their periods, and then it goes away. So something that you need to keep in mind. And some of my talk, some of the stuff I'm going to cover here, some of the symptoms, but then I'll complement my talk with some of the questions that I going to present at the end. Now, what is the clinical course of depression and teenagers? Now, the median course is usually between 7 to 9 months, okay? So now, regardless of what happened, this is what they go, it's about 7 to 9 months. Now, there are sometimes when the symptoms can be very severe. What can predict severity? You know, I'm sorry, the duration of the disorder. Predictors of the duration is symptom severity. So if they have psychotic symptoms, so some of these patients in the height of their depressive symptoms, they can present with psychotic symptoms. They usually called mood congruent, means they go along with the mood symptoms, okay? They think that they're going to die, they have cancer, they have some kind of other major medical illness, things like guilt, a lot of things to do with that. So in other words, it's mood congruent, goes along with the mood symptoms. Then they might have other psychiatric disorders, parental disorders, if they, you know, we're talking about teenagers here, and if they have poor psychosocial skills of functioning, those can predict longer duration. Now, 90% of adolescents with depressive episode, they can remit in 1 or 2 years, whether you treat them or not, they're going to come to a remission. Well, if you didn't prescribe treatment for them, they're going to suffer for 1 or 2 years. You prescribe treatment, obviously it's going to take much shorter duration. Now, about 50% of those adolescents will have a relapse, depending on many factors. I'm not going to go into that now, but just to compare that to adults, you know, as a rule of thumb, we say adults, if they have 1 episode of depression, they have about 25% chance that they're going to have another episode. The episode we just talked about now, 7 to 9 months. If they had 2 episodes of depression, that percentage goes up to 50%. And then if they have 3 episodes of depression, they're going to have a 75% or higher chance of getting a 3rd episode of depression. Now, if they have 3 episodes, they probably need to be in medication for the rest of their lives because they obviously need the antidepressant medication. Now, 6 to 10% of people with depression, they can have prolonged course of depression. Relapse, or do people relapse in depression? You bet, they do. So there's about 40 to 60%. Again, I'm talking about adolescents. I'm not talking about adults here. About 40 to 60% of adolescents will experience relapse after successful treatment. Now, predictors of relapse, the natural course of an illness if they had prior episodes, the lack of medication compliance, and that's probably the most common cause. People just don't take medication. They take medication at the beginning, then they feel better, and then they stop, and then they relapse. This is probably the most common cause for relapse. And then discontinuation of therapeutic treatment. So we need to talk about how long do we need to keep the treatment. And then finally here, keep an eye on bipolar. Okay, when you treat depression, please make sure you have asked if they had history of manic symptoms in the past. There is another issue which is very important, and I thought I'll mention it here. This is the topic of our research now, ongoing research about psychiatric manifestations of corona pandemic, COVID-19. And since all of you know, this is part of the proposal that we've done, and many of you know that this is we're going through special times now. I've seen patients in my clinic that I never thought they would show up in my clinic. Why? Because a lot of people have been in quarantine during the corona pandemic. And many of them, if they had probably mild symptoms, they could manage. They have with family support and many things, they couldn't do that anymore. We talk about social distancing. People don't mix. People don't see each other. And we encourage people to use social media to communicate. Now, all of these, and then the scare and the anxiety that people have during the corona pandemic. Now, I remember I volunteered at Johns Hopkins and what they call the COVID-19 call center. I was I was another psychiatrist. And we get information about the COVID-19. And in the COVID-19 call center, we get calls from families, we get calls from providers in remote areas. And we were considered the center where we give the information. So we get the information somewhere, then pass it out. We give people instructions about quarantine, social distancing, sick leaves, all of that from the COVID-19. And what happened was we didn't have, all of you didn't have a lot of information about COVID-19. What happens is we get one information today, then it changes tomorrow. Like for the quarantine, if you've been mixing with somebody who has the COVID-19, how long should you keep away? How many times should you repeat the test? So, and that was very confusing, not only to people, providers, but to us as well at the COVID-19. So there was a lot of vague information, and many of the studies were published on that issue. There was a long period of, like I mentioned here, is quarantine, enforced quarantine people that they had, and that by itself can cause, and this is not limited to the COVID-19, but in history, if you look at the history of pandemics, it's the same thing. Mass hysteria tends to happen during these periods. Anxiety and distress can happen during these periods. Now, what made things worse is a lot of people lost their jobs during the COVID-19, and that caused significant impacts, psychiatric distress. Now, cases of suspected COVID-19 may also suffer from anxiety, symptoms of OCD. I don't know how many of you were washing their hands excessively, but I know from the start, and my hands are quite dry, but I used to wash a lot, and I still do, okay? And many people were scared. Like, I remember my family, my sisters and brothers, they were spraying everything that comes from outside the house. And a lot of people were doing that. They're doing excessively, they're overdoing it. So that's really a big issue. Coronavirus have been associated with the onset of mood disorders, including PTSD, mood disorders, depression, and even psychosis. Cases of psychosis, even the scares, not just, you don't have to be infected with the virus, but even have family or worried about it, or being, contained in a house where you didn't go out. Now, with the widespread of vaccination, we still have a percentage of people, especially the elderly, who did not get the vaccine and still very scared to get the vaccine. That's still an issue. Children in particular have higher risk to experience depression and anxiety as well. Now, I'll talk about medication. I'm not going to go into details about the medication, but the focus, the primary target of medications is 3 neurotransmitters, okay? ما يشتغل هذا في pointer. Hold it. Okay. هذا يحرك اسمه. Anyways, so there is here's the synaptic end. If you see it here, it's not pointer. There's no red pointer. ها ما في. Okay. Thank you. All right, so this is the synaptic membrane here. And what we do, what is the mechanism, if you think of it, mechanisms of action for many antidepressants is they keep the neurotransmitters here, 3 main neurotransmitters, serotonin, dopamine, and norepinephrine. There's other neurotransmitters that are being implicated. They're working on it in research, but these are the 3 main neurotransmitters involved or targeted with antidepressants, okay? SSRIs, SNRIs, and then others, non-specific. Now, one thing I want to keep in mind, want you to keep in mind, which is placebo effect. There's about 1/3 of patients who will have response to placebo. Now, I remember when we're doing clinical research trials, what we do is give patients placebo and see them in 2 weeks. There's about 30% of patients who will show up, I feel great, doctor, I don't have depression anymore. And those are the type of patients who will exclude from clinical trials, and then everyone else will continue with the clinical trial. Why? Because the people with placebo effect will affect your results. You're not going to go who's responding to what. Usually, those who respond to placebo effect will have recurrence of depressive symptoms after 2 weeks or within a month, and the symptoms will come back, okay? So this is how we proceed. Now, this is very true when you come to younger population, adolescents, okay? These are the list of medications I'm sure many of you are familiar with. SSRIs, and then you have SNRIs. I'm not going to go into details, but the difference between these ones, the target of these ones is the serotonin. The target of this class of medication is both serotonin, norepinephrine. Now, we use venlafaxine, and there is here, this venlafaxine is longer acting, could be done used once a day, so it's the same with this one. The one good thing about this medication is that a specific indication is SNRIs can be very helpful with management of pain, long-term, mild to moderate chronic pains. So chronic fatigue, patients who suffer from chronic back pains, headaches, these medications, SNRIs can be very helpful as compared to the SSRIs. There are other antidepressants like bupropion. Bupropion is a good medication to use in situations like just about most of the SSRIs can cause sexual dysfunction. So ask your patient if they're married, ask them, is their sexual marital relationship has been affected by the medication? And if yes, this could be one good medication to use. It doesn't, and it doesn't cause weight gain. Having said that, this is not a good medication for patients who have a lot of anxiety symptoms. Bupropion is not. One other good indication for this medication is it is considered as a 3rd or 4th line for people with attention problems, ADD, who didn't respond to the stimulants, non-stimulants. So this could be the next choice of medication to use with these patients. So these are a few tips to think about when prescribing these antidepressants. Mirtazapine is a good antidepressant. If you think of it as mild to moderate antidepressant, it is good. It helps sleep, which is not simple, so it's very good medication. Problem with it is a lot of females will gain a lot of weight with this medication. So it may not be the best medication, but unless the patient has a problem with appetite, especially your elderly. The other good use or indication for this medication is your elderly patients. the CYP450 system. It's not involved, affected so much. So the medication to medication interaction is very minimal. This is why you will see a psychiatrist prescribing this medication a lot to elderly. Tricyclics. Does anybody here use tricyclics antidepressant? Anyone? I don't remember the last time prescribed anticyclics. But why don't we use them? Cardiac toxicity. So patients who are suicidal and they take overdose on SSRIs, they need about 1 kilogram of SSRIs to die. They need a few pills of tricyclics and they die. They get cardiac, if they get asystole, ventricular tachycardia. They don't last much. Okay, I'm not going to have a lot of time for my questions, but cardiac QT prolongations. Do we use benzos for young people? Not really much. We don't. We like. This is sort of a quick algorithm. When you prescribe antidepressant medications, you start fluoxetine, other SSRIs, TCAs, really rarely do we use prescribe. This is, you could, some augmentation mechanism that you could use. Patients who don't respond, you can augment your antidepressant treatment with antipsychotics, lithium, and some other occasions you might add another antidepressant, like you could use SSRI with a Wellbutrin, and then thyroxine, thyroid hormones can also be used for augmentation. Currently, FDA approved for adolescents too, fluoxetine and escitalopram. And I thought the Eli Lilly representative would like this one. Fluoxetine actually still has been, for the longest time, FDA approved for young people, Prozac. Suicide, something you need to keep in mind. There's a higher rate, it's controversial also, but something you need to keep an eye on. There is guidelines when you prescribe antidepressant to someone who's depressed, that for the first 4 weeks, you need to see them weekly. Now, you don't have to do that yourself. This is why it's always good to work with a therapist. So somebody has to see that patient weekly, because patients, what happens usually is they have suicidal thoughts, but they don't have the energy to act on it. Once you give them antidepressants, they feel better, they have the energy, and they might actually commit suicide during that period of time. So first 4 weeks, once a week. After that, every 2 weeks, and then after that, every 12 weeks. ECT used rarely, but it is probably the most effective and depression treatment, especially with severe cases. You do have a list of dietary supplements that can be very effective, SAMe, St. John's. By the way, before I forget, I put a handout which everybody can download. I was told from the MChat. It's about, I put together a short list of psychotropic medications commonly used with common side effects and doses. So those of you can interested can download it. And don't forget psychotherapy. It's always very helpful, very supportive. So there's different kinds of psychotherapy that we can give to patients. I personally, I trained with the CBT, cognitive behavior therapy, one of the most effective ways to treat depression, along with medications if needed. Take-home message: pediatric depression start with CBT, then you might consider medications. You don't start with medication with the young people always. And maybe you have time for 1 or 2 questions. I did promise to put in some questions here, but and I'll read these questions out loud for people. I'm sorry, I'm rushing through this, but I do have a lot of materials. But this is a 17-year-old female who come to psychiatry for history of anger, irritability, which occurs on a monthly basis on average. During this time, the patient also reports feeling anxious, is about to explode, which alternates rapidly with crying spells and angry outbursts. The patient notes that during this time, she can't concentrate, she can't sleep very well, she can sleep more than a few hours. She needs to she usually needs to do. During several days, these symptoms last. Patient must skip most of the classes because of she can't function during that time. And these are the choices. Any volunteers? And I know we have a bunch of people online. I hope they're following this. I'm going to leave it for just a few more seconds so people can read it. and maybe we can get an answer to this. Any thoughts here from audience? Thank you. It is. So symptoms very typical, right? Few days before, right? Few days, usually before your period. Okay, I think we might have time for another question, Doctor. Okay, question 2. 16-year-old female comes to the physician with a chief complaint of depressed mood. The patient states that she has anhedonia, lack of interest, which is anergia, 10 pounds weight loss in the last 3 weeks. And ايش هذا؟ السكرين عندي بدأت تتغير. 3 weeks. She states she doesn't care about anything anymore. She also admits to having suicidal ideation without intent or plan. Which one of these, and we're talking about physiology changes during depressive symptoms. Do they have physiological changes? Yes, they do. So which one of these choices do you think the patient has when they're depressed? They have decreased hypothalamic pituitary adrenal. So in other words, corticosteroids hormones in their body, are they increased or decreased during that? Is it a period of stress when they have the depression? Yes. So what happens during periods of stress? Steroids go up. Okay. Now, next one here, they have increased lymphocytic proliferation in response to mitogens. In other words, increase in WBCs. When people are depressed, do you have increased immune reaction or decreased? Decrease. When people are depressed, they have decreased immune. So there's a lot of research on inflammation and depression and mood symptoms. Now, 3, decreased core body temperature during sleep. What happens when we go to sleep? Everything goes down, huh? All body functions go down. So what happens? When we don't sleep well, what happens? Do we keep the same temperature? Does it go down? Does it go higher? Now, an increased phasic REM sleep. REM sleep is essentially what? Super light sleep. There's an increase or decreased? Says increased here. So to feel you slept well, refreshed, you have to get into deep sleep, right? Do they get much deep sleep? No. Okay. And then the last one here is increased anterior brain metabolism. Is the brain metabolism increased or decreased in the frontal lobe? Usually decreased in depressed patients. Okay. And this is not moving. ايش في هذا؟ زعل علينا. لا. So, okay. So increased phasic, this is the correct answer. REM sleep is increased while somebody's depressed. So when they look at this sleep pattern, do we have time for more question or that's it? Okay, I'll stop here. Thank you for listening. Thank you for being us. And thank you again for the organizers for inviting me to speak. Thank you.
Thank you, Dr. Ahmed, for your talk about a very important topic. It is our pleasure to invite Dr. Mohammed Al-Mgahoui to talk about substance abuse screening in adolescent. Dr. Mohammed is a psychiatric consultant at the Addiction Unit, Irada Complex for Mental Health Hospital, Dammam, and head of Addiction Unit, also Vice President of Addiction Division in Saudi Psychiatric Association. Welcome, Dr. Mohammed. The floor of yours.
السلام عليكم. التصفيق ما كان حار، شكلكم فيكم النوم الظاهر. ايوه كذا كل واحد صحصح. طيب السلام عليكم. بداية اشكر الزملاء المنظمين في اكاديمية طب الاسرة على هذه الدعوة وهذا التنظيم، واشكر كذلك اخص بالشكر الدكتورة نزيه الخاتم والدكتورة نادر بنيان على الدعوة وهذا التنظيم. محاضرتي بكم ميكس عربي انجليزي حتى تصحصحون بعد الظهر، الناس نايمة. طبعا موضوع الادكشن من المواضيع يعني حقيقة غير محببة حتى للسايكاتريست ترى. فيعني ذاك طريقة المحاضرة بتكون مختلفة تماما. ستكون 2 كيس سيناريو. ما في معلومات كثيرة knowledge wise حكم المعلومات موجودة في الكتب. أنا هدفي من المحاضرة هذه إن الفاميلي فيزيشن أو الفيزيشن بشكل عام لما يسمع الهستوري هذا الان راح اقوله وراح افصل فيه، يكون عنده تصور كيف او شيء وش المعلومات اللي احتاج اني اخذها من المراجع او المريض، وكيف ارتب المعلومات وكيف الملم المعلومات هذه، كيف ما هو الفحوصات اللي ممكن اسويها وما هي التدخلات اللي ممكن اعملها. طيب نبدا على بركه الله، بسم الله. طيب the objective is to be aware of the most common substance used by adolescents, to be able to diagnose substance use disorder in adolescent, to differentiate between addiction problems between adolescent and adult, to manage addiction problem in adolescent. من خلال السيناريوهات اللي راح نتكلم عنها، بعض الاحصاءات او بعض الابيديميولوجي. adolescent abuse a wide range of substance، في مواد كثير. ربما انا راح اتكلم من واقع عملي. اكثر مواد ممكن نشوفها في الادولسنت موضوع اللي هو الفولاتايل سبستانس، very common because it's very cheap and it is available everywhere. يعني ممتاز. طبعا حسب بعض الاحصائيات، ما عندنا احصائيات محليه لكن بعض الاحصائيات الموجوده 20% of adolescents aged from 13 to 14 years worldwide have tried illicit drugs. About 30% of 15 to 16 all adolescents have used illicit drugs. The most common substance used by adolescents tobacco, alcohol, marijuana. وهذا اللي نشوفها كثير جدا. يعني الان مساله بالذات الحشيش، اصلا في بعض التصورات المغلوطه ان الحشيش انه ليس ماده ادمانيه ويمكن استخدامها وممكن تفيدك بدون ما تدمن عليها، وهذا من المفاهيم الخاطئه. One of 5 adolescents has used marijuana or hashish. Approximately 1/3 of adolescents have used cigarettes by age of 17 years. Alcohol use among adolescents in the United States have shown to be that by 13 years age, 1/3 of boys and 1/4 by girls. انتقل الآن لزبدة المحاضرة. I will talk about 2 case scenario, and at the end of this case scenario, I wanted to ask you about differential diagnosis. Please focus with me. First case، ما عليكم الكلام كثير لكنه راح ألخص بيكون إن شاء الله سهل وواضح. 14 years old male adolescent patient come to our clinic with his parents. His parents report a change in their son since 1 year, and he has started to be aggressive to them and his older brother. He stayed out overnight multiple times in the past year as he doesn't like to be at home because his mother tried to tell him what to do. His teacher observed deterioration in his academic level and increase in his absence from school. After 2 months, they noticed the increased spending money and began stealing money from his father. Even their neighbor suspected that he stole from them. حتى الجيران بدوا يلاحظون بدأ يسرق بعض الشغلات منهم. He preferred to start fighting with others. بدأ يخلق مشاكل، يدخل في هوشات مع أصحابه وزملائه. His father stated that he lies constantly, sometimes for no apparent reason. When he was in grade 1 at school, he had attention problems. ركزوا الآن شوي. Silly mistake and didn't prefer activity that needs sustained attention. Also, he lost his book bag, and other important things. His teacher reported that he's talkative excessively, didn't wait for his turn to answer or complete the questions. He engaged himself in high-risk situation and didn't able to be calm most of the time. He was evaluated by a child psychiatrist, Dr. Ahmed, and was diagnosed with ADHD, and methylphenidate was prescribed for him. But the family didn't continue with the treatment, and he's currently on no medication. When he was 7 years old, his parents had multiple quarrels and separated once before. Most quarrel because his father abused cannabis and alcohol. Firstly, he abused them outside home, but in the past year, he occasionally abused them at home. 3 years ago, his parents found that he returned home, he had red eye, moved and spoke slowly with spontaneous laughing. They suspect drug abuse and came for us for evaluation. On examination, patient initially refused to answer question and turn away, but gradually began to talk. هذه يمكن نقطة مهمة ودي أركز عليها. أحيانا خاصة في الهستوري، ربما الزملاء اللي كانوا يمرون يأتون المجمع الأمل فترة التدريب، قد يكون التحدي انك كيف الحصول على المعلومه وكيف تخرج المعلومه. ففي تكنيك اللي هي انترفيو سكيل، الموتيفيشن انترفيو، في تكنيك بحيث انها تساعد الشخص كيف اني اطلع له سري. ممكن بكل سهوله بساطه اقول له تتعاطى، يقول لي لا. جربت ماده، يقول لي لا. لكن من خلال الجلوس معاهم والحوار بشكل جيد ممكن ابدا اخليه يتكلم واطلع المعلومات التي اعتقد انها تفيدنا. نقطه اخرى، ما في احد مستثنى من موضوع السؤال عن الدراجز او السبستنس. احيانا نركز مثلا عن الدبريشن، مثلا يسال عن الدبريشن ويسال عن الانكزايتي ونسال عن الاو سي دي ونسال. احيانا قد يكون نتحرج نسال عن اذا يتعاطى ماده او يستخدم ماده. في طريقه احيانا كذا مسجله، هذا ريكورد من وراء تريلات كذا، تجيب سؤال مثلا: هل في احد من زملائك او تعرف احد من زملائك يتعاطى؟ هذه احيانا تستخدم حتى في بعض الكويستشنير. الاسئله المباشره احيانا قد ما يجاوبون عليها، لكن لما نقول والله احد من زملائك، احد في الفصل يتعاطى، وممكن من خلاله نبدا نصل الى عرضت عليك الماده، جربت الماده، شفت الماده، يبدا يتكلم. هذه من التكنيك اللي ممكن تستخدم مع الادولسنت. he present a tough image with indifferent attitude toward the interviewer، يعني ما كان مره مرتاح. المهم بعد ذلك he confirmed substance abuse since 3 years and he start شابو اللي هي مثال الميثامفيتامين. He started to use shabu under his friend's influence. They persuaded him that shabu will improve his attention and school performance. لذلك الحين غالبا يزيد ايام الاختبارات، يزيد السوالف هذه. He started to abuse before exam and extended to the most of the time. In the last 3 months, he experienced seeing things and people not present and having ideas that others want to kill him and refer badly about him that completely improved upon stop the drugs. He denied abusing other substances. On examination, he also start cannabis in social activity ما كان بشكل دائم with his friends for its euphoric effect, and last one was 3 days ago. He has no delusion, no hallucination, or other psychotic feature. He preoccupied with his school failure and his parent quarrel. Medical condition was within normal. Routine investigation was done for him. EEG was normal. Connor scale for ADHD suggests presence of moderate severity of ADHD. Child behavioral checklist to detect behavioral and emotional problems, conduct disorder. Addiction severity index من الاختبارات التي تعمل في الادكشن to address medical status, employment and support, drug use, etc. differential diagnosis. من هذا السيناريو ابغى اسمع منكم ما هي التشخيصات المتوقعه حسب ما سمعتوا؟ شاركونا حفظكم الله. وات؟ ما اسمع في مايك. differential diagnosis. مش diagnosis، differential. اعطونا. ايوه and why. هذا السؤال.
يعطيك العافيه. هو لاحظنا عنده ريسكي بيهيفير، الفاميلي انفلونس وهو صغير، والاي دي اتش دي ممكن يكون في مع التينيجر، يمكن حيدخل في الكوندكتيف والانتي انتي سوشيال بيرسوناليتي. هذول اصلا بعد عندهم هاي ريسك يعني بيهيفير. فكرت فيه في البدايه.
فايش ممكن يكون التشخيص؟ ايش ممكن يكون التشخيص؟ هذا تشخيص اوكي. انت
بيرسوناليتي انا قلت لك
بيرسوناليتي
اي اللي انتي سوشيال بيرسوناليتي، بالتالي جمعت كل الاشياء هذه يعني.
طيب اوكي. في هناك ممكن تحذف له المايك يا بدل ما تسمع. طيب
السلام عليكم.
السلام ورحمة الله.
مثل ما قالت الدكتورة ندى، هو بالبداية عنده ريسك فاكتور انه هو ممكن يكون انتي سوشيال بيرسوناليتي، وبعدين بالاخير هو صار سبستنس اديوس سايكوسيس برايي.
طيب اوكي. بعد في اجابه اخرى؟ طيب اوكي. هل ممكن دكتور احمد يكون انتي سوشيال بيرسوناليتي؟ طيب طبعا هو اوكي تمام. طبعا في عندنا اكثر من ديفرنشال. في شغله واضحه ADHD هذه وين راحت؟ زين. طبعا في عندنا اكثر من تشخيص، وعندنا من ضمن اكثر من ديفرنشال، اكثر من تشخيص عفوا. ADHD conduct disorder methamphetamine and cannabis use disorder. طبعا ما نقدر نقول انتي سوشيال. ليش؟ الايج العمر، ايوه، فهو conduct disorder في هذا العمر. فاحنا لاحظنا الان في عنده اكثر من شغله. عمل له اللي هو الكونر سكيل، فعنده ADHD، وعنده البيهيفيرال شيكلت، فعنده الكوندكت، وعنده تاريخ التعاطي. فعندنا ADHD conduct disorder methamphetamine and cannabis use disorder. could be ممكن اللي هي bipolar disorder methamphetamine cannabis use disorder. في عنده بعض التغيرات في المزاج. عنده substance induced psychosis، لانه مثلا لاحظته في الهستوري ذكر انه فترات كان يسمع اشياء، يشوف اشياء ما كانت موجوده، فهذه ممكن تكون في الاعتبار. لكن اللي لاحظوا اللي الموجوده معاه دائما ميثامفيتامين اللي هو الشابو and cannabis use disorder. فهذه يعني عده احتمالات او عده تشخيصات وارده في مثل هذه الحاله. طيب في مثل هذه الحاله ايش ممكن نسوي؟ ايش التدخلات؟ المانجمنت طبعا عندنا انتجريتد مانجمنت فور ADHD والكوندكت والادكشن. يعني هو ما راح نركز على شغله واحده، نحتاج احنا نركز على الشغلات الثلاثه كلها. عندنا الفارماكولوجيكال انترفنشن اللي هو اتوموكسيتين اللي هو ستراتيرا. طبعا هو يعني اختياره لسبب انه نو ابيوز بوتنشال. بعض الادويه الثانيه تستخدم في ADHD ممكن يكون فيها اشكاليه الادمان، وهذا المريض عنده مشكله ادمان، فنحن ربما نفضل الاتوموكسيتين في مثل هذه الحاله اللي هو ستراتيرا. في السايكوثيرابي في عندنا تدخلات كثيره ممكن نسويها: سايكو اديوكيشن، اكاديميك اورجانيزيشن سكيلز، البيرنت تريننج، بيهيفيرال موديفيكيشن اند كلاس روم اند هوم، كوجنيتيف CBT. كل هذه تدخلات ممكن او من الضروري ان تكون تؤخذ في الاعتبار اثناء العمليه العلاجيه. كذلك موضوع substance use disorder تحتاج ان احنا نتعامل معه بشكل جيد من خلال فيسز او عده مراحل. الديتوكسيفيكيشن بحيث لو جانا في مرحله تعاطي نحن والله نبدا في ديتوكسيفيكيشن فيز اول 2 to 3 ويكس حسب الماده، وبعدين ندخل معاه في المينتنس فيز من خلال عده برامج تاهيليه كريلابس بريفنشن بروجرام اور ماتريكس بروجرام، بالاضافه الى الفاميلي ثيرابي. فهو الان هذا اسمه holistic intervention، لان عندنا we have many problems with this patient, we have to deal with each problems بشكل جيد. عندنا وقت؟ اوكي ندخل على الكيس الثاني. خلكم جاهزين. differential diagnosis قبل شوي 2 شاركوا، الحين نبي 4 يشاركون. الحاله الثانيه 16 years old female adolescent patient presented with her mother as she was referred to for evaluation by her pediatrician based on her chronic gastrointestinal complaint without any organic illness. تشتكي مشاكل في المعده لكن ما في فحوصاتها كلها سليمه. She complained that she became more irritable and excessive worries about her health, her parent safety, her school performance, and her peer relationship. She was very distressed by news report about a catastrophic event locally and around the world, crimes tourism. At school, her teacher لاحظوا عليها about her يعني excessive worry about her school work and often become concerned about adult matter, finance, parent, job security. مشغولة بالعالم كله، أهلها والعالم والاقتصاد، فكانت قلقة جدا. She has multiple somatic complaints as stomach pain and problem in failing and falling asleep. She also became repetitively verbalizing. She worries even after reassurance was given. She was irritable and difficult to soothe as an infant. Developmental milestones were met with normal limits. She has family history, including depression. Her maternal grandmother and her mother was generalized anxiety disorder that's controlled by medication. The patient started to misuse her mother medication to control her symptoms. بدأت تاخذ أدوية والدتها. She abused alprazolam occasionally when anxiety is severe and decreased up to 3 to 4 tablets for its calming effect that lead to control her anxiety. مع القلق بدأت تاخذ أدوية والدتها اللي هو علاج alprazolam. 1 month ago, her mother noticed her daughter talking about medication and persuaded her to stop abuse. When she was stopped, she became irritable, easily provoked, disturbed sleep, and led to deterioration in her psychiatric condition. So she returned to abuse occasionally. She denied abusing any other substance. She denied any experience of fits or delirium upon stop the medication. On examination, she's irritable طبعا أثناء المقابلة, kept on the edge, preoccupied with her life, safety, herself, and others. She's hardly cooperative. Fine tremors were observed throughout the interview. She has no delusion, no hallucination, no obsession. She has fair abstraction, judgment, and insight. Vital sign within normal. No sign of suggest thyroid or examination within normal. Investigation, routine investigation within normal. EEG thyroid was within normal. Urine toxicology screening was positive for benzodiazepine. اللي هي الأربعة كانت تاخذها. Hamilton anxiety rating scale for adolescents showed moderate severity of anxiety. Also, addiction severity index was done for this patient. Differential. أسهل من كده ما فيش. إيش؟ Generalized anxiety disorder and
benzodiazepine abuse.
benzodiazepine abuse. طيب. آخر كلام.
withdrawal symptoms يعني secondary to abuse.
طيب اوكي هم الان في الاسيدتين الاخير ما في شيء اسمه ابيوز. في نقول الماده يوز ديس اوردر مثلا بنزودازيبين يوز ديس اوردر او مثلا البنزودازيبين انديوس سايكوسيس ففي اختلافات. فالابيوز والمسيوز الان انشالت ما تستخدم. ايضا تشخيص اخر بس كل هذا بوحه صوتي بس هذا هو. طيب الديفرنشال نبغى يعني لا دقيقه لحظه طالع بعد. طيب ما ماشي مثل ما قالت الدكتوره جوناتال انكزايتي ديس اوردر بنزودازيمين يوز ديس اوردر انلس انكزايتي ديس اوردر بنزودازيمين يوز ديس اوردر. ليش جبنا التشخيص هذا؟ بناء على ايش؟ بناء على ماذا اللي هو الانلس انكزايتي ديس اوردر؟ بناء على ماذا جبناه وحطيناه؟ ايش كان في الهيستوري؟ اول شريحه ايش كانت تقول؟ كان عندها سوماتيك سيمتوم وما كان في سبب واضح وكانت تروح وكانت بريكيوباي بين هير هيلث اند هير فاميلي فممكن نعتبره يكون داخل من ضمن ديفرنشال. also اللي هو ممكن عندنا بنزودازيبين يوز ديس اوردر سبستانس يوز انديوس انكزايتي ديس اوردر. هذا الجزء الثاني هذا منين طلعناه في الهيستوري اللي هو السبستانس انديوس انكزايتي ديس اوردر؟ من اي جزء من الهيستوري؟ ايش؟ انا اشوف كذا بس ماني عارف ايش من اي جزء من الهيستوري؟
The last part of the history. After she is taking the medication, she wants to stop. She was anxious.
لما توقف.
Yes.
لما كانت توقف البنزودازيبين فكانت
She
تطلع
had
معها
the withdrawal symptoms.
جميل withdrawal symptom. جميل. طبعا المانجمنت الفارماكولوجيكال انترفنشن اللي هو الاس اس ار اي. طبعا السيرترالين يعتبر فيرست لاين تو بي بريسكرايب فور adolescent, السي بي تي فور انكزايتي، المانجمنت للبنزوديازيبين او الدرج بشكل عام مثل ما قلنا قبل شوي، الديتوكسيفيكيشن فيز withdrawal gradual withdrawal benzodiazepine over 1 to 3 months. طبعا في نقطة مهمة جدا في البنزو بشكل عام او الكحول، حتى الwithdrawal symptom احيانا قد تكون very severe، ممكن تؤدي الى فيتس ولا ممكن، فغالبا اذا كان ياخذ هنا شيء شورت اكتنج نحاولوا الى علاج يكون من اللونج اكتنج، مثلا لونج هاف لايف عفوا مثل الفاليوم، ممكن نحوله للفاليوم لانه الشورت هاف لايف ممكن لو قطعت بسرعه ممكن قد يكون في صعوبه في ايقافها، وممكن نحول بعضهم الى اللونج هاف لايف مثل الفاليوم ونبدا جراديوال تيبرنج تل دي سي ذا ميديكيشن. طبعا بعد ذلك ننتقل للمينتنس فيس، ما قلنا موضوع السي بي تي ريلابس بريفنشن ادكشن، الماتريكس بروجرام اند فاميلي اديوكيشن فاميلي ثيرابي. Last slide. Substance use disorders common among adolescents and it should be screened. وهذه نقطة مهمة في خاصة بحكم العمل في المراكز الصحية في المراهقة، لا يكون فقط ممكن يجيني عنده صداع، عنده مشكلة في النوم، عفوا عنده زكام، عنده خلوا نضع جزء من أسئلتنا نسأل قلنا عن موضوع المواد أو الاستخدام. ممكن غالبا المدخل اللطيف اللي ممكن ندخل من خلاله يدخن، جرب شيء غير الدخان. ترى طريقة السؤال لها ممكن إما أنه تنفر بتخليه يخاف أو تخليه يبدأ يتجاوب معك، تعرف أحد يستخدم أو يتعاطى أو أحد من زملائك، فالمداخل مهمة جدا في التعامل مع مثل هذه الحالات. Substance abuse may be a sequence for another psychiatric and medical disorder. Comorbidity are the rule not the rare. Lack of parental supervision and parent quarrel or separation are among the common risk factor for developing substance use disorder, integrated management for addiction problem and psychiatric disorder. شكرا جزيلا لكم.
Thanks, Dr. Mohammed, for this nice interactive presentation. We would like to welcome Dr. Reem Al Abdul Qadir, Assistant Professor, College of Medicine, Imam Abdulrahman bin Faisal University, Consultant Pediatric Ophthalmology and Strabismus, King Fahd Hospital of the University, to talk about visual screening in pediatric. Welcome, Dr.
Assalamu alaikum, everybody. First of all, I would like to thank you all for inviting me to speak in this beautiful symposium. Our talk, inshallah, today will be short and sweet, and I need cooperation from the audience to give me just what they think. I know many of them would be like in-depth or detailed ophthalmological problems, but I think you can pick them out, and that's the idea of this lecture. So the objectives are what we're going to talk about, inshallah, today. The scope of this lecture is to identify the pediatric visual screening guidelines that should be done in Saudi Arabia and the role of the family physician in the pediatric visual screening. And finally, when should you refer a patient to me or other ophthalmologists? So what are the indications for the referral of patients? What is the difference, first of all, between a pediatric screening and a comprehensive eye exam? Obviously, from the name, a screening should be done by a pediatrician, a family physician, an optometrist, or even an ophthalmologist, and also can be done by trained technicians. You know, if they are in close contact with the patients and they know how to examine the eye, they can perform it. While a comprehensive eye exam should be performed by an ophthalmologist, if the child is very young, it is preferred to be seen by a pediatric ophthalmologists because children can be challenging, especially if they cry and they close their eyes, you will not be able to see anything. Visual screening is the right for every patient. I'd like to use the pointer here. So Visual screening is the right for every patient, every child at different stages of their life, as you can see in the last row. And the comprehensive eye exam should be referred for patients that are referred from the family physician or other caregivers for the child. How do you screen the patients? You do it as a clinic-based evaluation for all normal children at different stages of their lives. While the comprehensive eye exam is a lengthy clinic-based exam that requires dilating drops. Sometimes we cannot even see the details of the eye, so we need to examine them under anesthesia. So we'll do EUA or examination under sedation. And sometimes we even take them intraoperatively to do examination plus minus surgery. So what are the guidelines according to American Academy of Ophthalmology and the American Academy of Pediatric Ophthalmology and Strabismus? Well, they recommend the following program, and I really wish that you would convey this to your patients. All newborns should be examined, okay? Usually they are by the attending pediatrician or the OB-GYN. At 6 to 12 months, they should be seen. So I roughly tell my patients, you should bring your normal children at 6 months, because sometimes they take more time than that. And then at 1 to 3 years. So I tell them, if I see them at 6 months and they're fine, bring them to me again in 1 year or in 3 years. And then at the age of 3 to 5 years, and finally, just before they go to school, we can check them at 5 years or older. We're talking about the very young, where saving the child from many diseases is very important, and anything later than that would be crucial. So what should you do for a newborn baby? Well, there's something called Bruckner test, which is nothing more than a red reflex test, the blink response and the pupillary response. Here you can see Bruckner test, where the examiner is looking through the peephole of the direct ophthalmoscope. I'm sure all the clinics have them. And you will try to evaluate the quality and symmetry of the red reflex between the two eyes. For example, the first picture on the top is showing symmetrical, and all of these patients are dilated. So just to show you more how the quality would be. Normally, children will have smaller pupils, but these are dilated babies, so or children. The first picture will show symmetrical and equally bright red reflex, indicating normal child. The next one shows an upper red crescent or an upper bright crescent. This indicates hyperopia or farsightedness. The child will not be able to see the near, they will see the far better. And the middle picture is showing a lower crescent where the child has myopia. So the opposite of hyperopia is myopia or nearsightedness. The next picture shows a slightly brighter red reflex in the right eye compared to the left eye, indicating an anisometropia. Anisometropia means inequality between the refractive error of the right and the left eye. And this could be amblyogenic. It can cause amblyopia for these children. The last line shows the right eye, brighter red reflex than the left eye, indicating strabismus. So if you see one eye brighter than the other, it could be either strabismus or something wrong with the dark eye, like this picture. This child has, can anyone name the sign? What do we call this? From the name, leukocoria means white pupil. When you are shining a red light on the pupil, you should say here, either leukocoria or absent red reflex. So the more accurate term here is absent red reflex in the left eye, indicating visual axis obscuration. If I'm just looking at the child in a photograph or directly looking at the child and I see the pupil is white, then we call that leukocoria. So you can send the patient for me saying that this child has abnormal red reflex. Okay, if you see him without this direct ophthalmoscope, you will say leukocoria. This is nothing more than the blink reflex. Can I get some water, please? The blink reflex is a normal reflex for all pediatrics, and they do usually blink sometimes to sharp sounds and even a facial touch other than the glabellar reflex. We're talking about the normal reflex. And also if you shine very bright light to these babies, they will also blink normally because bright light is quite, the children are sensitive to bright light and they want to shy away from it. Excuse me. If this reflex was abnormal, you are requested to send the patient to the ophthalmologist. Another thing you would like to look at with this test is the size of the pupil symmetry as well in the light reflex test. Newborns will not have a well-developed pupillary response because the dilator pupillary and the sphincter pupillary muscles are not yet well developed. So you have to allow for the child to be a bit older to assess the the reflexivity or the reflex of the pupil. Okay, what do we do for children that are older? So 6 to 12 months, you expect these children to have done the above tests, and you will do them at 6 to 12 months. And then you will visually inspect the eye like you inspect every child that comes to you in the clinic, and you will check for the alignment with what is called a Hirschberg's test, which is nothing more than a light reflex test, as I will show you. And you will check for extraocular motility. We all know how to do that from the neuro rotations in medicine. So this is Hirschberg's test, where you would be looking at the centricity of the corneal light reflex. You see the arrows showing symmetrical location of the light reflex, the corneal light reflex. This is different from the red reflex test. And how to do this test? You'll just shine any torch, or preferably not something that is very bright, any like gentle torch on the eyes from below the child in the center. So it can be in the center. If you shine it from the side, it will shine temporally here and nasally here. So try to be as center as possible. In the normal children, it is normal to have them a little bit 1 millimeter nasal in both eyes. But if you see huge difference, then you will have to think of abnormality. So this is her Hirschberg test. And in this child, it is normal. This is the extraocular motility. Can anyone comment? I think it's very obvious what the problem is. Excellent. I see someone pointing like this. Excellent. What's the problem? All right. Is it in the up and down gaze? No, it's in the right gaze. Exactly. So exactly, our eye is not going all the way to the right. We go to the right. Exactly. Which eye? The right eye, exactly. So there's a limitation of abduction or out, looking to the right with the right eye. What else do you notice? Okay, the central picture here shows a normal symmetrical size of the palpebral fissure. When the child looked to the right, what widened? There's widening of the right eye as well, right? All right, and when the child looked to the left, what happened to that same eye? It's narrowed, so there is narrowing and retraction of that eye. So this indicates abnormality in the extraocular motility. This you can do very quickly. And children that are younger than 5 months can only follow horizontal, pursuit. However, older children, like 5 months and older, they should be able also to follow vertical. So don't expect a child that's 3 months to follow a target from up to down. It will only develop at 5 months. So you have to know the age-appropriate examination. Very good. So at 1 year, 2, 3 years, I prefer at, any time in between. I tell my patients, if the child is normal at 6 months, bring him to me at 3 years, unless you notice something. So this is, of course, we'll examine whatever we examined prior, plus we will check the healthy development of the eye. We'll see from the family, is he seeing well? Is he falling a lot? Is he picking up small objects from the ground as he crawled and as he walked? Is he very hesitant to cross a specific line in the floor, thinking that this might be steps? I have one child like this. Whenever there is a specific line on the ground, they stop and then they start to feel his ground to appreciate that it is leveled or depressed. So because he fell so much. And then you want to ask them, are they interested to look at your phone? Are they are they trying to lean and see what you are seeing on the phone or not? Because lack of interest of the child to mobile devices these age at this time, is abnormal. Usually children are very drawn into these colorful screens and noisy programs. So the examiner, if you are lucky, and in your clinic or in your healthcare facility, if you have this photo screening test device, you will be able to have a peace of mind, take a picture of the child, and then get a display of whether you should refer this child or not. For example, you will sit a few meters away from the child, and the child will not be distressed. You will take a quick picture. The child will be attracted to a toy or a face or like a moving object or noise in the machine. And then it will take a picture of the child, and it will display to you something similar to this depending on your device. So this is called, this is by Welsh Allen, by the way. It is SPOT. It's called SPOT, photo screening test, SPOT. And I personally have done a screening program for children. I went to 4 schools and I used it. It is very beautiful. It's a very beautiful machine. If you can have that in your clinic, it's good. So it will tell you a screening is complete. All measurements are normal. What does it detect? It detects alignment. So if there is squint, it will show you that the eye is off center, and it will tell you in red, there is squint, or there is myopia, or hyperopia, or anisometropia, or astigmatism. It will tell you there is no lead reflex in one eye. It can even, some devices can display that because the light has to come back to the machine and is captured, so they can detect also the clarity of the red reflex. If this machine tells you, yes, do refer it, you can print out a printable PDF paper that they can take to the ophthalmologist and see, why are you referred to me? Like, at 3 to 5 years, we're talking about children that start to talk now. We can actually, use their smarts to appreciate how much they can see. So we can take their visual acuity, and that's the utmost function of the vision, okay, of the eyes, is to have good visual acuity and stereopsis, of course, which is the appreciation of the depth of things. So you will also test for alignment as well, which we talked about before. So you can have any of the following or even different ways to measure the visual acuity quantitatively. Okay, you can really appreciate how much the child will see. Again, at 4, and then just memorize this with me, 4, 5, and 6 years of age, you expect the children to see 0.6, 0.8, and full vision. So don't bring a child that is 4 years old and expect them to see 6.6. They should see a line or 2 lines below. That's fine. That's the normal for their age. They can be younger and see full vision, and that's not supernatural. That can happen, but don't be harsh on them. The most important thing is to find out or appreciate the difference between the vision in both eyes. So if there is 2 line differences in the visual acuity between the right and the left, this is amblyopia. And this has to be referred as soon as you diagnose it to treat it before the child actually loses the window, which we can treat amblyopia, which is below 6 to 8 years. So what is your role as family physicians in the pediatric visual screening? We mentioned how you can conduct it in the clinic. And now I want you to not only think about that, also think about, other than the vision screening, inquire about the family. Do you have any pediatric eye diseases or any adult onset eye diseases? That means these children are at risk. For example, one of my patients, the grandpa and the grandma, they both had glaucoma. So we screened the 2nd generation, so their kids, so they were asymptomatic glaucoma. So we got the teenagers in these children, in this family, and they had increased cup to disc ratio. So if we didn't screen them before, we wouldn't keep an eye on them, although they noticed it at an older age. Educate and encourage the family about the screening protocols for vision, because as hearing and vision, require a lot of development or quick development in the younger years, you have to, as you encourage them for also for vaccination, you have to encourage them to visit the eye doctor. Detect and refer patients, as we will talk. When should you refer patients to an ocular exam? I'm sure we, covered a lot of the things, but we will just go over a bit more. Excuse me. So in the newborns, apart from the abnormal examination that you have seen, if a child has history of prematurity or is ex-premature, should be seen by an ophthalmologist. If there's any sign that you see in the clinic like ptosis or drooping of the eyelids, abnormal size or abnormal shape of the eyes. As we said, family history of the eye diseases. At 6 months, another, if you notice strabismus, if you see abnormality in the motility, 6 to 12 months, and if you see any development abnormality and abnormal photo screening test. This is just, running again. If at 3 to 5 years, if you see 2 line differences, which is called amblyopia, or strabismus, or any significant refractive error outside the normal for that age, then you would refer these patients. So now just quick slides, and I need you to give me quick answers. Based on our lecture and based on your knowledge about pediatrics, what is the management, or what do you see abnormal, and what is the management, all right? So this is the first case. First, do you know what this test is? Is it the corneal light reflex test, or is it the red reflex test? Corneal light, so it's Hirschberg, okay? Hirschberg is the corneal light reflex test. Bruckner is the red reflex test. I don't want you to think about these fancy names. Just do them in the clinic. See why you need to do this. So you're looking here for what? For the quality of the red reflex? For the alignment. Excellent. So is this patient aligned? Why do you think he came to your clinic? Yeah, the patient looks like he has or she has a right eye esotropia. Family will say, especially a دكتورة لما يشوفني على جنب. When they see me, when they see sideways, this eye almost half of the cornea will disappear. So these children have wide nasal. What is the cause of the pseudo-esotropia? Wide nasal bridge and epicanthal folds. Excellent. Excuse me, today I'm not feeling very well. So this child has a wide nasal bridge and epicanthal folds. However, the alignment is okay. So what's your management? Reassurance and follow up in 6 months. You have to follow up in 6 months because these children, more than the normal children, tend to show esotropia, even at older age. We don't know if this is actual association, which I don't think so, or it's actually over-diagnosing them. Because you screen them, you tend to screen them more, so you can pick them up more. So that's why the results are skewed towards more esotropia diagnosed in pseudo-esotropes. Or another reason could be that when they look to the side, this eye is not seeing very well, so they will try to converge. Maybe they will develop esotropia. What do you notice here? نفس الكلام, wide nasal bridge, صح? Epicanthal folds. Here it was, epicanthus, running from the top to the lower. It could be only lower, it could be only upper, it could be, from the top to the bottom. So this is superior one. So what should you do? Esotropia, not because of, not every wide nasal bridge and epicanthal folds is a pseudo-esotropes. They can have actual esotropia. So your guide is not the scleral show, rather the presence or the centration of the light reflex, corneal light reflex. Excellent. Which eye is squinting? The left eye. أحسنتم, بارك الله فيكم. طيب, can we check that this eye is always squinting, or can we see if there is alternation? You can check that. You will cover, for example, in this child, you'll cover this right eye, and you will see if the child will hold fixation with that eye. That means, alhamdulillah, there is no amblyopia. If he can hold with either eye alternatively, so that means there is alternating esotropia. That's common in infantile esotropes, and they will do very well post-surgery. You have to do surgery within the first 6 months of age. طيب, أنا بسألكم سؤال. لو جاني طفل عمره 2 months and the mother is noticing esotropia, would you do anything? No. When would you do anything? The child is 2 months. What's your management? 2 months. And the eyes are going in. You have to ask a question. أحسنتي, بارك الله فيك. Is it continuously in, or is it on and off? Is it, sometimes straight, sometimes in? Is it, intermittent or constant? أحسنتي. So if it is intermittent, this is the normal squinting in the normal age. Up to 3 months, we accept, we let it pass. If there is any intermittency of squint, beyond 3 months, there should be 0 squint. No intermittent. We're talking about normal children, not cerebral palsy, not microcephaly, not patients with other diseases. I'm talking about normal children should not have any squint beyond 3 months, and definitely no squint beyond 5 months. No intermittent, no constant. So if you see squint in children below 3 months, you should not be so much alarmed, but follow closely because they actually can have a problem. What's the abnormality here? Ptosis. Is it visually significant ptosis or visually insignificant? Visually significant, why? It's obscuring half the pupil. We measure in the ophthalmology, I know this is not your scope, but we measure something called marginal reflex distance, which is the distance between the margin of the eyelid and the light reflex. The marginal reflex distance, margin to reflex, okay? So in the right eye, it's normal and it's very wide. It's about 6 millimeters, 5 millimeters, because the cornea is about 11 millimeters, so it's about half. In the other one, it's about 1 millimeter. So this is visually significant. Sometimes it's minus. So let's go to the next one. What do you think? This, let's say 2-year-old child came to you in the clinic. The mother noticed the right eye going out. With the tilt X, and there's abnormal head position to the left side. So you will refer this child, right? But you will reassure her regarding the outward deviation or the right eye out, because it is not. This child has a pseudo exotropia because the scleral show in the right eye nasally is more than temporally. That's why it indicates to you that he may have an outward deviation, but this child is straight. Look at the corneal light reflex. It's in the center of both pupils. Here, quick spot diagnosis. Which eye is normal? All right, عشان ما أظلمكم, it could be the right, could be the left. Okay, depending on the focus of this and how close you are to this patient, but it is right eye microphthalmia. All right, it could be left eye ophthalmos. So if it was right eye microphthalmia, refer to the pediatrics ophthalmology or the ophthalmologist. If it is left eye enlarged globe, we call that ophthalmos. You have to also refer the patient because this can be what causes the eye to grow. Tumors, pressure, glaucoma. Okay, glaucoma is very, very important. What do you notice in this child? Corneal opacity in the right eye that is visually significant. I cannot see the details of the iris. I cannot see that or appreciate the red reflex test. So what else do you notice on the eyelids? Tearing, we call that epiphora. If there is any epiphora, photophobia, don't think it's nasolacrimal duct obstruction. You have to rule out glaucoma because glaucoma and the nasolacrimal duct obstruction in this age will not show in the cornea. It can be only epiphora. It can be only photophobia. The child is always closing the eye when you shine the light. So this is right eye obscuration of the corneal clarity, and that is glaucoma in the right eye. This one, is it leukocoria or absent red reflex? What is it? في red reflex أصلاً أنتوا شايفين red? So it is leukocoria, white pupil on the right eye. By the way, this child probably has an RD that's close to the lens or probably retinoblastoma. This child, hemangioma. It could be capillary or cavernous. We'll decide based on histopathology. And this is visually significant, obscuring the visual axis. So this is almost the final slide. The American Academy recommends parents, I want you to convey this message also to your patients, that you should, as a parent, seek an ophthalmologist if your child fails a vision screening exam. The vision screening was inconclusive, or it cannot be done because the child is not cooperative. Refer by a pediatrician or a nurse. Okay, these patients should be seen in the clinic. Has a vision problem, has a problem or behavior that is abnormal regarding his vision, or is at risk of developing any eye problems like Down syndrome, prematurity, juvenile rheumatoid arthritis, idiopathic arthritis, neurofibromatosis, etc., or any family history of what we mentioned before, has any learning disability, because dyslexia can be treated and the child can learn normally. Finally, this is the one if you want to take a picture of, the summary of when and what to do according to age. Thank you very much.
Thank you, Dr. Reem, for your nice presentation. Now we'll come to the last presentation for today about managing food allergy in pediatrics, presented by Dr. Hassan Al-Hashim. He is a consultant pediatric allergist and clinical immunologist, Dammam in Maternity and Children Hospital, fellowship in pediatric allergy and clinical immunology from King Faisal Specialist Hospital, Riyadh. Welcome, Doctor.
الملف الثاني second file not this file. الملف الجديد هو الملف الثاني مش هذا الملف الثاني. السلام عليكم، مساء الخير جميعا. I wish you are still awake and not hungry. This is the last lecture on this day. I hope I can convey an important message about food allergy. I am Dr. Hassan, working in Maternity Children Hospital. I run about 3 clinics per day and about 20% of my clinic in food allergy. So it will be like focused presentation about clinical food allergy. I hope you can practice it in your primary healthcare center. So I have 2 long cases and 2 short cases. I wish you participate with me in short cases. I will talk about adverse reaction to food and how to classify the food allergies, what is the prevalence in food allergy and the clinical manifestation, both IgE, non-IgE, and other adverse drug reactions or food reaction, and how to diagnose a diagnostic approach and the importance of history in taking in food allergy. What labs we can do to diagnose food allergy and how we rely on the labs based on the history and at the end management and prevention. So this history is a girl, 16 years old, with the known allergy to peanut. She was having a dinner at Chinese restaurant with friends when she began to have trouble breathing, progressive to wheezes. Within a few minutes, she also showed signs of confusion and slurred speech. Confusion may reflect hypotension. The girl was immediately taken to nearest hospital. She is known to have a bronchial asthma. She is not on medication, and she has previous attack of similar presentation requiring ER visit. Upon arrival, she was noticed to have diffuse urticaria and patient arm, legs, face, particularly around the eye and the mouth. The patient also appeared to have angioedema in the throat and the tongue. The examination revealed a pulse rate of 140, which is tachycardic. The girl's friend told the family emergency response that she is having peanut allergy. And during transport, she was placed on ATT tube because of hypoxia. And after that, she was given epinephrine 0.3 milligram, to which she has responded very well. So this is the angioedema in the lips and the throat, angioedema on the tongue, and the urticaria on the arm. So our differential diagnosis could be either IgE-mediated food allergy with anaphylaxis. Do you support this diagnosis? Could it be food poisoning? We'll see why. Could it be food intolerance? Also, we'll see why it's not food intolerance. Could it be food-dependent exercise-induced anaphylaxis? So we'll go through topic review and we'll see the final diagnosis. Our immune system is a complex network of cells and organs. Their main response to protect us against infection and cancer. So allergy is part of excessive immune response to non-harmful protein. Allergy is always against protein, not other molecules. These reactions is reported, this adverse reaction reported up to 25%. But the adverse reaction is the broad term that contributes to any ingestion of food. Food allergy is part of this adverse reaction. So how we divide these reactions based on underlying pathophysiological changes. This is the adverse reaction to the food. It could be toxic, like bacterial toxin, Staph aureus, salmonella, aflatoxin, which is a fungi that cause hepatic toxicity and hepatic cancer, scumbroid food poisoning, which is usually histamine-like component, and the fish, which is not well cooked or not well stored. So this is toxic reaction. Is it adverse reaction? Yes, it is adverse reaction, but this is not allergic reaction. In non-immune mediated arm, we have food intolerance. which is a basic example of food intolerance, is lactose and fructose malabsorption, or lactase and fructase deficiency, which the patient usually have flatulence and abdominal distension, nausea, 30 to 2 hours after ingestion of these sugars. And immune mediated, which is will focus on our part, we have the IgE mediated food allergy, usually present with urticaria, angioedema, bronchospasm, rhinitis, laryngospasm, and anaphylaxis. And non-IgE, which is more insidious and more slow progressive immunological mediated food allergy. The main presentation is food protein induced enterocolitis. We have a case about this manifestation of non-IgE, food protein induced proctocolitis, and food protein induced enteropathy. And we have the mix, both IgE and non-IgE food allergy. The classical example about mix is cow milk protein allergy. This is the most common food allergy in infants. Eosinophilic esophagitis and eosinophilic gastroenteritis is other entity of mixed IgE and non-IgE. So the IgE mediated is very rapid in onset, usually within seconds even from ingestion. They usually begins up to 2 hours. After 2 hours, it's unlikely to be IgE mediated. So this will help us in diagnosis of the IgE mediated food allergy. The sign of symptom involve skin, urticaria as in the picture, respiratory, wheezes, stridor, GIT, including vomiting, abdominal cramp, diarrhea, and cardiovascular, mainly hypotension. It's caused by mediator that's released from tissue, mast cell, and circulating basophil. This video will tell you how the IgE-mediated mechanism works. I hope the sound is well working.
Some people develop an allergic reaction or hypersensitivity when exposed to substances such as dust, pollens, animal dander, or penicillin. This hypersensitivity is mediated by IgE. Sensitization up, processed by antigen-presenting C to T helper cells. Tissues under the mucous membranes are rich in B cells committed to IgE production, and IgE-producing cells are more abundant in persons susceptible to allergies. The T helper cells produce cytokines which stimulate these B cells to proliferate and differentiate into IgE-producing plasma cells. As IgE is produced in specific areas of the body, the IgE molecules attach via their constant regions to receptors on nearby mast cells. Mast cells contain granules packed with chemicals that induce a hypersensitivity response. Once attached, the IgE molecules can survive for many weeks. The individual is now sensitized to the antigen. When exposed to the antigen for a second time, the antigen binds to the IgE antibodies on the mast cells. To trigger a response, two cell-bound IgE molecules must react with a specific antigen. Within seconds of the reaction, the mast cell releases histamine and other mediators of the inflammatory response from the granules, triggering a variety of symptoms.
So the common 5 food allergens in pediatric is milk, peanut, egg, fish, soya, and wheat. The other is like shellfish, tree nut, usually comes in adult, but any child could present with any food allergies, especially those with that's not early introduced during early infancy. So how to evaluate? History is the most important part in the evaluation of food allergy. We'll take food ingested in detail. What exactly he ingested? What's the amount of food ingested? Sequentially report. What time he ingested? What symptoms start within how many minutes or hours? If 2 hours pass, usually it's against IgE-mediated allergy. So timing is important, and food quantity. Usually IgE-mediated needs small amount to introduce the symptom. Not like let's say about food intolerance, needs larger quantities of food or milk to have a symptom. If we have emergency department visit, we check the vital sign, how was treated, in case of anaphylaxis. There is what's called the reproducibility. This means that every time he ingests the food, he should have symptom. Usually, if you ask this question, it will roll out many suspected food allergies. the mother will tell you that sometime he ingested will have symptoms, sometime not. This is again is IgE mediated. IgE will have symptom with every ingestion, and usually small amount is enough. If she told you that if he ingests like half of mango, he will be fine. 1 mango, he will have symptom. This is again is IgE mediated. So this is basic history. Can either roll in or roll out food allergies. What is the provocating symptoms? Like if he exercise and they have symptom, usually in adolescent, this is what's called food-dependent exercise-induced anaphylaxis. I have 2 nurses with this diagnosis, and we should have about pre-existing atopy, especially dermatitis. Atopic dermatitis is a common comorbidity in food allergy, other asthma and family history. So how to investigate? We have either in the clinic, we can do skin prick testing, which is cost-effective and immediate result. We get it. It's measuring the wheels, any wheels about 3 millimeters above the negative control, considered positive. However, it's not for screening. It is sensitive, but not specific testing. So we don't do it for screening. The positive predictive value is low and the negative predictive value is high. This means that if we have negative, it's unlikely to have food allergy, but still we have about 5% risk that he have negative test and he have allergy. So we don't just jump about diagnosis unless we have clear history. So the larger the diameter, the more risk of anaphylaxis. This is how we do the test. Okay, this is how we put the reagent with the skin, then we break the skin by special needle, and we measure it after 15 minutes. We should have like positive control to make sure that he's reacting to histamine, negative control, which is usually normal saline, and the reagent we are looking for. We just look for the reagent that we are looking for. We don't screen. We don't screen if he has like suspected cow milk allergy. We don't screen for wheat. If he's tolerated, we don't screen for it. If we don't have the reagent, especially in fruits, we do what's called the break-to-break test. We break the fruits and we break the skin, then we read it after 15 minutes. So this is cost-effective. We can do it in the clinic, and it is considerably cheaper than the in vitro testing. The in vitro testing, usually do it in the lab. We have it in our regional lab. This is what's called RAS test, or specific IgE testing. It detects serum IgE by exposing serum to allergens bound to solid matrix and using secondary labeled anti-IgE to detect these IgEs in the patient serum. When we need it, if we don't have skin prick test, of course, we do the RAS test. Or the patient would have extensive dermographism. This means that he will have reaction even with negative control in skin prick testing. And the patient with extensive atopic dermatitis, we cannot do the skin prick test. We go through the in vitro testing. And the patient cannot stop antihistamine. He is dependent on antihistamine or cortisone. So the skin test will be not reliable. We go to the RAS testing. Life-threatening reaction to the food or air allergens. That's, you are afraid about if you introduce the skin testing that patient might react even with that small amount and we have anaphylaxis. So we'll go to the RAS test or in vitro testing. So without history, these all tests have no value. If the history is suggestive, we go to our testing. If not, this test have no values. How to interpret these testing? Positive tests indicate the presence of IgE, which is called sensitization. If you remember the video, presence of IgE is sensitization. Clinical reactivity is allergy. So it can detect the IgE, but not necessarily the patient is allergic to these or symptomatic. The negative test essentially rule IgE mediated allergy, but if patient have history clearly with anaphylaxis to food and the test is positive, this is diagnostic. However, the gold standard is oral challenge test. We do it in case of unclear history or the test was not supporting us. The diagnosis of food allergy cannot be performed in the basis of non-compatible medical history. I want to take this message home, please. Don't screen, don't do the labs without clear history and no diagnostic analysis, skin test, patch test, or specific IgE of a value of interpreted without reference to medical history. So what is our differential now? I think it's clearly IgE mediated food allergy with anaphylaxis. Why not food poisoning? the symptom is clearly going with IgE, and the other members is not affected. If it was food poisoning, the other members would be affected. Really? Food intolerance is unlikely, and food-dependent exercise-induced anaphylaxis is unlikely because the history is not suggestive. How to manage? It is avoidance. And this is the diagnostic criteria of EpiPen is important in these cases. In case of anaphylaxis, it is available in Ministry of Health. If you don't have it, send the patient to me. It is life-saving, the EpiPen. If you have infant with anaphylaxis, send it to me immediately. Call me and send it to me. I provide EpiPen. If you can follow. If you cannot, send it to me as a referral, please. EpiPen should not be delayed immediately, even if you don't have the test. If he came with anaphylaxis, give him the EpiPen. So this is which is good guidelines to go through. It is a bit long, but it is easy to read. So what we have now, we listened about classification for adverse reaction, sign of symptom for IgE mediated, importance of history, and how to manage IgE anaphylaxis, and importance of EpiPen prescription from first visit. Second case, 4-month-old, presented to ER with history of chronic loose stool with mucus and streak of blood for many weeks. The family reported history of itching, redness in the skin since the age of 1 month. They sought medical advice in clinic, and he was advised to change formula from regular to soya-based formula with no improvement. They have strong family history of atopies, no chronic respiratory symptom. Physical examination, well-looking, undernourished, and irritable infant. Vital sign was stable. His weight was far below centile, and his height is within normal. He has red oozing skin rash affecting the cheeks, forehead, and the trunk. Chest was clear, abdomen was normal. This is the picture of the child. What's the diagnosis here? Atopic dermatitis. This is the investigation was done. The WBC 7000 lymphocyte is normal, which is reassuring because one of the differential is immune deficiency. Neutrophil was within normal, and lymphocyte was sky high. His hemoglobin was low with microcytic hypochromic anemia, platelet higher, which might indicate iron deficiency anemia with these streaks of blood. His albumin was in the lower side also. So what's our differential? Could be non-IgE cow milk protein allergy. Could be atopic dermatitis with lactose intolerance. It is not. So lactose is not the manifestation with the blood. It doesn't come with weight loss, and usually not the age of presentation. Lactose intolerance usually comes with more older child. Is it IgE mediated? Any urticaria, wheezes? There's no. So it's not IgE mediated. Could be primary deficiency. We'll see. So basic knowledge: the cow milk protein allergy is up to 2.5% of infant, and this is the most common food allergen in pediatric population. The prevalence in the breastfeeding is much lower, which indicate the primary prevention of the breastfeeding and the importance of breastfeeding in the infants. And the IgE mediated, it's both mixed IgE and non-IgE. The IgE represents 60% of cow milk protein allergy. The other 40% is non-IgE. It's third most common cause of anaphylaxis. Peanut is the first common cause of anaphylaxis. So this is the third most common cause, and it's clearly overdiagnosed. I see many patients that's labeled as cow milk protein allergy that they came not to be. Not any atopic dermatitis is cow milk protein allergy. So it's overdiagnosed, and usually patients stay in special formula for years, then come back to me. It seems to be not cow milk protein allergy. So we'll skip this slide in sake of time. What could be the manifestation of non-IgE cow milk allergy? Eosinophilic esophagitis is very important. It's a rare disease, about 1 in quarter million. Usually it presents with postprandial vomiting, abdominal distension, failure to thrive, and the most important is food impaction with solid food. So if you have a patient with high eosinophil in the CBC, food impacted in the esophagus, which is going for long years, think about eosinophilic esophagitis. Some of them, they have IgE mediated reaction. The other non-IgE mediated cow milk allergy is food protein induced enteropathy. Enteropathy, this means that small intestine is affected. They have diarrhea, failure to thrive, abdominal distension, and malabsorption, least frequent anemia and hypoproteinemia. Food protein induced enterocolitis, which is both small and large intestines affected. They have vomiting, diarrhea, blood, and mucus in the stool. Food protein-induced proctocolitis, you can see it in the primary care center. They have just stool with the blood, no diarrhea. Skin might be normal. So this might indicate cow milk, non-IgE cow milk protein allergy. So to sum up, for non-IgE mediated, it could be eosinophilic gastroenteropathy, food protein-induced proctocolitis, or could have eczema with reflux and constipation. So this is a very important slide, how to approach such patient. First, we take the history. Is the history going with IgE or non-IgE? If it's going with IgE, we do eliminate the cow milk from the food. We do the test. If the test is positive, this is diagnostic. We eliminate the food. So we have clear history of IgE. Test is positive. That's it. If the test was negative, then we do challenge test, which is the gold standard. If the challenge came to be negative, so the food is not allergic. He's not allergic to that food. If the standardized oral challenge test is positive, this is diagnostic for food allergy. So again, oral challenge test is very important in diagnosis, but more difficult for non-IgE. If the history is going with non-IgE, like blood in the stool, eczema, colic, regurgitation, we do that, what's called diagnostic elimination diet. We eliminate the cow milk from the patient diet or from the mother diet if she's breastfeeding. And we see the improvement. If they improve, we do challenge test. If it is positive, this is diagnostic. If they improve, if they did not improve with elimination of the cow milk, this will rule out non-IgE cow milk allergy. This is a very important slide to consider. In non-IgE, we don't do test. It has no value at all. So a patient with diarrhea, blood in the stool, we don't do that specific IgE. It has no value. American Academy of Pediatrics also recommend that in case of reflux that is not responding, especially those not responding to protein pump inhibitor, consider cow milk allergy and start him on excessive hydrolyzed formula and see the response. It might be a manifestation of non-IgE cow milk protein allergy. So in that patient, our final diagnosis is non-IgE cow milk protein allergy, which is food protein-induced enterocolitis because have diarrhea plus blood in the stool and anemia. Why not primary immunodeficiency? We should consider primary immunodeficiency in these cases. He's underweight, he's high eosinophil, skin rash, but the family was negative for immunodeficiency, which is the most indicative factor. Again, treatment, avoidance. If he is on breastfeed, breast milk, and the mother wants to continue breastfeeding, we should instruct the mother to eliminate the dairy product from her diet. And we should give her calcium supplement. Always make cessation of breastfeeding the last solution. Try to continue breastfeeding because it is protective. So she's breastfeeding, eliminate the dairy product from her diet and give her supplement. Soya is not recommended, so in that case, it's not recommended. It was in previous guidelines. Partial hydrolyzed formula, HA formula, is not for therapeutic. It is for prevention. Other mammalian species, like especially we have goat milk here, many companies advertising it for cow milk allergy. It is not recommended for cow milk allergy. They have cross-reactivity. Excessive hydrolyzed formula, they usually have good response. Up to 90% of these patients, they respond to excessive hydrolyzed formula. We have here, I think, Alernova or others brands. I think limited brands we have for excessive hydrolyzed formula. Amino acid formula, 10% will need amino acid formula, but try to keep it at the end, unless we have specific symptom like anaphylaxis. If you have anaphylaxis, go immediately to amino acid formula. If not anaphylaxis, IgE, non-anaphylaxis, try extensive hydrolyzed formula. If you have rectal bleeding with hemodynamic instability, amino acid formula should be chosen. Growth failure, like in our patient, amino acid formula. If the patient has symptom in the breastfeeding, we should go to amino acid formula. And if he's in excessive hydrolyzed formula, still have symptom, this is amino acid formula. So history, examination, elimination, we done. Just few short slides. Okay, patient, 3 months of age. His length and weight with a normal, spitting up and irritability. with colic, and breastfeed for 1 month, then shifted to cow milk formula. She was started on protein pump inhibitor, poor response. What could be the diagnosis in such patient? Cow milk, IgE or non-IgE? Non-IgE. What is the treatment? If she's breastfeeding, we exclude the cow milk product from the mother diet. If she's in formula, excessive hydrolysis formula. Any test we can do? Blood test? No, we don't do specific IgE because it's non-IgE mediated. The other last case, 9 years old, his length and weight is normal. His weight, length, height and weight is normal. He has bloating, gas, abdominal cramp, distension, nausea, symptom after dairy product ingestion. The more he ingests, the more he has symptom. And he is on sharing family diet, including dairy product. Others negative. He has bowel motion and stool for reducing substance positive. What could be the diagnosis? Lactose intolerance. What is the formula to choose? Lactose-free formula. Yeah, that's it. Or you avoid all dairy product. Thank you very much. Sorry, I am taking more time.
Thank you, Dr. Hassan, for your nice presentation. Now the floor is for discussion. Welcome, Dr. Hassan, Dr. Ahmed, Dr. Reem. Yes. Okay. Now we'll take the questions from here, the audience. Anyone or have any question for Dr. Ahmed or Dr. Hassan, Dr. Reem? Dr. Ammar.
They grow when they grow.
But there are some food allergies that they don't have. The IgE-mediated cow milk allergy, we thought that previously outgrow within 3-4 years. The recent study showed that usually they outgrow median age of 10 years, the IgE-mediated. And non-IgE has more better outcome. They usually outgrow within 3 years, up to 4 years. 90% they outgrow it within 3 to 4 years. However, other food like peanuts, tree nuts, they take longer. There are some predictive, like if the patient have other atopies like asthma, atopic dermatitis, or you have multiple food allergies, or the IgE was very high in the blood. This usually indicates the outgrow will be more slow and usually take longer. If the other is negative, like family history is negative, he has no atopies, the IgE just class 1 or class 2, usually they do well and they outgrow earlier. Okay, that's very important question. How we do it depends on the symptom, severity of the symptom. If it is IgE mediated and the symptom is anaphylaxis, we repeat the test every 18 months. If the test came to be negative, which is specific IgE, we do challenge in the hospital. We don't do the challenge in the home because he's at risk 5% to have anaphylaxis. If the symptom is non-anaphylaxis and the test was negative after many years, we can't challenge him in the clinic or in the home even. For non-IgE, we don't have the test. So every 1 year, if the symptom was not compromising his life, he can't challenge himself in the home. So every year we challenge him to see the response for cow milk allergy outgrown for non-IgE mediated.
Any other question?
I do have a comment, if you don't mind, although I mean, I'm not asked, but after my lecture, somebody يعني pointed out something very important that I would like to share with the group, which is that he was telling me, my child also runs in the house all the time, and now I'm worried about it. So, but you were saying that could it be autism or not? So I just want to make something clear. We don't look at one symptom. We look at the collective symptoms. So if you remember category A and B, we look at the social interaction and then repetitive movements or play and stuff. So not everybody who's flapping has autism. And not everybody who has a social, like an anxiety or social avoidance has autism. Not everybody who has a language delay has autism, but it's collective information. I just wanted to make that clear. Maybe I did not have the right time for it during my lecture to say that.
Okay, thank you, Dr. Also, we have a question from online for you, Dr. Amal. Is there any medication that can help with the sleeping disorder?
If you're talking about sleep disorder associated with developmental disorders, yes, okay. So usually we start with sleep hygiene before we jump into medication, really. So there is like, where does the child sleep? What time do they sleep? Do they have a routine of sleeping or not? Decrease the sensory input while sleeping, and what about the diet and so on. And then we say, okay, if that's all done and the routine is very good and still the child has a problem, we usually start with melatonin. Melatonin has, as far as we know, the least side effect, and it has, and also there's a lot of good study, the developmental disorder kids have melatonin release abnormality. So it's good to add melatonin. If that doesn't help with follow-up, we could always add some clonidine and other medication that we could help with the sleep, yes.
Also, another question, is ADHD under the umbrella of autism, or it is a totally different diagnosis?
ADHD is a different disorder. So it's a disorder entity on its own. It has its own category of diagnosis, and we have to have certain criteria to reach a diagnosis. But we do have a lot of overlapping with autism, and that's make it very confusing. You know, sometimes the impulsivity and not being attuned to the social cues, they look like autistic, especially when they have a speech delay, but they are an entity on their own, separate from autism.
Dr. Ammar.
If we have a child, usually we do visual acuity screening before the child enter to the school or kindergarten. If we see refractive error in the child, his vision is not going up to his age. Does this child need to be seen by ophthalmologist, or we advise them to do proper visual acuity assessment by optometry, and then he can wear eyeglasses?
Thank you very much for this question. Actually, many patients are not seen except 2 times, at birth and at 6 years, or in their first year of school. So this is a huge gap where many things can come and occur to these children, and nobody will diagnose it, nobody will treat it, and the window for treatment is gone. One of them is amblyopia. So if there is a refractive error, all right, you know the normal refractive error for that age is that should not be significant. It should not be more than +1 or more than -1. It should be as normal as immetrope. We call that immetrope, means no refractive error. If the patient has significant refractive error, then you have to refer to the doctor first to indicate that this child has amblyopia or not. Because sometimes if you just refer them to the optometrist and they will check the glasses power and they will prescribe it, the patient will go home, he will wear or she will wear the glasses to correct the refractive error, but no treatment for amblyopia was done. Amblyopia rehabilitation takes time. We have to detect the improvement of vision. If there is asymmetry in the, which is anisometropy between the 2 eyes, you have to patch one eye, increase the visual stimulation to the other eye. So we'll tell the family, put the patch under the glasses, put the glasses on, and then give him an iPad to hasten or fasten the recovery of the vision in the amblyoptic eye. If it does not recover, there are other ways which we can do. The children sometimes are not cooperative for patches. That's our, agenda. And for you, yes, I recommend if you see a refractive error that is significant, or you can, this is, I think, by an autorefractor, there's a machine the child will sit and it will give you just what the child has. Another thing I failed to mention in the lecture, the patient has headache. When he's reading, they have headache or blurring of vision, then they have to be screened by a doctor, because more often than not, the optometrist will give a false glasses if they did not do a dilated fundus exam. We do a dilated fundus exam to identify also a dilated cyclorefraction to identify the true rather than the false refractive errors. So he could have -1, the refraction, the optometrist will give him the -1, but actually he was +2, and the child is actually pseudomyope. So he was hyperope by 2. The child cannot see the near very well. Without the glasses, the child will be trying to focus by accommodation, and then they overshot the 0. They corrected the 2, but they went to the -1. So you give them a -1 glasses, you further deepen him in his blur, and you make him even more strained, straining more further to see. So this can cause them headaches and even can cause amblyopia. So yes, we should be at least once, if we see that everything is fine, it's only refractive error, no amblyopia, okay, go ahead, especially at 6 years. Thank you.
Thank you, Dr. Reem. A question for Dr. Hassan. Does early introduction of food provoke or rather decrease further allergic reaction?
That's very important. Actually, I have a slide about it, but the time was not allowing me. Yes, the recent advices is to early introduce foods. In 2000 guidelines for American Academy, there was advice to delay introduction of like egg, fish, and other allergenic food, which is shown to be increasing the prevalence of allergy. The new advices is to introduce foods early, up to 4 months of age, and to continue breastfeeding as much as possible. No food to be delayed like before, after 1 year or after 2 years. All food should be introduced one by one at early age, and in case high risk infant, like family history of atopies or his atopic dermatitis, and formula want to be add on, which was hypoallergenic formula, partially hydrolyzed. This is the guidelines from European and American Academy of Pediatrics.
Doctor, I have a question actually. Thank you very much for raising this point. My eldest son had eczema. He's now 12, and he had a lot of, food allergy associated symptoms. So he would get redness, he would get, rashes on his face, nothing serious, alhamdulillah. So we took him to the pediatrician. They did for him, through the history. They told me that he's allergic after the skin test to most food types. And they did also the blood test, so I believe it was IgG as well. And they told me that it's sometimes 13-fold the normal, for example, for nuts and certain foods. But for milk and, it's double the normal level of IgG. So they told me, okay, we cannot deprive the child from everything. The only thing he was not allergic to was dust. That's the irony. So
is it IgG or IgA? Sorry,
I'm not really sure.
If it is IgE and the history is going with exacerbated eczema, the test should not be done because this is non-IgE. Eczema is non-IgE mediated. So again, what I do usually in this patient, they have conflict about, they did labs in the private and they came with a lot of food allergies. What I do, I control the atopic dermatitis very well. I go strictly back to the skin to the normal, then I introduce one food at a time. If it is IgE, usually they have symptom within 1 up to 2 hours maximum. If they have no symptom, that's it. It's rule out the food allergy. The history is not suggestive. So again, this again emphasize the importance of history taking. His eczema, and he might have flare up already. Introduce the food. Then we thought that this food might be a reason for it his eczema, but he's already eczema. He has a flare up already at that time. So what I advise is control eczema very well. Introduce one food at a time. Forget about the test.
That's my question, actually. When should you start? You said introduce it as early as possible. For him, they recommended that I never give him anything before 8 months.
If he's symptomatic, yes.
Yes, he was symptomatic.
If he's symptomatic clearly as IgE, yes, we avoid it.
I don't know.
We avoid it. But if the eczema is overlapping about the symptom, that is it urticaria, is it atopic dermatitis flare up? No, we should not go with test. We should clarify the history. Then based on the history, we go to the test. So what I advise is control the eczema, then check the history
How
again.
do you
Introduce
control the
food.
eczema? I mean, local
Yeah, local
steroids and
steroid,
exactly.
emollients, with
Exactly.
rubbing.
Yes.
Yeah,
Because now he's eating everything, thankfully.
that's it.
He's eating everything. The only thing is that this eczema is not disappearing.
Because it is eczema. It is chronic
eczema.
disease.
Mm.
It's barrier.
It's rather
dysfunction.
than a
Yeah.
food allergy.
It is not food allergy. Yeah.
I see. I see. Thank you very much.
Okay, thank you. Last question.
يعطيكم العافية دكتور ريم. When the patient with the strabismus, when اللي نعتبرها كريد فلاجز الموضوع ما هو just a local issue.
All right.
إذا سؤالي واضح.
Thank you very much. That's an excellent question. So if a child presents to the clinic with acute onset squint in an age where you don't expect squint, that is anything beyond the age of 5 months. We talked about no squint beyond 3 months. You can accept intermittency, but after 5 months, there should not be any squint because the visual system has matured. The nerves, all of the nerves have been myelinated from the optic nerve. Actually, it takes many years to fully myelinate, but generally the visual function is excellent at that time. And the child should not have any squint. If there is acute onset, it means within 1 week or 2 weeks. And I have one patient. I saw the patient at age of maybe 2 or 3. I did for him cyclorefraction. I did everything, examined from A to Z. And then I gave them the glasses that they needed. They went back, they went home. They came to me 3 months later for a follow-up. And the child had third nerve palsy, partial third nerve. I checked the notes. I wrote myself, the extraocular motility was full. And now I see that he cannot abduct, almost -1. I sent him for an MRI. So any acute onset, it was 1 month prior to presenting to my clinic the second time. So MRI revealed brain mass in the apex of the orbit compressing on the nerve. So any acute onset squint. Another thing is if there is any other associated finding like leukocoria, sometimes retinoblastoma will present with squint initially. All right. If the family report that in the pictures, for example, صورة لمعة العين في اليمين غير اليسار. هذه حمراء هذه ما تعطي أحمر. This is a red flag. Another thing, any squint beyond the age of 5 months. We said that already.
Thank you, Doctor. Dr. Amal, the chat is done by doctor or self-answered by parents, the questionnaire?
So the MChat is a 20 question for the parents. They're the one who's answering. Sometimes we prefer that somebody sit with them to make sure that they understand the questions. What's nice about the MChat are that it has examples also of the question itself. And it's so easy to score. If you think it does not fit the child, please clarify the questions again with the parents.
Thank you very much.
Dr. Anada, I'm sorry, another thing you have to add is headache. If the child has squint and headache, you have to image these children. If they have squint and nystagmus, so you will look for other signs. A lot of the times, if you see everything is normal in this child, this could be an acquired, especially the intermittent exotropia that comes and goes, and you look at the father, he's exotropic, or the mother. So this is not alarming, even if it comes as acute. Maybe the family did not notice it before. It was an exophoria, which is a latent strabismus, became an exotropia. But if they have headache, or if they are always closing one eye, so this should be referred as soon as possible. Thank you.
Thank you all. Inshallah, we'll see you tomorrow. Good to have a nice day. Thank you.